A very good morning, ladies and gentlemen. On behalf of the Society of Renal Nutrition and Metabolism India and the Department of Nephrology, SGPGI Lucknow, it is my privilege and pleasure to welcome the patron of the Society of Renal Nutrition and Metabolism, Padma Shri Awardee Dr. D.S. Rana, President Padma Shri Awardee Dr. A.K. Balla, Vice President Dr. Georgie Abraham, Chief Guest of the Day, Professor R.K. Dhiman, Director, SGPGI Lucknow, and Head, Department of Nephrology, Professor Narayan Prasad, invited esteemed faculty and delegates to 7th Advanced Course in Renal Nutrition and Metabolism 2021. The aim of this course is to bring to you an update on recent advances in the care and management of patients with kidney disease, to streamline nutritional intervention in order to prevent malnutrition and delay progression of kidney disease. The curriculum covers pathophysiology of chronic kidney disease and its consequence, malnutrition, along with management of specific conditions like acute kidney injury, glomerular diseases, involvement of cardiovascular diseases, diabetes, and conditions specific to kidney transplant recipients. Our society has reached more than 3 billion people to apprise them of chronic kidney disease and ways to prevent malnutrition in the patients. The theme of the course is Feeding Well in Chronic Kidney Disease. On this morning, I recall my roots of learning that lie deep in England, particularly the University of Cambridge, and I remember the then Chancellor of the University, Prince Philip the Duke of Edinburgh, who recently took to his final abode in the Royal Vault. May he be showered with blessings from heavens. On this note, let us begin proceedings of the day with Saraswati Vandana.
Papa?
I'm okay.
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Deepajyotir parabrahma. Deepajyotir janardanah. Deepajyotir parabrahma. Deepajyotir janardanah. Deepo hartu me papam. Sandhya deepa namostute. O deepa brahma rupasvam. Jyotisham prabhuravyayah. O deepa brahma rupasvam. Jyotisham prabhuravyayah. Arogyam dehi putrasya. Matim swachham hi me sada. Raverastam samarabhya. Yavat suryodayo bhavet. Raverastam samarabhya. Yavat suryodayo bhavet. Yasya tishte gruhe deepa. Tasya nasti daridrata. Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah.
I now invite patron of the society, Dr. D.S. Rana, Chairman, Sir Gangaram Hospital, to say a few words. I now invite patron of the society, Dr. D.S. Rana, Chairman, Sir Gangaram Hospital, to say a few words.
Dr. Rana? Let me call
I invite President of the Society, Dr. A.K. Balla, to address the forum. So you may start with the
Yes,
press.
yes. In the meantime, till Dr. Rana joins. Good morning, everyone. At the outset, on behalf of Society of Renal Nutrition and Metabolism, I welcome you all to this 7th Advanced course of Renal Nutrition and Metabolism. I must congratulate Professor Anita Saxena, who is Secretary of this Society, for her dynamism, passion, and hard work. That in spite of these COVID times, she has spared her valuable time to organize this very, very informative 2 days meeting. And I am really grateful to all the faculty members for sparing their time to prepare their thoughts, especially in these COVID times when all of us are busy in doing COVID duties. I am especially grateful to Dr. R.K. Dhiman, Director SCPGI, for sparing time, because I'm sure everybody is over busy in these times. And Dr. Rana, of course, as you know, that you have been reading in newspapers and TV, all the day, whole days, arranging beds, arranging oxygen, and
Hello.
the media. So I'm grateful to Dr. Rana also for sparing time to come for this today inaugural function. And I will request him to release the journal also, because it is all the efforts, sole efforts of Professor Anita Saxena, that she has been able to produce this quarterly journal of renal nutrition and metabolism. With this, I will request Dr. Anita Saxena to invite Dr. Rana to address the inaugural function.
Well, thank you, sir. I now invite patron of the society, Dr. D.S. Rana, Chairman, Sir Gangaram Hospital, to say a few words.
Anita, firstly, I must congratulate you for starting this initiative and continuing, and congratulations to you and your team and all people who are present there, that you are carrying this on virtual platform in spite of what's happening in the country. And I will just say, where there is a will, there is a way. You started this initiative about 7 years back, and at that time, people were thinking that probably whether it will succeed or not. But even during first conference, there was a very, very good conference, and it was organized very nicely by you. And I am glad that this is continuing, and Dr. Valla and other people, they're helping you out, and you are coming with this journal also. So I think in the days to come, right now, I cannot call you Mataji, but in the days that come, you will call Mother of Nutrition and this metabolism. In the days people have called Mother of Nutrition. Okay. So with it is my privilege to release the Journal of Renal Nutrition and Metabolism, and this is what as far as
Thank you, sir.
Thank you, and thank you very much. Thank you all. I am needed in the hospital very badly because there is crisis in the hospital of oxygen, and I'm going there.
Thank you, sir. Thank you, sir, for your.
Thank you, sir. Thank you very much, sir.
Thank you, sir. I now invite Vice President Dr. Georgie Abraham to address the forum. Is Dr. Georgie, have you joined, please? Okay. So if Dr. Georgie is taking time to join, we move on to our chief guest. And ladies and gentlemen, it is a privilege for us to have Dr. R.K. Dhiman, Director SGPGI, as chief guest here. And in such busy times of COVID pandemic, he has been kind enough to spare 20 minutes for us. I now invite Professor R.K. Dhiman to address the forum.
Thank you, Dr. Anita. And Dr. D.S. Rana, Padma Shri, is the patron, and the president, Padma Shri Bhala, and the vice president, Professor Georgie Abraham, and Dr. Nayan Prasad, delegates, ladies and gentlemen. It's indeed an honor to be with the august gathering of the renowned nephrologists and the physicians who are practicing the nephrology. And I've been told that this Society of the Renal Nutrition and the Metabolism, the idea came when the two people like Dr. Anita and the Bhala was attending one of the society or the conference there, and they have gone for the training in the Stockholm and the Sweden. And since then, this society has grown a lot. What I have heard from Dr. Bhala as well as from Dr. Rana, that this society and the journal is coming out on the quarterly basis. I think that is a great achievement. What I am saying that this 2 days course will deliberate upon the various aspects as far as an hepatologist is concerned. as an hepatologist, I would say that the kidney is a very, very important, and our liver problems, they are all linked to the kidneys also. And there are many similarities also. For example, the malnutrition. The malnutrition is quite common, not only the liver disease, but also the kidney disease. Because the metabolism, whether it is the carbohydrate or the protein or the fat, they are all changed. And the incidence or the prevalence of the sarcopenia that you see is very high. So I would say, besides the proper management of the kidney disease, what is more important, the nutrition is even more important and should be looked for. And indeed, it is the most neglected area. And I am happy that Dr. Rita is looking after it, and he is guiding force, I would say, in this specialty also. At the last, I would like to say that there should be courses like PDCC, the PDCF also, and more PhDs should be there who are working in the nutrition in the kidney or the renal diseases. I think with these words, time is up. That was only for the 3 minutes over here. And once again, congratulations for conducting this 2-day conference. And I wish this course a big success. Thank you so much.
Thank you, sir. May I now request you to release the information booklet for post-transplant patients? So this is Eat Well to Stay Well booklet for our post-transplant patients, and it will be translated in a lot of languages. Thank you so much. Thank you, sir. And may I now request the Vice President of the Society, Professor Georgie Abraham, to say a few words.
Good morning to you all, and respected Dr. Diman and my esteemed colleagues. It's a great pleasure for me to be associated with the renal nutrition course. And during this pandemic time, when everybody is looking down, and we have to be optimistic, and we need to take this forward. I congratulate Anita and her colleagues for conducting this virtual meeting. And I am also very indeed indebted to Anita for her adequacy and initiative. Thank you all, and I hope we will enjoy a great feast.
Thank you, sir.
Thank you.
I now request Professor Narayan Prasad, Head Department of Nephrology, to extend vote of thanks.
Good morning, everybody. At the outset, I would like to thank, first of all, our director, Professor R.K. Dhiman, sir, for sparing his time despite being so much pressure of the administration from the institute side, from the administration side, from the state levels. And sir never say no for any academic activities happening at the institute. So he always comes forward, and thank you very much, sir, for sparing your time for today's morning meeting at peak of that time. At 9 o'clock, you are here for the inauguration. Thank you very much, sir. Thank you, Professor D. Sharana, sir, for sparing his time. The chairman of the Sir Gangaram Hospital for the limelight in the news for last 2-3 days, and managing such a great institution and sparing time for this innovation. Thank you, Professor Anil Balla, sir, for sparing your time. And I I understand your dedications towards the SRNM, nutrition metabolism of kidney origin, particularly. You have spent so much time and you are dedicated to this work. Thank you, Professor Georgie Abraham, sir, for being here with us. On despite being so much busy schedule in your own institution, Triple M, and then Pondicherry institutions, so many works at your head, but you are sparing time for this meeting. Thank you very much, sir. Thank you all delegates. Thank you all industry persons for sparing time or supporting this SRNM. Thank you, everyone. Thank you for joining this meeting. And in the last, I would like to thank, but not the least, Dr. Anita Saxena, who is taking this SRNM, Renal Nutrition and Metabolism Society forwards. And we have all noticed that it came so many steps ahead now. They have their own journals. There are so many publications from their there are so many books there for this help of this year. And just I wanted, we have surveyed, and our 70% of the patients in this zone had some degree of mild or moderate malnutrition. So the prevalence of malnutrition is very high in this part of India, and it requires to be taken care. So thank you, everyone. Thank you, Anand, your senior, everyone. Thank you, all delegates.
Thank you, sir.
Thank you, Dr. Narayan, for your kind words. And that brings us to the end of the inaugural session. I profusely would like to thank all the dignitaries who participated in the inaugural session, particularly our chief guest, Dr. Dhiman, our director. And sir, thank you so much for joining us. Now we move on to the first session on chronic kidney disease, and the moderator for this session is Dr. A.K. Sareen, who is a consultant nephrologist at New Delhi. May I request Dr. A.K. Sareen to please invite the panelists and the speakers. Dr. D.S. Rana has already left, so you may invite the speakers now. Dr. Sareen, have you joined?
Hello, can you hear me?
Yes.
Yes.
Yeah. So as somebody said, that malnutrition is such a major problem in our renal patients, and some of our Indian patients, and especially those of the others, the indigenous specialties, say, don't eat this and don't eat that. And I trained in the UK, and eating for renal patients is so important. And we used to have a little kitchen in our renal unit where there was a dietitian who would weigh each and everything and fed the patients. Of course, everything was very calculated, but the patients were very well fed, whether they were pre-dialysis, dialysis, or post-transplant. So nutrition is exceedingly important. Treatment of renal disease is not just medication, and we all know that. So to start the first lecture, progressive nature of kidney disease, and none else but Dr. Georgie Abraham. Can I invite Dr. Georgie Abraham to talk on progressive nature of kidney disease?
Yeah, thank you so much, Professor Sareen. And I would like to dwell on the progressive nature of the chronic kidney disease. So I will project my first slide. A moment, please. Yeah. So thank you all once again, and for the benefit of the people to understand, chronic kidney disease is defined as kidney damage or a glomerular filtration rate of less than 60 ml or an albumin creatinine ratio of 30 milligram per gram of creatinine for 3 months or more, irrespective of the cause. It can affect all 4 compartments of the kidney, including the tubules, the interstitial compartment, the vascular compartment, or glomerular compartment. Kidneys filter waste and excess fluid from our blood, which is then excreted in the urine. As chronic kidney disease is progressive, dangerous levels of fluid, electrolytes, and waste can build up in the body. Not moving. Slides are not moving. How do I? This slide, though it is a little complex, shows the chronic kidney disease and cardiovascular risk in 6 regions of the world by the ISNKD-DC, a cross-section study. When you look at the bar diagram on the left-hand side, India with a population of 1.3 billion people, the prevalence of chronic kidney disease is about 17.2%. And it is seen in general population cohorts, and it is shown in high-risk population cohort. And when you look at the chronic kidney disease registry of India, which was published nearly 10 years ago, diabetic kidney disease is the most common cause of chronic kidney disease. And when you look at the chronic kidney disease algorithm, you have the kidney disease from stage 1 to stage 5, shown here stage 1, stage 2, stage 3A, stage 3B, stage 4, and stage 5. And the albumin excretion ratio is shown on the horizontal axis, less than 30 milligram of albumin per gram of creatinine in a spot urine, 30 to 299 milligram, and above 300 milligram. So every nutritionist should be aware of this particular graph so that they can follow the progression of chronic kidney disease in patients, and thereby they can adjust the diet or give dietary advice. And in some instances, you may find that there will be a temporary fall in GFR in a chronic kidney disease patient to stage 4, which can revert back to sometimes to stage 3 or stage 2. So this should be taken into consideration while looking at patients, especially by the nutritionists and by the doctors. Who should be involved in the patient safety approach to chronic kidney disease? So the stages are shown in the rectangular gray graph: stage 1, stage 2, stage 3, stage 4, and stage 5. It can be the primary care practitioner in the early stages up to stage 3, as it is done in UK healthcare service, or in India also this can be taken care. And in stage 4 and stage 5, it should be involved by the nephrologist as well as by the nutritionist. And so nutritionists should be there all through to help the patient, enabling safety, and also other specialists should be involved. For example, you Odisha, Goa, and Maharashtra. Although no single causative factor is proved, several have been proposed: waterborne agrochemicals, silica chemicals, flavors in the pesticides. They are all responsible. Dr. Narayana Prasad is involved just a cartoon to show what is a normal kidney, and this is the glomerulus, and you can see the Bowman space there. These are the tubules, which are the proximal convoluted tubule. This is the distal convoluted tubule, not the difference between the proximal and the distal convoluted tubule. And this is the juxtaglomerular apparatus. This is an afferent arteriole, and these are the component cells of the glomerulus, which involve mesangial cells, endothelial cells, and also epithelial cells. And so this is a normal glomerulus. As the disease progresses, this may move on to abnormal nephron, which shows sclerosis of the glomerulus. Then you have almost completely sclerosed glomerulus here. There is also vascular sclerosis as shown here. And also you see the loss of tubules where you're not seeing any tubules compared to this one. So tubulointerstitial disease. So all compartments of the kidney are affected when there is a progression of the chronic kidney disease from stage 1 to stage 5. So people always see that is the serum creatinine definitely tells about the kidney. This graph shows the non-linear relationship between serum creatinine and glomerular filtration rate. At any glomerular filtration rate on the x-axis, there is considerable variation in the measured serum creatinine concentration. This is the serum creatinine shown in the vertical axis and the GFR by inulin clearance on the horizontal axis. So even with a creatinine of 1, you could have a GFR as low as 40 ml per minute. So this should be taken into consideration. That is the reason why people have put forward the eGFR estimation using either cystatin and the CKD-EP formulas and various other formulas, including the Cockcroft and Gault formula. So kidney maintains fluid electrolyte balance, acid-base balance, removal of waste, blood pressure control, erythropoietin secretion, vitamin D, active vitamin D formation, keeps the bone healthy, maintains calcium, phosphorus, vitamin D, PTH, and FGF23 within normal limits, maintenance of amino acid pool. 50 to 70 gram of amino acid are filtered, and 98% is reabsorbed in the proximal tubule. Kidney is also involved homeostasis of glucose and insulin. And this cartoon shows a kidney with normal and going to stage 5 kidney disease. And there are no specific symptoms, but kidney function can slowly decline. And here, kidney can no longer keep up with removing waste products and extra water. This is called kidney failure. Although there is no cure, treatment options are available, such as dialysis and transplantation. So this is our data on malnutrition in CKD population in India, published data. And this shows the color coding shows CKD stage 5D in blue and CKD stage 5 non-D in green, CKD stage 4 in yellow, and CKD stage 3 in red. So when you look at the middle income group and low income group, you can see that in the low income group, about 93% of patients are malnourished on dialysis, and in the middle income group, it is 68%. And the malnutrition levels are low in other early stages of chronic kidney disease. So albuminuria and CKD staging I have already alluded to. So green shows low risk as it is here. Yellow shows moderate risk as it is shown there. And orange shows high risk as it is shown here, and very high risk. So diabetic kidney disease, the most common cause of kidney disease in India, and 87 to 91% are due to type 2 diabetes mellitus, and 50% go to CKD, and 7% to 12% are due to diabetes mellitus 1, 33% go to DKD. Diabetes have nearly twofold higher odds of CKD than those without diabetes. 1 in 3 adults with diabetes are estimated to have CKD, and most are not aware of having CKD. There are 77 million diabetics in India. The level of CKD awareness is less than 10% in the general population of CKD patients, even in United States of America. The role of kidney in glucose homeostasis. The kidney is considered as 2 separate organs. The renal medulla is characterized mainly by glucose utilization, and the renal cortex is responsible for glucose release. The 3 different mechanisms involved in glucose homeostasis by the kidney are gluconeogenesis, that is production of glucose, glucose uptake from the blood for its own energy requirements, and reabsorption of the glucose into the general circulation in the proximal tubule from the glomerular filtrate in order to preserve energy. So kidney disease in diabetics, I just want you to look at this stepwise diagram. It shows no signs of symptoms until 70% of the kidney function is lost. CVD risk is equivalent. Serum creatinine rises only if 50% of the renal function is already lost. 50% of the beta cell function may be lost at the diagnosis of type 2 diabetes mellitus. Primary care physicians screen only 20% of their diabetic patients for kidney disease before prescribing. Hypoglycemia worsens as kidney impairment. And these are the data from India, from New Delhi, Chennai, New Delhi and Davangere, and the prevalence of low excretion of albumin, that is microalbuminuria, varies between 16% to 42% in various studies in India. So looking at the diabetic kidney, it is inflammation and fibrosis are destroying your patient's kidneys. So you have metabolic drivers such as elevated blood glucose shown by hemoglobin A1C levels. Hemodynamic drivers are shown in this cartoon: rise in blood pressure, high intraglomerular pressure, and then inflammatory and fibrotic drivers, pro-inflammatory cytokines and fibrotic protein. Today, the treatment of CKD in type 2 diabetes does not adequately address, particularly this part, inflammation and fibrosis, a major driver for CKD progression. So diabetic kidney disease, the risk factors are susceptibility factors such as age, sex, race, ethnicity, and family history. Initiation factors are hyperglycemia and AKI. Progression factors are hypertension, dietary factors, and obesity. So genetic contribution to diabetic kidney disease, we know that there are 102 genes involved in diabetic kidney disease. We are not sure about the genes in our country. We are doing a proactive study with one of the pharmaceuticals looking at our patient at various stages of kidney disease, an ongoing Indian study. So I want you to look at, inflammation and mitochondrial function. And when you look at the tumor necrosis factor and the time constant, so you will see that the TNF is less in controls. Patients with CKD 3 and 5, it is slightly higher, and patients on maintenance hemodialysis, it is much higher. These are all statistically significant. Then interleukin 6 shows the same pattern in control in CKD 3 to 5 and in maintenance hemodialysis patients. So the possible association among factors that could be implicated in the pathogenicity or frailty in patients with CKD are uremia leading to oxidative stress, inflammation, mitochondrial dysfunction, physical dysfunction, frailty, physical inactivity leading, and I will show you what is EMAT. So I will show EMAT is intramuscular fat accumulation. Uremic toxins are small water-soluble molecules, molecular weight less than 5,000 Daltons, and middle molecules and protein-bound compounds. I'm not going into detail of that. So what is the gastrointestinal tract doing in chronic kidney disease? You have a diseased kidney shown by this cartoon. There are comorbidities, medications, dietary factors such as anorexia, low fiber constipation, decrease in motility, decrease in protein digestion, decrease in absorption leading to edema, intestinal edema. Prebiotic and probiotic may be of value here. Increase in proteolytic bacterium flora, that is dysbiosis, toxin generation, mucosal injury to the gastrointestinal tract, translocation of bacteria and toxins, inflammation, immune suppression, all leading to increase in cytokines, uremic toxins, endotoxin, and increase in cytokine production, and increase in half-life because of chronic kidney disease, and decrease in cytokine elimination. So uremic syndrome, gut microbiota plays a major role, as I have shown you here. So if you have symbiosis, it is fine. When there is dysbiosis, that is alteration in the gut microbiota, normally 85% of the gut microbiota among the 100 trillion microbials in the gastrointestinal tract are beneficial, and 15% are not beneficial. When you have CKD, this reverses, giving rise to dysbiosis and worsening of chronic kidney disease. So this is shown in this, and I'm not going into protein energy wasting. And then you have the chronic kidney disease, CVD, all leads to inflammation and dysregulation of immune regulation, leads to infection. And these are the two toxins produced by the gastrointestinal tract, peak resolved sulfate and indoxyl sulfate. So protein energy wasting syndrome is a very busy slide. It involves malnutrition, uremic toxins, protein energy wasting, cachexia, hypercatabolism, inflammation, leading to decrease in albumin, weight, BMI, survival paradoxes, increase in mortality, atherosclerosis, and cardiovascular death. And mechanism leading to protein energy wasting is also very complex. Nutritional restrictions, increased activity of mitochondrial uncoupling, and decreased nutrient intake, proteolysis, all leading to protein energy wasting. And so these are the essential nutrients: carbohydrates, proteins, fats, vitamins, micro and macronutrients. And we all know that we have to give them adequate amounts of these. As the GFR falls, we have to produce restriction. So energy expenditure in normal individuals, it is shown in this bar diagram. Basal metabolic rate is about 60 to 75%. Physical activity is 15 to 30%. Diet induced is 7 to 13%. Others are 2 to 7. So depending upon the physical activity, you may have increase in energy requirements in patients who are quite physically active. So this is a study which we did in quantification of subcutaneous and visceral fat in abdominal CT and correlation with metabolic parameters. And CT abdomen was run between L4 to L5 intervertebral disc, 10 millimeter, were selected to quantify WAT and SAT during gastrointestinal advanced work station. WAT stands for tomography quantified visceral fat, and this is subcutaneous fat. And we found that the mean GFR among hypertensives was 78.1 compared to 106 in normotensives. A trend was observed towards low GFR with high VAT. The mean eGFR among diabetics was lower compared to non-diabetics, and this was statistically significant. So what are the importance of exercise? This has been recently published. When you look at the exercise pattern, those people who are exercising, they do have slowness of the progression of chronic kidney disease as shown in this particular graph. And when you look at that physical activity assessed by accelerometer and questionnaire, and you can see that moderate to vigorous physical activity, the odds ratio is shown here, and the GFR is shown here compared to TB watching and overall activity. They have also randomized according to Mendelian randomization. This is a large cohort of 100,000, 360,000 people in UK. So exercise forms a very important part. So treatment of disorders of sodium balance, you can see that systolic blood pressure is high when you have high salt, and diastolic blood pressure is also high. And high salt also produces increase in extracellular volume, increase in weight, and high salt. So the CKD is most commonly associated with expansion of the extracellular fluid volume, which contributes to hypertension. Loop diuretics are often required to reduce extracellular fluid volume and to correct hypertension. So types of metabolic acidosis, this is a latest publication. Normal acid-base balance, base generation is equal to acid generation. U bicarbonate, here normal serum bicarbonate, normal pH, but the acid accumulation in the interstitium is there, which leads to non-acidemic hypobicarbonate because the low bicarbonate is low here. The base generation is decreased and the acid generation is increased, and towards the end it is acidemic hypobicarbonate. So bicarbonate should be about 22.22 millimoles. Acid accumulation is progressive with CKD, risk for poor outcomes. So I will just come to the last slide. Primary care practitioners, the first line of defense against CKD: identification, effective management, regular monitoring to slow the progression, and early detection is by albumin creatinine ratio and eGFR by CKD epi formula. And then moving on to the next one, comprehensive care in CKD in diabetics involved this pyramid: antiplatelet therapies and SGLT2 inhibitors, RAS blockade, glycemic control, exercise, blood pressure control, lipid management, and all. So conclusion: CKD and CKDU are enormous challenges in India. Malnutrition is a critical issue to be addressed in CKD and in CKDU patients. Nutritionists play a very critical role in malnutrition therapy. Thank you for your kind attention.
Dr. Serene, I'd like to inform you that Dr. Sunil Prakash, who's the next speaker, is stuck up with emergency in the hospital, so he won't be able to take up the talk now. Maybe we can organize the talk much later, but we can move on to the next speaker now.
Hello. Hello.
Yes, Dr. Serene, please continue.
Can you hear me?
Yes, yes.
Can you hear me? Yeah, thank you very much, Dr. Georgie. That was a very exhaustive talk in a short 20 minutes. And I just want to point out that you dwelt very well on exercise. Our Indian patients, you know, they don't bother about exercise. They don't even think about, they say we should lie down and after eating, you know, we have to take this medicine and that medicine. But exercise, they don't give importance at all. So I'm very glad you dwelt on this very important aspect of daily life. We'll move on, as we said that Dr. Sunil Prakash will be coming a little later. So we'll go on to the third speaker. Can I invite Dr. Dhananjay Ukalkar? He will be talking on implementation of nutrition care process in nephrology practice. Implementation of nutrition care process in nephrology practice. Dr. Dhananjay, please.
Thank you, sir. Good morning, ladies and gentlemen. Chairman, sir. I would like to begin by thanking the organizers for giving me this opportunity to share my perspectives on how nutrition care process could be implemented in a nephrology practice. Nutrition care process has been introduced in the West, and majority of the developed countries use that as the standard way in which nutrition care is delivered to their patients. It was introduced in 2003 by the American Dietetics Association, but unfortunately, because of multiple factors like lack of adequate training of this concept in postgraduate education in India, this has not yet picked up in India. There is an inadequate remuneration for nutritional services in India, both at the government and at the private sector. Nonetheless, if a nephrology practice is determined to introduce it, I would like to share some of my perspectives since I have been trying to implement this in my setup for the last few months. So over the next few minutes, I would like to talk about what is nutrition care process, how to implement that nutrition care model in your practice, how to implement nutrition diagnosis, how to do nutrition assessment will be dealt with by my colleague, Dr. Ashwini Ukhalkar, and what are the nutrition interventions which a nutritionist alone is responsible for carrying out after having made a nutrition diagnosis, and then having made nutrition interventions, how she should be figuring out monitoring and evaluation of the process. So broadly speaking, the nutrition care process concept talks about the determinants of good quality nutrition care at the hands of a nutritionist. It is recognized that our healthcare set systems in which we work, our social systems in which we work, the economics of the area in which we are operating, and our practice settings will be the main determinants of nutrition outcomes in our population. Inside this circle, as far as the individual is concerned, it is the knowledge that the dietitian has, her skills and competences, her critical thinking ability, her ability to communicate well with patients and to collaborate with her colleagues, and ability to practice evidence-based medicine under the code of ethics will be the other big circle which will influence how this nutrition care process will deliver the results. The process is very simple. It is an integrated 4-step process of nutrition assessment to begin with, followed by making a nutrition diagnosis, and then planning nutrition interventions and monitoring what are the results of that nutrition interventions. And so that the outcomes can be measured, and then those outcomes will feed back into nutrition assessment, again, reassessment. So this is the nutrition care process. My other colleagues will be speaking in more details about this concept. But first and foremost, I would like to point out that this is a very advantageous way of working as compared to the previous models which we have been seeing being followed by the nutritionist. One is it uses a standardized process and a standardized language. It can be of immense educational tool for dietetics because there is a common language between two dietitians. And therefore, the data which is generated can help in qualitative and quantitative research for our patients. And since there is clinical documentation and dietetic-related communications, the outcomes can be evaluated and the shortcomings of the process can always be rectified. Previously, when we were not using this nutrition care process, the typical dietitian's consultation would begin with the medical diagnosis with which the patient was coming, followed by a cursory assessment, which was not structured, and then straight she would jump on to giving a diet prescription based on the nutrition prescriptions which are advised in the books. She would give it and the patients would be lost afterwards. There was no monitoring, there was no outcome measurement, and we really did not know whether any good was happening because of the dietitian's advice to the patients. But after we started using it, our documentation has improved and we can now find out all that which is not going right in the patients. There were barriers to this implementation. The first and foremost was was a lack of nutrition care process knowledge amongst the dietitian. Because although the textbooks of postgraduate education have this section since a very long time, since I think 2015, the University Grants Commission has introduced this, the teaching of nutrition care process during the postgraduate period was not much. There were claims that there was time constraints from the dietitians, and that they thought that this is some research tool which the nephrologist is trying to push onto their routine clinical practice. And since they had never seen it before, they did not appreciate its importance. We have an electronic medical record system, and so there were some challenges of introducing this NCP within the framework of the electronic medical records. But we persisted, and we encouraged the dietitians to attend workshops and raise the awareness and understanding amongst the staff. And we have been supportive as managers to their growth and development. Since it is not very aggressively taught in the postgraduate courses, we found this nutrition care process web-based training very useful. This is available freely on the eTribe website. There are 6 videos, each of approximately 10 minutes duration. They are free. Each video is followed by an assessment tool, and they cover the entire gambit of nutrition care process from introduction, nutrition assessment, diagnosis, intervention, monitoring, followed by a quiz at the end. If it is answered correctly, then you can get a certificate also at the end. This is another book which I found very useful to teach my nutrition, to implement this nutrition care process in my practice. This is with the American Dietetic Association, Nutrition Diagnosis, a critical step in nutrition care process, because the nutrition diagnosis are in 3 domains. One is the intake domain, for which the dietitian is solely responsible for taking all corrective actions. The second is the clinical domain, and the third is the behavioral and environmental domain. A nutrition diagnosis is a nutrition diagnosis is different from a medical diagnosis. A medical diagnosis, let's say diabetes or chronic kidney disease, will remain permanently with the patient till he is alive. But a nutrition diagnosis will change as the patient's condition changes. And naming the nutrition diagnosis helps us in setting up realistic and measurable goals, outcomes, and design appropriate interventions and track progress. Each of these domains, intake, clinical, behavioral, environmental, has a number of classes. And then the dietitian is supposed to make a nutrition diagnosis based on this. This is another very useful book, Chronic Kidney Disease and the Nutrition Care Process. It's specific about chronic kidney disease. I am in no way alluding that nutrition care process is focused only on CKD or nephrology. This is a universal process of all dietitians, whether they work in gastroenterology or cardiology or nephrology. It is an easy to use book. It comes also on an online version and it helps in implementation of the nutrition care process. There are two main interventions which a nutritionist is supposed to make. One is she's supposed to give a nutrition prescription in collaboration with the nephrologist. And that prescription is quite well known. Many people are aware of that prescription of how much calories to give in a CKD, how much protein, how much salt or potassium. The second is implementation of whatever prescription is getting generated. And there are four main interventions which a dietitian is expected to perform in the nutrition care process. These are food and nutrient delivery. Second is nutrition education. Third is nutrition counseling. And fourth is coordination of nutrition care. I'd just like to highlight that nutrition education and nutrition counseling are two different interventions. And counseling is an important intervention in the nutrition care process because by a counseling alone, nutritionists can encourage clients to make and maintain dietary changes. But counseling skills are akin to the skills which a psychotherapist would have of behavioral modification. This is a book which is specific for nutrition care process and what are the nutritional counseling skills which the dietitian will require. Integration of the electronic nutrition care process documentation into the electronic health record. This is a very good free webinar, recorded webinar, which is very useful which I found very useful in my practice. Documentation of the nutrition care process, interactions of the patients and the dietitians. This is a template. The mnemonic is ADIME, assessment, diagnosis, or a problem, etiologies, signs and symptoms statement, interventions, nutrition prescription, nutrition interventions and goals, monitoring, evaluation, and notes for the follow-up. So this is a more elaborate way of how the nutrition notes should be written, and this could be written in MS Word and then attached to your EMR. In the nutrition assessment, who sent the patient to you? Why was the patient referred? What is the initial session? Was it an initial session or is it a follow-up session or a yearly checkup? What is the nutrition related history? What are the anthropometric measures? What is the biochemical data, physical findings, and what is the medical history of the patient? The nutrition diagnosis comes up as PES statements, and the nutrition interventions have mentioned about the goals and priorities of the patient, considering his values and beliefs. And then what have you taught as a dietitian to the patient? Have you taught him blood sugar monitoring? Have you taught him self-blood pressure monitoring? Have you taught him how to measure the fluid which he is taking through a measured bottle? How to measure the salt intake which he is consuming? And what are the agreements that we have between the dietitian and the client or the patient as to the modification in behavior which they will do? And what are the indicators that we will monitor for the process success? Because a dietitian no longer sits in the corner office and patients just before buying the medicines go and give her a cursory visit. She is now becoming a central figure into a collaborative group model. This is a very good webinar for this, although it has a price tag, but still it changes the perspective of a standalone warrior to a collaborative model. And there are various mobile apps now available for which will help us in the nutrition care process. And some of the apps, one of these apps is NutriGuide. This guide, when patients go grocery shopping, all the gas which is delivered in their session simply evaporates. And the patient is at loss to know whether I should pick up this food item or should not pick up this food item. So NutriGuide app helps this patient to scan the barcode of that food item, if it is a canned food item, and then they take a call whether it is okay with him or not as per his advice. Another software which I found to be very useful in my practice was this Nutrium software, which has changed the way we have now understanding the nutrition process. So just to tell a few nutrition diagnoses which are very common in my practice, this in the intake domain, inadequate energy intake without any restriction of protein. This is not a diagnosis which we are seeing at all. But majority of my patients have inadequate protein and energy intake. 91% of them started with 86 and to March 91% in this year. This means that there is less than 30 kilocalories per kilogram protein intake and less than 1 gram per kilogram protein intake in my dialysis population. And this is maybe because of because of loss of appetite, although majority of them are on thrice a week dialysis. Maybe because of little less adequate dialysis, because majority of them have a KT/V of 1.2. Or there could be economic constraints in some of my patients because they cannot buy the protein supplements and increase their protein intake. And depression is a common feature in majority of my patients. Roughly about 70% of them feel depressed. And so inadequate protein energy intake up to the tune of 90% of my patients are caused by multiple etiologies. And because we start writing this diagnosis in this way, we can then sort out how much is the contribution of inadequate dialysis, how much is the contribution of depression, how much is who are the people who cannot afford protein supplement, and then the dietitians can take appropriate actions. And many of these patients have evident protein energy malnutrition in the form of varying grades of severity of malnutrition as per the SGA classification. Although majority of them have mild malnutrition, very few patients nowadays come with very severe protein energy malnutrition. But yes, it's a problem that we have to tackle. Many of the patients have excess fluid intake because of their unwillingness or lack of interest in reducing intake and depression. So they keep on having an interdialysis weight gain of more than 2.5 kg, although they are on thrice a week dialysis. Not many people in my population have excess mineral intake, either phosphorus or potassium. So our patients' serum phosphorus and potassium are nearly normal. Chewing difficulty because of poor dentition is a common problem because majority of my patients are beyond the age of 60. Impaired nutrient utilization is seen often because 40% of my dialysis patients have diabetes. And about 30% of the patients are underweight. That is, their BMI is less than 18.5. Only 4% of the patients are overweight. And there is a universal lack of knowledge of food and nutrition knowledge amongst these patients. And there are about 20% of patients who have some kind or the other of harmful belief systems which interfere with their rehab on the nutrition frontier. And many of them are simply not ready to change their behavior. Nutrient use necessitates the involvement of the patient in monitoring what he has eaten. But a large number of my patients simply cannot cope up with the demand of reporting their food habits all the time. So this is the nutrition prescription which is given to these patients. The second is the nutrition delivery implementation, giving protein or vitamin supplement, checking food medication interaction, and adjusting the phosphorus binder doses. As far as nutrition education is concerned, there is a lot of resources available from the Academy of Nutrition and Dietetics publications to the American Association of Kidney Patients publications. But I found that these publications are of limited utility because of the low health literacy in our population. And the trouble that majority of these publications are in English and I deal with a population which is not much comfortable with English. But there are other educational resources from Life Options, from National Kidney Disease Education Program, and from the websites of dialysis providers like Davita, which are quite useful, provided they are translated in the local language. But to motivate our patients to change, our dietitians need to be trained in psychotherapy and counseling skills to be able to ask open-ended questions, express empathy, listen reflectively, and explore the discrepancies in the patient's narratives. Because change doesn't come suddenly. Change comes in stages, from pre-contemplation to contemplation, preparation, action, and maintenance. This is also called as the trans-theoretical model of intentional behavioral change. And in each, there is a duality. The patient has to do something, and the dietitian has to give him an appropriate response so that the patient comes to the next stage and behavior is ultimately modified. There are strategies for modifying behavior like stimulus control and cognitive restructuring, which would require a long session to discuss. In brief, I would just like to highlight again the point which Dr. George Abraham made about the importance of exercise. And like his unit, we have also started using a bicycle for exercising for patients while they are on dialysis. There are loss of appetite is an important problem in my patients, but these medications which are there as appetite stimulant, one has to be aware that many of them will have side effects which should be monitored. And we need to monitor in these patients their food and nutrition related history, the changes in their biochemical data, and serum albumin takes a long time before it starts dropping. So many of these patients may be severely malnourished, but their albumins may be normal, is my observation. And the more regular monitoring of their weight, post dry weight, and the regular monitoring of their tricep skin fold, mid-arm muscle circumference goes a long way in changing the way we practice dietetics in nephrology. So this is another structure that we are using in electronic medical record of documenting what is the nutrition diagnosis, what is the nutrition intervention, what are the patient's priorities, and what the dietitian thinks should be the priorities, and in between both of them, what goal they decide and agreements they reach, and then what are the indicators that they will use. To conclude, the nutrition care process is currently being implemented in different countries globally, translated into 11 languages and dialects. Unfortunately, it is not yet popular in India. But from my personal experience, I can say it is not difficult to start implementing the nutrition care process model in a practice with the available resources that are already at hand. Thank you.
Thank you very much, Dr. Dhananjay. It was an excellent talk on the process of nutrition. And I'm very glad you dwelt on the behavioral aspects, depression in patients, because it is not just prescribing a diet by the nutritionist or the nephrologist, but it's implementation, counseling, encouragement of the patient, and a very positive attitude from the part of the nephrologist and the nutritionist. So it's very important that, you as you said very rightly, that you have to encompass all these factors. It's not just prescribing a diet. So we move on to the next talk, which is has Dr. Prakash come in? No. Implementation of the nutrition care process, clinical case, Dr. Himani Puri. Dr. Himani Puri, please.
Good morning, everybody. Can I start sharing my screen?
Yes, ma'am. Yes, ma'am. You can.
Good morning, everybody, and thanks a lot to the organizers and Dr. Nita Saxena ma'am for giving me an opportunity on being on the platform with such eminent speakers. I'll be talking about the clinical scenario of the nutrition care process. Dr. Ukalkar in my previous session has already spoken in detail about what the nutrition care process is. We'll be talking about the clinical implementation of this process in a practical scenario. So as we all know that whenever a patient is walking in, we are intervening the patient with the nutrition is concerned, where diet is concerned. We evaluate and we monitor the diet of the patient. We also come to a diagnosis, and as Sir said, probably a medical diagnosis is what we use to intervene the patient where diet is concerned. We screen the patient. We also are assessing the patient for the nutrition intake. We are also communicating amongst ourselves and probably with the patient and the family also when it is required. However, it happens in random, maybe not in a specific pattern. And that is where actually the nutrition diagnosis came into existence. So what does this nutrition diagnosis basically mean? It basically refers to forming a PES statement, which can be defined as problem for P, E for etiology, and S for the science. So this collectively helps us to come to a conclusion as to intervene the patient in the diet is concerned, and to reach to this PES statement in the NCP process is important. So the nutrition diagnosis basically refers to the term, that is nutrition problem, probably malnutrition or undernutrition or less intake of the calories and the proteins, which could be related to the etiology, that is the patient is not eating well, and can be evidenced by the signs and symptoms, that is probably we can see the MUC of the patient, that is the mid-arm circumference which is lesser, or we see that the patient's BMI is lesser than the normal range. So for this, the NCP process was formed. It was adopted by the ADA in March 31, 2003, and refers to a systematic problem-solving method that makes the dietetic professionals to think critically and make decisions to address nutrition-related problems and provide safe and effective quality nutrition care. The NCP basically is a four-step model or a process and involves one, the assessment, second, diagnosis, third, intervention, and fourth, the monitoring and evaluation of the nutrition status of the patient. The NCP process does not include the nutrition screening of the patient, which is what we do when the patient walks in into the OPD or walks in front of us. So this NCP process is got a basic purpose of identifying nutrition related problems, and the process of NCP basically involves obtaining, verifying, and interpreting the patient data. The NCP process first step involves the assessment of the data, which can be basically in two main sources. One could be from the health records that are available to us, maybe the lab values, the medical diagnosis, or the administrative reports which are already existent in the patient file. And the second is that we create an assessment based on these sources. Probably we take a diet record, which Dr. Ukalkar would be talking about much in detail in the next session. We take the anthropometric measurements of the patient, or we try to gather more information by interviewing the patient. So the nutrition status of the patient can be assessed in the following pattern. It basically includes the 5 domains. I'll be talking about each domain with a case presentation. So the first domain includes the patient history, which includes the general information about the patient, like the age, gender, ethnicity, the family records of the patient or the medical history of the patient, and the social history of the patient as well, like his socioeconomic status, his medical care support team, and his involvement as in the social groups. So for example, here, there was this patient who is a 53-year-old pleasant gentleman. He had come with a history of nausea, low appetite, vomiting, edema in the feet, puffiness of the face since January 2020, and he had been on dialysis since past 3 months. On further investigation, it was found that he had a high creatinine level and diagnosed to have CKD. In the month of April, he felt semi-unconscious, disoriented, and therefore was admitted in the hospital and was directed to have uricemic and CAF. On USG, he was found to have small size kidneys and loss of CMD. So this was the patient history which was taken in the first part. The second assessment, can I just request others to mute, please? On further investigation, it was found that he had case of weakness, low appetite, giddiness, nausea, vomiting, high creatinine levels, and high urea levels since 5 days. and therefore he was admitted, and permanent catheter insertion was done, AVF construction was done, and was put on the HT. He was admitted again in June with fluid overload and sepsis, and in September 20, he presented again with a case of weakness, breathlessness, cough, nausea, giddiness. So you can see clearly that the patient has been having these symptoms since almost 5-6 months now. Further investigation was done, and the list of his medications was taken, noted down. Socioeconomic profile of the patient was assessed. There was no specific family history noted. The patient had good relation with the family. That means that the patient's family was very supportive of his medical care and also social background as well. The wife took good care of the patient and was always accompanying him during dialysis session. This becomes very important because family is the primary contact with the patient care is actually taken, and therefore it becomes very important for us to understand how supportive the family is in terms of the nutrition care and the medical care as well. Also, it was further discussed and found that the patient's wife was also very supportive and very inquisitive about the nutrition intake of the patient, and the patient was socioeconomically stable. He had no financial concerns and was a banker by profession. So this actually helps us to form a diet for the patient. In terms of the diet, becomes easier for us to plan where the financial restrictions are not involved, and we know that the patient family would be equally involved in the diet care process of the patient. The second domain was the food-related history of the patient, which was taken, and it was assessed for the food and nutrient intake. It was also observed for the food and nutrition administration, any food allergies, medication or complementary alternative medicine use, which was there. The patient's knowledge, belief, attitudes are observed. His behavioral factors which affect his nutrition-related goals are also observed. And the access to the food is also very, very important here. And of course, Sir has already spoken about the physical activity. The previous two speakers mentioned about the importance of physical activity, which again is taken into consideration. So it was found with the diet recall. As you can see here, that his calorie intake was 1500, his protein intake was around 45, his fat intake was 15 grams, carbs 180, salt 5 grams, and his water intake in the 24 hours was 2 liters. So this was the breakdown done of the macronutrient intake of the patient. It was found that his carb intake was almost 408 grams, which was more than what was expected by the patient. His protein intake was lesser, and his fat intake again was lesser than the normal. So clearly the patient was overloaded with the carbohydrate intake. Also, he was checked for any food allergy and if he was taking any other alternative medicine, which was found to be none. The patient was spoken about and we spoke about the religious beliefs that he had about diet intake, and it was found that the patient was vegetarian, so he was comfortable with eating the eggs. However, on specific days he did not prefer eating the eggs. However, there was a clear understanding of lack of knowledge about what to eat from the patient. He had clear misconception that if he ate more he would become obese, and that could actually aggravate his problem. So he was trying to decrease his intake. He also felt that after he ate, he was having difficulty in breathing. And he was advised by his certain relatives and friends that if he ate more protein, he would have more complications with where the kidneys is concerned, and therefore he had stopped consuming the proteins or was taking it on and off. Also, he was told by the relatives that fruits, vegetables which have seeds should be avoided because they can cause further damage to the kidneys. And he was in love with tea. He was addicted to tea completely and thought that missing out on tea gave him a headache. The next part was the physical activity, and it was found that he was maintaining a regular fitness activity. He was going for regular walks and exercising since 3 months. However, since his dialysis sessions, he started to feel weak, and therefore he started skipping his walks and exercises. And his movement was restricted only to daily course, that is traveling around from one room to the other. The domain 3 was the assessment for the biochemical data, medical tests, and the procedures. The biochemical parameters were checked, his X-rays and US sonographies were done, and his physical examination was also done. So as you can see here, these are some of the blood reports which were done and the history of the biochemical parameters taken. As you can see clearly, there has been quite a peak travel from high to low in the HB. His TLC count was from 7,000, it rose to 10, and then it came down again to 5. His neutrophils again showed a jump here. His creatinine again was very high earlier. It came down to 2, but then again had risen to 4.5. His calcium level had dropped down from 7.9 to 7.4, and his phosphorus had shown a slight increase. His serum iron had dropped down. His ferritin level had again improved slightly in between and again come down. His transferrin saturation again had dropped, and his TIBC again had come down from 32.5 to 290.4. The other biochemical parameters which were assessed were the PTH, the alkaline phosphatase, the sodium, and the potassium intake. The examinations were done, which can be seen here. The fourth domain was the anthropometric measurements, where his height, weight, BMI, and growth pattern indices were checked and the weight history noted. It was found that as per his height, his ideal body weight should have been somewhere around 58, but he was lesser on the weight, which was 47 as of now. His waist circumference, hip circumference, and the mid-arm circumferences were noted and measured. As you can see here, there was a clear decline in his weight. It had improved in between in 2016. However, after that, there has been a gradual decline in his weight, though it had never gone down to 45, but he had never improved on his weight to 58, which he had achieved in the month of September 2016. His dry body weight was checked. The dry body weight is very, very important for us as dietitians. It is a good indicator of the nutrition status of the patient. The better the dry weight is, the better the nutrition status of the patient. So this is a formula here for checking the dry weight of the patient. So for this particular patient, the dry weight was taken. His actual body weight was 47 into 60, which is the normal percentage of water, which comes to 28.2. 28.2 into 142 with the sodium levels gave us the range of 29.4. And this excess body water was calculated, body weight was checked by the formula of ATBW by the NTBW, which came down to 45.6. So if you want, you can just see the formula back again here. Okay. So this is how we get the dry weight of the patient, which is checked in terms of the actual serum sodium level of the patient and the liters of the fluid intake of the patient. So as per the history, it was found that there was a gross difference in the patient's weight before dialysis and after dialysis. His intradialytic weight was assessed, and as you can see here, there was again quite a difference between the intradialytic weight gain of the patient. The higher the difference is, the more deleterious effects it is for us. So we have to try to reduce the gap, and we have to try to reduce these peaks and try to maintain the dry weight of the patient as far as we can. Okay. Domain 5 focused on the nutrition and the physical finding of the patient, and it was observed for the fat content of the patient, the oral health of the patient, the appetite of the patient, and the swallowing, or the sucking or the breathing ability of the patient. So it was observed that there was no pedal edema and the skin was normal. However, the clavicle bone picture showed clear indication of malnutrition, muscle wasting. There was no history of nocturnal urination, of melena or hemoptysis or joint pain or hematuria or oliguria. No complaints of chest pain or dimness of vision or headache or giddiness or unconsciousness or tingling. And there was no observation of impaired hearing. The body composition of the patient was done. However, now with the increasing pandemic situation, body composition is becoming a difficult concern right now, and therefore the skin fold measurements are being done. Dr. Ashwini Kalkar in her presentation will be talking in detail about how these skin fold measurements can be done to assess for the body fat percentage of the patient. Though it is not an accurate, 100% accurate when the patient is doing it himself, but still it is something which can actually help us give a better data about the patient health. The oral examination was done, and there was no deformity found at the dentures or at the tongue. There was no specific complaints about sucking, swallowing. However, the patient did complain of mild breathlessness on and off, and patient did complain of low appetite, of course. So based on all the assessment, the next part which we come to in the NCP process is assessing the patient or giving him the score for the malnutrition. So for that, in CKD patients, we can use various types of tools. One such tool is the SGA, that is what we call as the subjective global assessment. The SGA is based on the 7 questions, and for each answer, a score is given, and depending upon the score, the patient is categorized into degrees of the malnutrition. As you can see here, with the 7 being the minimum score, the maximum being the 49. If the patient has a score of 1 to 14, it means that the patient is well nourished. If it is 15 to 35, the patient is mild to moderately malnourished. And if it's 36 to 49, the patient is severely malnourished. In addition to the SGA is called as the MIS. So MIS is called as the Malnutrition Information Score, which takes into consideration the 7 questions of the SGA, but they also add 3 more questions to the SGA, which talk about the BMI, which also talk about the serum albumin, and which talk about the total RN binding capacity also. So again, the MIS has various components to it, 0 being the normal and 3 being the severe, and the patient is scored out of 30 for all the answers. So this patient was assessed for the SGA and for the MIS both. So for the first question, the patient had a weight loss of 5 to 10% in the last 6 months and therefore was given the score of 3. The dietary intake was semi-solid and therefore the score was 2. For the GI, because there was nausea, the score was 2. For functional capacity, because the patient was doing light activity, therefore the score was 4. For comorbidity, because the patient had been on the dialysis since less than 12 months, the answer was 1. For physical examination, because of the moderate loss of the subacute, the answer was 4. And for the muscle wasting, because you could see the clavicle, at the clavicle you could see the muscle wasting, the score was 4. And therefore the total score of the patient came to 20, which indicated of mild malnutrition in this particular case. Again, if we assess the patient based on the MIS score, because of the weight loss for more than 5%, the score is 3. For dietary intake, because it is suboptimal, the score is 1. For GI, it is 2 because of vomiting and moderate GI disturbances. For functional capacity, because it is limited, the score is 1. For physical activity, because the patient is on dialysis less than 1 year, the score was 0. The patient had a moderate loss of subacute and therefore the score was 2. Because of muscle wasting, the score was 2 again. The BMI was 1 between the range of 18 and 20. For the laboratory parameters, the albumin was 3.5 and therefore the score was 1. And for TIBC, because it was less than 250, 249 and therefore the score was 0. So the total came to 15 and that 15 actually again gave us the impression of moderate malnutrition. So based on both the tools, the patient was actually categorized as having moderate malnutrition. So therefore the summary for the assessment was that his SGA score was 20, his MIS score was 15, body fat was lesser, muscle mass was lesser, body weight was lesser, his intrahepatic weight gain was more than 4%, which is actually not correct. He was normoglycemic and on not any potassium binders. However, he had a clear case of anemia. There was no case of complaints of swallowing and constipation, low appetite. He was eating deficit and was not on regular food intake. His lack of knowledge about the food had also impacted his intake. And he had just misconceptions which actually need to be tackled. And also his relatives had to be counseled, or the immediate family had to be counseled about the do's and don'ts of the dietary intake. So therefore, the diet prescription should be was formulated based on the parameters of the uremia, because we had to focus on the better uremic control. We had to focus on improving the appetite. We had to work on declining the progressing renal function, deterioration of the progressing renal functions, control the comorbidities, hypertension, prevent PU, improve the nutritional status, and maintain good hydration of the patient, reduce metabolic acidosis, and reduce inflammation oxidative stress. So therefore, I would not talking about the guidelines here, but these are the KDOQI guidelines. Based upon the assessment, the patient was initiated on the diet. This was a diet which was planned for the patient. He was put on almost around 35 kilocalorie per kg body weight diet with fat as 30%, carbs at 50 to 60%, and the dietary cholesterol intake was reduced to less than 20. The protein intake was worked up upon 71 grams. And of course, with the keto analogs, the diet, the pattern changes completely. So finally, salt restrictions was advised, phosphorus restriction was advised, potassium education was given to the patient, calcium education was given to the patient, and he was also asked to improve his dietary fiber intake, but more of soluble fibers again here, not the insoluble fibers. So finally, to summarize, an assessment of inadequate intake does not always lead to nutrient deficiency. Inadequate intake should be considered in combination with many other factors like the diagnosis, the biochemical reports, the anthropometric measurements. Bioactive substances, those who do not have the DRIs should be evaluated and should be given or introduced depending upon the patient requirement. And the diet plan should always be customized as per the patient requirement. And finally, we have to determine appropriate data to collect. We have to identify the need for additional data. We need to have a proper choice of what assessment tools and procedures we are going to use to assess the nutritional diagnosis of the patient. And also we should be having proper procedures to actually use those tools. And we should be able to identify appropriate comparative standards. And we should be, of course, depending upon proper relevant data where we are using, and the tools should be validated and should be practical to use. Thank you. Sir, you are on mute mode. Dr. Sareen, you are on mute.
Dr. Sareen, would you unmute yourself?
Am I all right now?
Yes, sir.
Hello?
Yes, sir, you're audible.
Hello?
Sir, you are audible.
Dr. Anita, can you hear? Yeah,
Yes,
so
we
that
can
was
hear
very
you.
well covered.
Yeah, we can hear you.
Yeah, I can hear you, sir.
For a single patient, and I'm very glad you spoke. Even our vegetarian patients are advised by friends and relatives not to take dal. Imagine dals. Even dals, they are told not to eat. Yes. And fruits and vegetables with seeds. So, you know, there's a lot of negative propaganda and that don't eat this, don't eat that. I'm very glad that you covered this aspect very well. Okay, we'll move to the next. I don't know whether Dr. Sunil Prakash has arrived, or we'll have Dr. Ashwini Ukalkar, who will talk on assessment of nutritional status in patients with chronic kidney disease, practical tips for day-to-day management. Dr. Ashwini Ukalkar.
Thank you, sir. Please give me a minute to share my screen. I hope all of you can see my screen. A very good morning to one and all. At the outset, I would like to thank the organizers and especially Dr. Anita Saxena for having included me in this August list of faculties. I'm really pleased to be here, ma'am, and to contribute to this Nutrition Society in any way that I can. Also, thank you for guiding us so much during the publication of our paper. So I have been allotted the speaker assignment of assessment of nutritional status in patients with CKD, practical tips for day-to-day management. Although I'm a pathologist, I am very much involved with the patients that come to our hospital and regularly interact with each of them. And I have often noticed that it's a group of ladies, usually the males are the patients, and the ladies' relatives, they just sit outside and gossip, and then they interact and exchange recipes, or they exchange unnecessary tips like not eating dal, etc. Especially when a new patient is added to the pool of patients that we have, everybody pounces on him and is the doctor in charge, or is the Google expert, or is the WhatsApp expert, and they are the nutrition experts too. So in order to avoid all of this, we have extensively implemented nutrition care process in our hospital. We have tried to, and I'm grateful to Ms. Shraddha Kulzade, who is our current dietitian, for having implemented almost all of our desires onto paper. So having said this, I will start with my talk. I will be speaking on the nutritional needs of patients of CKD, which are very specific, and also how we screen for risk of malnutrition in the patients of CKD. Dr. Himani has already covered extensively the patient history, nutrition history, and a part of the focal physical assessment which is required in CKD patients. I will also cover a part of the laboratory assessments and the anthropometric measurements which are to be taken. And finally, I will demonstrate through a case to you how we do it using the Nutriem in our hospital. So CKD patients have very specific needs, and be it energy, be it protein, be it carbohydrates, be it potassium, sodium, fibers, there are very specific targets that we can achieve, and which is a good thing, because quality improvement like the PDCA cycle only comes from setting targets, setting goals, and then trying maximum possible to achieve those goals. If we don't have targets, then the patients are at a loss. Eat more dal. What does eat more dal mean? Exactly, you need to measure the dal that is being eaten and give him a target that this is much more that you will have to do. With that, it becomes easier for patients who are compliant, and they easily follow the instructions which are given to them as per the dietitian's prescriptions. If we have everything in the air and just say, okay, eat more dal, eat less leafy green vegetables, and avoid potassium, do leaching, well, that's very subjective, and it really helps no one. So the very first step in our journey of nutrition care process begins even before the assessment. It begins with a risk assessment. That is, when a patient first walks into your domain, what do you assess for the risk? Whether the patient is at risk of developing a severe malnutrition, a moderate malnutrition, or a mild malnutrition, or no malnutrition at all. For example, a patient who is exposed to acute stress, like acute on chronic CKD, or even acute kidney injury, or the patient who has had a surgery immediately. These are the cases where, or he is in diabetic ketoacidosis or some such complications, sepsis, pneumonia. These are the patients who are going to suffer and are severe risk of malnutrition. The other category of patients are those who have poor socioeconomic histories of either social care, caregiver burnout, and other situations in which the patient himself cannot comply with the requirements of the dietetics and is dependent on his immediate caregivers to provide the same. But these two are not able to give it to him due to different various factors. And the mild malnutrition occurs in those who refuse to do behavioral changes. Despite knowing that dal is required or the protein intake is reduced, they refuse to comply and continue to with their behaviors. For example, we had a patient of dialysis who for many years used to finish his dialysis and go across the street to the best samosa wala and have a samosa after every dialysis. So much so that the other patients started envying him. But this behavior pattern was not at all allowable, and despite different counseling methods, he did refuse to budge. Anyway, that story I will tell you some other time. So what are the nutrition screening criteria that we commonly use? When the patient walks into the OPD, the average person asks, oh, was there any weight change? Did you drastically lose weight in the last 6 months, more than 10% perhaps? So the patient will come up with histories that, yes, my blouses are ill-fitting now. My pants are loose and my belts are tighter. I had to change the whole of my belt size. Okay. There are other indicators that we use, like do you have persistent nausea, vomiting? Do they have any bad bowel habits, either diarrhea or constipation? And also chewing and swallowing difficulties. Then one goes to the laboratory data of albumin or hematocrit and so on and so forth. So these are commonly ad hoc used nutrition screening criteria. But there are better nutritional screening tools like the rapid nutritional screen, the Aspen's adult nutritional screening and assessment algorithm, the Duke University's nutrition screening form, and a trademarked tool, mini nutrition assessment, which is used by Nestle. These are but a few, and I have not given the screenshots of those because these are trademarked and copyrighted. And since I haven't taken the permission, so I haven't used these. But Basically, there should be a screening first of the nutritional risk to the patient, followed by which it is important to take a detailed patient history. Here, it's important to note that the nephrologist very often helps us, the dietetics department, because he himself has bothered to take a lot of the history for you. So whether it's chief complaints of breathlessness or edema feet, which indicates fluid overload, or accelerated hypertension, or whether there is increase in nausea, vomiting, or whether there is some diagnostic procedure to be performed like IVP or otherwise, whether there is any other medical therapy that's going on, the patient has uncontrolled blood sugars, whether there's a consistent family history of any congenital disorders like Alport syndrome or otherwise, and also whether the patient has a good oral healthcare history or not, and the medications. So the history taken by the nephrologist on the first visit of the patient would probably be a good guide or a good resource for a dietitian to take care of. Following this, one is expected to look into the medications of the patients. Most patients have a prescription which is 1 page long. And I really mean it's 1 page long, because nephrologist has to take care of the bone mineral metabolism, the anemia management, the fluid management, vitamin deficiencies, and so on and so forth. And finally, what does the dietitian do then? The dietitian is expected to inquire about medications which have potential food and drug interactions. For example, warfarin is a very good example of this, where green leafy vegetables and cabbage, which contain a high level of vitamin K, will interfere with the actions of warfarin and in fact enhance the actions of warfarin, which you don't want. Similarly, ciprofloxacin, if given in the ICU setting through a Ryle's tube, it may clog the Ryle's tube and cause blockages. There are many such examples. One is also expected to find out whether there are drug-induced metabolic alterations. For example, there are many drugs which cause an altered taste, like metronidazole, which gives a metallic taste. And our patients commonly have diarrhea. It's very common amongst the patients of CKD on dialysis. Or there may be appetite changes. For example, insulin, which is again commonly used in diabetics with the CKD. Insulin causes a sudden increase in appetite. Okay. Similarly, there are drugs which cause dry mouth or nausea, like chemotherapeutic agents. So you may have a patient of RCC with later on CKD, and he may also be given chemotherapeutic agents. Or you have the difficult to treat nephrotic syndromes, which are given endoxan therapy, and these again may have dry mouth and so on and so forth. Also, it is important to note that some of the drugs may cause potassium alterations, sodium alterations, like usually general practitioners like to prescribe Lasix or Lacilactone, which is a potassium sparing diuretic. And so very often we find that the patients who come first time to our clinic are usually told to avoid these and to use torsemide instead. So in short, you will have to find out whether there are any drug and food interactions and whether there are any side effects due to the metabolic alterations due to the drugs provided. We commonly use softwares online like this drug bank, in which you can see that warfarin has been selected as the drug and the food interactions have been shown. I know we don't use grapefruit products, but we definitely use vitamin K foods like leafy vegetables, which can reduce the warfarin efficacy. Also, similarly, we use a software called drugschecker.com, in which there is a drug-drug interaction report. Sorry. Here I have chosen nifedipine, which is a commonly used calcium channel blocker, and calcium acetate, which is a common calcium supplement used for CKD patients. And here you can find that not only the interactions between the drugs is being seen, that is, there is a moderate level of interaction between nifedipine and calcium acetate, but you can also find out that there are drug and food interactions between nifedipine and certain products. Patient history has been covered in detail by Dr. Himani Puri. But here I would just like to point out once again that it is the social history which is very important. Is it an elderly couple coming for dialysis, living alone with NRI children? Is it a person from the Rajiv Gandhi scheme or the Mahatma Jyoti Phule Yojana scheme who is living in a small chawl or a one-room tenement and has no specific caregiver for him allotted to him? Is it someone coming from far away? We have patients coming from 300 kilometers far away from Nagpur and who travel all the way just to attend the dialysis and then go back again by the evening bus or train. So these kind of histories are very important because they will determine that every second day that he comes for dialysis, is he able to maintain his 24 hours diet at that time or not? There may be history of certain recent crisis. Today is the day of COVID-19. And all of us know, even in the morning today, one patient called and said, I'm asymptomatic, but my COVID-19 positive report is there. What should I do? So there is recent crisis. We had a family in the early days in March 2020, where the lady tested positive, the patient, and 9 members of the family also tested positive, and everybody was quarantined. Now, who's going to look after the lady's dialysis and the lady's nutrition? Obviously, when she was admitted at the medical college where the only dialysis facility was available, there was no option, but whatever food was provided was consumed. So we have to keep in mind all these things when we are taking care of the patient or taking the history, social history of the patient. Also, the nutrition history is important. The current nutrition status, whether the patient is on a semi-solid diet, a soft diet, or he is able to consume full-fledged diet. Also, the appetite of the patient, whether it's fair, whether it's bad, the satiety level, the snacks consumption, like I explained to you, there was a patient of samosa eating episodes. Then whether there are any fat diets. There are many who take alternative therapies and they are told, prescribed along with that a certain specific diet, that you only drink these fluids or you only drink this kind of kadha and things like that. But we should be aware of all these. There are different methods of obtaining a good diet history, and these are subjective as well as objective. Unfortunately, the nutritional biomarkers which are commonly discussed, that is pre-albumin and transferrin and ferritin, these are not routinely done except once in 3 months or once in 4 months in a clinic. Sorry. So we go on to the subjective methods which are commonly used. The estimated food diaries and weight food diaries are not commonly used, but the 24 hours dietary recall is definitely a tool which can be, should be, and could be used by every nutritional assessment expert. There are also food frequency questionnaires that we can use. For example, in our hospital, we often try and find out the potassium intake of patients specifically, or the protein intake of patients specifically. That, like Dr. Ukalkar has shown you, a large number of patients do suffer from protein energy malnutrition in the unit. And despite them walking in and walking out of the hospital for their dialysis. What I mean to say is they look and feel good, but actually they have protein energy malnutrition. There are also many apps available, like he has said earlier, which are technology assisted dietary assessment tools. And we will shortly see one of these. So coming to the 24 hours dietary recall. Now, how exactly do we do a 24 hours dietary recall? I know there are many dietitians here, but there aren't many dietitians here either. Some like me learned along the way, and this is how I learned it. So a 24 hours dietary recall method is intended to capture detailed information about the foods and beverages consumed by a patient in the last 24 hours. In the US and the UK and the Australia. In the UK, they found out that 4 repetitions of dietary recall were adequate enough to find out the dietary nutrient pattern of consumption. In the Australian study, they found that there were 8 repetitions required for dietary recall before you could say safely that this is the nutrition pattern followed by a patient. In the US, they follow only 2 recalls. One is a one-on-one interview, and the other second recall is taken on a telephone by another person and just recorded. So here again, open-ended questions are asked and specific questions are asked. What does the dietary recall tell us? The dietary recall tells us a large amount of information. It tells us specific nutrients which are consumed by the patient, his dietary patterns, his dietary habits, his comparison between the same individual. You take a dietary recall now, you take a dietary recall 1 month later, and you find out the difference in the consumptions. Also between patients, like we have analyzed earlier. So how do you exactly conduct a dietary recall? So the timing should be from the last meal onwards, backwards. Some people say it should be from midnight to midnight, but I have found this method better. That suppose it's 4 p.m. now and I'm taking a dietary recall. So I'll start with the lunch that was consumed last, then go on to the breakfast or mid-morning snack, then the dinner before, and then the evening snack and lunch. So from lunch to lunch, I have covered 24 hours. Ideally, it should be done dietary recall for nearly 3 to 7 days, but try asking yourself only, what was the sabji that you ate 4 days ago? And I'm sure none of us will remember. So you should try and take a dietary recall as much as possible, as many times as possible, to really record what the patient has eaten. And then the dietary recall is to be followed by quantifications. Quantifications are very important. Just saying half a katori of dal is not important, because his katori might be very much bigger than your katori, and then we are all in trouble. So household measures may be kept by the side of the dietitian. In fact, I have seen dietitians who have cutouts of the size of the roti. They have specific measures like spoons and other things. And most importantly is the multiple pass approach. This is what I'm talking about. These are the ready-made measures that we can use. But a patient usually doesn't remember, or even the wife usually doesn't remember whether the tablespoon she used was this size or that size, or was it this much dal or that much dal. I found this measuring tool using hands. And yes, I think it is useful, but I have not validated it yet. But yes, we do have patients who say ki itna sa dal khaya ya itna sa dahi khaya tha. And itna sa dahi, I presume, would be 1 inch as per this chart which has been given. But we'll have to find that out soon. So what is the multiple pass method in the dietary recall? First is a quick list, to collect a list of the foods and beverages that were consumed during the previous day. This is followed by probing for forgotten foods, specifically, like I said, for proteins or maybe potassium, or maybe sweets that he may have eaten. And if there was a specific time and occasion, like we are in the month of Ramadan, definitely the patients who are observing the fasting of Ramadan would be having a different consumption pattern from the pattern that they usually follow. So it would be important to ask them at the outset, are you on the fast? We should record the details of the cycles, that is the consumption of the quantities, the methods of cooking. Are they using leaching? Are they using any other style? What are the brands of foods purchased? Like Dr. Ukalkar pointed out, NutriGuide is a good method in which you can scan the barcode and you can actually find out the level of salt, carbohydrates, proteins, fiber, etc. in that packaged product. And then a final probe to just check if anything else you have left out. So what does the dietary recall tell you? It gives you exact portions in grams. It matches all the food ingredients with the food composition table. And from this food composition table, one can then find out the exact level of nutrient intakes. So this is a chart that I took from the India Environment Portal. And this has been validated by the National Institute of Nutrition, Hyderabad, in which each item, like for example, jowar, you can see exact amount of protein content, exact amount of fat, fiber, etc. is available. This is another very nice tool which is given by the ICMR, National Institute of Nutrition, Hyderabad, in which you can count what you eat. The portal itself says that count what you eat. So they have two options. You can either put in recipes like dosa or idli and sambar, or you can put in exactly like I have put in here, wheat and bread. So I took 10 grams of wheat bread and I found out what is the total protein intake that I have consumed. Now this is where Nutrium comes in. For example, this patient's nutrient pattern is evident after the dietary recall. And one can see at the bottom, there are graphs showing her carbohydrate, protein, and energy intake for breakfast, for mid-morning snack, for lunch, for afternoon snack, for dinner, and for supper. Now, if you notice the protein content specifically, which is the green column, you can immediately see that the large amount of protein is taken in only at supper time and not during the day, which is I find very strange. So this patient needs counseling to change her habits and to actually consume the protein during the day, so that 2/3 of the protein intake is completed by 4 p.m. and then only a small 1/3 portion remains to be consumed at night or in the evening snack. Why I'm saying this is because many patients who have low appetites, they do not consume the amount of protein or energy required during the daytime. That's when they're awake, right? So when the patient is awake and he doesn't consume what is expected of him, then is he going to consume it at night when he's fast asleep? No, definitely not. So we have to be after a patient right from the morning and encourage him for the morning breakfast, for the mid-morning snack, for the lunch, and for the post-lunch evening meal, snack if possible, so that 2/3 of your requirements are consumed by them. So 24 dietary recall, however, this does have some disadvantages, and that is mainly recall bias. Like I said, do you remember the sabji we ate 4 days ago? Or social desirability bias. There are patients who are educated by Google and they want to say, yes, I've eaten a lot of protein. So they will say yes, yes, yes to everything that you ask. Observer bias. I may be focused too much on protein and therefore it's detrimental to the assessment that I take. A physical examination then is the next important step, and a general examination of the patient gives us a very fair idea of the nutritional status. This again can be obtained from the nephrologist notes. One may not do a detailed physical examination. You can just rely on their notes. But what is specific is wasting, muscle wasting, and the second is the oral hygiene and status. Here clearly it's seen that a patient has very bad hygiene in teeth, and therefore obviously is not going to be able to consume the food that he can or is expected to. So similarly, hair, teeth, gums, everything has to be checked whether there is any evidence of malnutrition. What are the laboratory assessments? These are in tandem with the laboratory assessments that nephrologists ask for. Albumin or pre-albumin, serum creatinine, sodium potassium electrolytes, hematocrit, a whole range of the anemia profile, and fasting lipid profiles. Some of these tests are done on a monthly basis and some of these tests are done on a 3-monthly basis. It depends on the protocol of the unit, which tests are done when. But whenever the tests are done, as Dr. Himani has earlier showed you, you must prepare graphs of these tests and you must monitor whether the tests are conducive to the progress of the patient or are they retarding the progress of the patient. This is our dietitian Shraddha. She's hard at work measuring, doing the anthropometric measurements. So what are the measurements that we commonly take? We do a BMI, we do a dry weight measurement, estimate, triceps skin fold thickness, a mid-arm circumference, and a mid-arm muscle circumference. Dry weight has already been explained to you by Dr. Himani. Here, I just want to caution people that when we were calculating the caloric requirements of patients or protein requirements of patients, we kept the dry weight in mind while doing these calculations. I don't know again if this is a validated method or not, but I found it logical. That is, the edematous weight is not to be considered as the weight for calculating the protein intake. It will go wrong. But the dry weight definitely we can consider. So here is a very small video of how to take the triceps skin fold thickness. So we have the vernier calipers. There are the skin or the subcutaneous tissue is pinched, and then you measure exactly. The arrow here shows where there is a how many millimeters it is. Now there are different sites in which the estimation can be done. Common is the triceps skin fold thickness, but the other.
Dr. Ashwin, can I interrupt you?
Yes, ma'am.
Time is up. Yeah.
I'm so sorry. I will just finish fast. So SGA rating, as Dr. Himani has again said, and finally Nutrium. I would just like to show a few glances of this Nutrium software. We get an estimate of the macronutrients and the micronutrients, and a typical analytics will tell us the energy protein distribution. Thank you so much.
Thank you, Dr. Ashwin. Very well covered. And I think we have the last speaker now in this session, Dr. Ashwin Dhabi. Appetite assessment, tools in general practice, and in the ICU setting.
I'm afraid.
This should be very interesting, the ICU setting, yeah.
No, I'm afraid the Dr. Ashwin Dhabi is not able to join us. So Dr. Anita Jatana is taking this talk on appetite assessment tools in general practice and ICU setting.
Fine, fine, okay.
You may introduce Dr. Anita Jatana, please.
Yeah, Dr. Anita Jatana is now going to speak on appetite assessment tools in general practice and in the ICU setting. It'll be very, of course, general practice is important, but the ICU setting is a major issue. So I'm glad, I'm sure she will deal with it very well. Please go ahead.
Please unmute yourself, ma'am.
Can you see the slides?
Yes, yes.
Yeah, all right. Good morning, everybody. And thank you, Dr. Saxena, for this opportunity. And Dr. Sareen, I loved it when you said that we have so many wrong fads about diet, and we have actually patients who come to us with a nil protein intake because somebody told them stop dals. That's one simple thing that is told to them, and that's the beginning of the story. So we've heard lovely lectures today. Screen. Video. Next slide.
Can we, ma'am?
Yeah.
Can we go to the full
So
slide
we have,
mode?
yeah. So we have the huge problem of malnutrition. We've been hearing that since morning, and obviously it's disease related, and it actually gets worse by the time the patients leave the hospital due to long fastings and people not eating on time. So all that generally happens a lot. So the statistics says that 25 to 40% in hospital inpatients are already malnourished, 15 to 25% in home care because nobody is assessing them there, 20 to 25 in nursing homes, and 15% of the malnutrition patients receive nutritional treatments. That's just about half of them or even less. So in order to diminish the negative consequences of disease-related malnutrition, it is of paramount importance to recognize malnutrition patients at an early stage. So that we've all been hearing how to assess patients and things. So when Dr. Anita Saxena told me that I'm going to be speaking on assessment tools of appetite, we ask them these questions, but then we don't sort of address them at all, and we don't document them. So I had to do a lot of study myself, and we came across a lot of things. So we know anorexia-related weight loss can have devastating consequences on life, morbidity, mortality. I think it's all been talked a lot. And in the elderly, it's even worse because they lose weight very fast. And the complications of anorexia-related weight loss include frailty, falls, fractures, compromised immunity, and pressure ulcers. So they have the denture problems. So they have other added problems because they can't eat. They have GI problems. They can't take milk. So all that also happens in the elderly. So with a simple tool to evaluate appetite, I think we can do better. And healthcare providers often use inaccurate surrogates such as measurement of energy consumption and nutritional risk. So we've been seeing all those assessment forms, which are time consuming, but which I think most hospitals are now doing because of JCI and all these things that are now happening. For the newcomers, just a quick this thing, we all know what hunger is, appetite, aphasia, hyperaphasia means overeating, orexia, satiety, when you stop eating the moment you sort of had a meal, the feeling of satiety, the craving, that always happens even with sight of food. The picker, I think, is more with the pregnancy and the polyphagia and the anorexia which follow, which is the loss of appetite. So coming to appetite, it's a desire to eat food. Believe me, when the patients fuss about food, I wonder why are they fussing? There's a meal there, there's so many items. Why can't they eat something out of the tray which has come to them? But if you're on the other side of the table, and which I just went through, believe me, it actually puts you off. The sight of food also gives you nausea. And that's when the anorexia definitely is there and you have a decreased desire to eat. So brief period while you are recovering from an acute illness will be there, and you recover the moment your medicines decrease and your temperatures are better and you're much better. But there are long-standing chronic illnesses like CKD where anorexia definitely affects them more. CKD and maybe the high urea creatinine levels, which also affects. But we all know hypothalamus plays a central role for maintaining the appetite along with different nucleopeptides. So just to show diagrammatically how it matches, how important it is, this part of the brain that lies below the thalamus contains many centers for neural control such as temperature, hunger, appetite, and thirst. Now, is it just a simple thing as appetite? Is people just fussing about it? But if I go through this whole thing, I think my 20 minutes will be over. But just to say, the leptin is produced by the adipose tissue, plays a central role in the long-term maintenance of weight homeostasis by acting on the hypothalamus to decrease food intake and increase energy expenditure. Then we have the GI peptides, ghrelin, glucagon, somatostatin, cholecystectin, satiety signals, and thus decrease food intake. Hypoglycemia suppresses insulin, reducing glucose utilization and inhibiting the satiety. So there's so many, hormones, and we have the variety of cytokines, including tumor necrosis factor A, IFNY, and the leukemia inhibitory factor, which is LIF. So together, this cytokine storm definitely increased production of leptin from fat stores. Mechanism of weight loss includes decreased food intake, malabsorption, loss of calories, and increased energy requirements. Hence, loss of appetite directly related to weight loss. So we know this whole thing circle is a complex situation, and just not that the patients are fussing. Mechanism of weight loss includes decreased food intake, malabsorption, loss of calories, increased energy requirements. We all know that the energy requirements are higher, so there's a loss of appetite. Food intake may be influenced by a variety of visual, olfactory, and gustatory stimuli. Seeing a good picture, seeing a good attractive tray makes a lot of difference to a patient's appetite. So physiology is hunger. We all know that the hormones of the hypothalamus we just discussed in details, and the contraction cause a tight feeling in the stomach and cause pain known as hunger pangs. So going over the different afferent mechanisms, quickly I'll go over them. There's a lipostatics hypothesis, which says the adipose tissue produces a humoral signal that is proportionate to the amount of fat acts on the hypothalamus to decrease food intake and increase energy output. Gut peptide hypothesis, which postulates that the food in the GI causes the release of one or more polypeptides that act on the hypothalamus to inhibit food intake. Glucostatic hypothesis is increased glucose utilization in the hypothalamus and produces a sensation of satiety. Thermostatic hypothesis, fall in body temperature below a given set point stimulates appetite, and the rise above the set point inhibits appetite. So all these factors all contributing to a simple thing like an appetite, which we take it for granted when we are fine. The physiological influences, definitely gastric contractions, absence of nutrients, endorphins, dopamine, which we just heard, we heard ghrelin. Then sensory influences, seek food and start a meal, the thought and sight of food. Sometimes it's just the aroma of a pakora frying, you're not hungry, but you suddenly feel an urge to eat. Advertisement of a chocolate on a TV, you're not hungry, but just the thought of that or the sight of it gets you wanting to eat that chocolate. So these are all things which definitely influence us, the cognitive influences, the time of the day, the clock definitely works. The post-indigestive influences, the satiety, when you have had a meal, even the sight of food doesn't make you hungry or you be wanting to pick up a food. So if you snack on wrong foods in between your meals, you'll not be able to eat a normal meal. And the post-absorptive influences, a heavy meal definitely stays for a longer time, especially when you have fried foods, because the fat stays longer and carbohydrates get digested faster. So when you have a very heavy meal with proteins and carbs, it stays a longer time than just a carb diet. So all these are influencing factors. So these are the factors that I've just discussed. The decrease in blood glucose concentration is associated with development of hunger. The effect of blood amino acid concentration on feeding, increased concentration of amino acids in the blood reduces feeding activity. Effect of fat metabolism, which I just said, as the quantity of adipose tissue increases the rate of feeding, decrease this is caused by the negative feedback regulation and the body temperature and food intake interval. So we all know that also when we have fevers, we are down, and the temperature outside also has a thermostatic effect on the hypothalamus. So wait for the older people, you've seen the aging of the peripheral appetite signaling molecules, aging of the gut, aging of the sensory perception, and the social environment factors. So the elderly are more affected. It's the anorexia of aging which affects them more, leading to undernutrition, sarcopenia, and frailty, and we have the negative outcomes. So the elderly people have to be really closely monitored more than the younger groups, sorry. So anorexia we know poses life-threatening complication, and that is why it needs to be captured early. causes malnutrition, abnormal heart rhythms, low blood pressure, dehydration, electrolyte imbalance, amenorrhea, osteoporosis, sleep disorders. So keeping this in mind, I think these new forms have come up which should sort of catch the appetite problems earlier and avoid the problems. Causes of loss of appetite are changes in metabolism. We just heard the handful of medications and the long prescription list that these patients are on. And they have the unpleasant sight and odors, the anemia, low blood count, the medical treatments, the chemotherapy we all know, and pre-exist as a primary condition owing to depression, social isolation, and advanced stage. So these are patient barriers, the system barriers, and the clinical barriers, which totally all lead to the loss of appetite in patients, and just not that they are fussing. So these are the appetite tools, which I've taken a picture of from the Google itself, the self-assessment of the appetite. It's a qualitative, very descriptive, and the simple answer as reduced tells you that the patient is anorexic. Then we have the VAS, quantitative. There's a 0 to a hunger scale. I'll be talking about it in more length. Anything less than 50 is anorexic. The functional assessment, the FACT score, 12 questions related. Each question is on a 5-point Likert score with a 0 to 4, and anything less than 30 is positive to anorexia. And we have the anorexia questionnaire, which is simple 4 questions. And if you have one positive answer, that means you are diagnosed as having anorexia. Very, very simple tools, can be done. I wonder how many are doing it. We've not adopted it yet, but we are doing a lot of mini nutrition assessments and other tools. But having gone through it, I think it's really worth taking this forward. So these are the assessment tools, time frame of reference, and patient appetite versus appetite over the last month. Subjective assessment of appetite is 7 days. The VS, at the moment it is completed, it tells you the present appetite with a line of scale of 100. The FACT score at the moment it's completed, you get the answers, and the anorexia questionnaire, the moment it's completed, it gives you the answers. So anorexia questionnaire is this, was developed as a rapid qualitative tool for diagnosis of anorexia associated with chronic diseases, including ESRD. It investigates the presence of 4 main factors: early satiety, taste, smell, meat aversion, nausea, vomiting. 4 simple questions anybody can answer. Any patients reporting at least one of these symptoms are considered to have anorexia. So AQ, this is the self-assessment appetite changes. During a 30-day period, patients were asked to compare the present appetite to the appetite over a month old. So, you want to know, is it decreased over this period or is it just been the same? Then it's fine. And then we have the subjective assessment of appetite referred to the last week, increased, same or decreased. A simple question again was performed according to the first question of appetite and diet assessment tool as previously performed in hemodialysis. This qualitative tool may prove effective in routine monitoring of the efficacy of the anti-anorexic therapies that are adopted when the patient is having this problem of appetite. So this is a simplified nutritional appetite questionnaire. So the first one was developed by the Council of Nutritional Appetite Questionnaire, which is a CNAQ, which is of 8 questions, and anything less than 28 points indicates poor appetite. Again, the questions are very simple, can be done by anybody there, doesn't need very qualified people. And simplified nutritional appetite questionnaire was developed using only 4 of the parameters, which is my appetite, food taste, number 4, number 6, normally I eat. So just these 4, and when I eat. So only these 4 are taken, and a score of 14 indicates risk of at least 5% weight loss within 6 months. So from the same questionnaire, 2 have been developed. One is a CNAQ and an SNAQ. Simple things again, very simple tools to adopt. So visual analog scales is a reliable tool to evaluate hunger and satiety at point of food consumption, consists of a life of 100 mm. The extremes anchored to no hunger, 0 mm, and hunger was administered. This tool allows a quantitative measure of appetite. And now the Zabel et al. Has, earlier there was a no cutoff point, but now they said anything 50 mm is indicative of anorexia. So a 50% cutoff point is indicative of a visual analog scale. So this is how it is done. This is what it looks like. So it says greatest imaginable hunger, and at the end of the scale, it says absolute fullness, even though you've not eaten. So it's beautifully shown here also to a layman, yeah, I'm not, the food is there, I'm not hungry, and when I'm absolutely full and I'm not feeling hungry, though you may actually not have a meal. So very well visually shown. So functional and assessment of anorexia, cachexia therapy of FACCT score. The functional assessment score recently developed by the European Society of Clinical Nutrition and Metabolism is based on the subset of in particular, the anorexia, cachexia subscale. So again, the score consists of 12 questions related to appetite and food intake and allows a qualitative and quantitative diagnosis of anorexia. Again, it's got a 5-point, and a total score of 30 was considered to indicate the presence of anorexia. So what causes decreased appetite? Various reasons are illnesses. We all know cancer patients are on the worst. We have patients with GI, pneumonia, colitis, skin infection, meningitis. I think anybody who's going through an illness will have a problem. But these are ones which are more chronic, and CKD is another problem. If the ammonia creatinine starts rising, it affects them badly. And if the dialysis is not well done, then again, it's another problem. So these are pharmacological approaches. I'm not getting into it. We have the medical team who addresses it if required. I know steroids definitely make you hungry. I've just had a small dose of it. I was literally eating the whole day and wondering what's happened to me. I became a glutton. So these are medicines that can be used if you really find it. But for us as a nutritionist, keep meal times as snacks flexible. Don't give them a meal when, give them in between meals. Let them not skip meals. Give them good nutritious snacks, especially at bedtime, and leave it with them at the bedside once they're in hospital. A good environment. I don't know hospital how much is there, but the tray should look appetizing. That's the way. That's why we, think of colors when we are planning a menu. There's a little red, a green, and a yellow on it. So it looks more appetizing than a yellow tray with everything yellow on the tray. So all that definitely visual will have an impact. Frequent meals coming up rather than one complete meal, where the patient gets overawed by that huge tray which comes on them table. Eat healthy, high protein, high calorie snacks in between, and eat foods which are more calorie dense. We teach them, in small quantities, how they can add paneer to that small quantity of pudding, so that what he's eating should be really calorie and protein dense rather than, have a katori of maybe a porridge which may be having nothing in it in terms of nutrition. And give them good nutritious in between meals, some drinks rather than plain water. This will also get them to, increase their food intake. There is some science behind using Indian gooseberry, ginger, black pepper, small cardamoms, and ajwain, which we've been using from our kitchens for a long time. And we see definitely good results. You can definitely, they are digestive. Ajwain is known to have digestive properties, so can be used for these patients. So management of poor appetite in patients with CKD, which is a chronic problem. Appetite worsens with progression of kidney disease, leading to malnutrition. Nutrition status is an important factor in dialysis, we know that. And the fear of a low protein diet while they were in CKD does not go away. So once a dialysis started or transplant has happened, they just cannot take that they can eat normally and they can improve on their protein intake. That fear phobia stays for a very long time till it's reinforced that you have to increase your protein intake now that the dialysis has started. So it's really touching base with these patients more often and hand-holding them, which will show results. So assessments, again, duration change in oral intake, assess for specific food aversions, glycemic control, fluid balance, depression, anxiety, nausea, constipation. There's a BCPRA symptom management resources. I'm not going to get into it, but it was started in 2014, and this scale is also there for the dialysis patients. This is what it looks like. So everybody can download and see what it is. It's hypertension, medications, and all the CKD patients can be assessed using this scale. So I think my time is running out. We've just seen how it affects, and the CKD patients are affected: depression, anxiety, appetite scores, screening, treatment, malnutrition, all interlinked, and we definitely have a huge problem. So I'm finished right on time. This is my last slide. No single appetite assessment tool corresponded best to all the criteria measures. The FACT and the VAS had the strongest association with low self-reported food intake. The anorexia, according to the VAS, was also associated with low NPCR. These instruments may be useful in clinical setting for assessment and monitoring of appetite in hemodialysis patients. However, these instruments were less associated with changes, and inflammatory biomarkers are definitely also required in addition to these tools. Thank you.
Thank you very much, Dr. Anita.
Yeah.
That was very well spoken, very well, a lot of practical tips. Can you hear me?
Yeah, I can, yeah.
Yeah. So very well spoken indeed. A very exhaustive subject covered very well in this short span of 20 minutes. So, Dr. Anita, Dr. Anita Saxena?
Yeah, hi, I'm here.
Do we have any other speaker? Dr. Prakash?
No, not the session. So you can just wrap up the session with a little bit of panel discussion. Dr. Rana is not available because he's busy with his hospital work. And so
is this a question answer session or anything?
Yeah,
or
yeah. Yeah, you can, in case there are any question answers in the chat box, just have a look, or else you, along with the speakers, if you like to give some more.
Yeah, I want to ask anybody, Dr. Anita Jatana, or anybody, we know about the potassium-rich foods in our CKD patients, for example, citrus fruit, juices, nuts. Are there any, and banana, are there any other foods in our daily dietary regime which we should avoid in patients?
Yeah, I think I'll give you a little personal experience now. Because of COVID, a lot of patients have started doing turmeric water. So I had one patient where he came with a very high potassium level. I had eliminated all the foods as you just listed, but his potassium still went on to be high. And we realized that he was doing a lot of that turmeric water. He was literally boiling a concoction. And the moment we stopped that, his potassium came down.
So turmeric is rich in potassium, is it?
All spices are very, very high. So when we tell them low salt, but use, all these flavors from these spices, we have to tell them with the word of caution that they are also high in potassium, to use them sparingly and use them just to enhance flavors. So it's not a free food. So everybody was doing a lot of turmeric because of COVID, and these patients were also at risk. So they also followed the guidelines, what you've been reading all over, that turmeric water helps bringing up the immunity. So
one more question I have. Our Indian patients are, most of our patients in North India are vegetarian. So when patients are on dialysis, can we make a vegetarian diet comparable to non-veg? Because I want my dialysis patients and my post-transplant patients to eat a lot of protein, fair amount of protein. Now, is a vegetarian, how do we make a vegetarian diet comparable to the non-veg diet?
Dr.
Or do you say, is it comparable?
We tell them to use dals. I can't help that because, we don't talk of A-class protein, but we do give them a lot of curds and milk products. And there was, I think Dr. Anita Saxena only presented, no one other. When you give them hunk curd, then the phosphorus gets leached out. So, and then the quantity also becomes more. And you can give them more of hunkers where the phosphorus is there, the fluid intake won't happen. So using that, we definitely are able to achieve the protein requirements.
We can also opt for whey proteins. I mean, though it's a supplement formula, but yes, whey protein also is better absorbed, and they also give us a good protein quality. Soya protein in the form of soya isolate is good, but using soya beans or soya chunks as it is does not actually account for, because they do not have a good biological absorption.
And they have very high phosphates.
Yes.
Yeah, but
soya. So we should avoid soya?
Yes, soya.
Can I just chip in?
Yeah,
Actually, because human beings do not express the enzyme called phytase, which is required for absorption of phosphorus. So plant food is definitely far better than animal food, because the phosphorus, even if it is high, it's absorbed only to a tune of 40 to 50%. Whilst if the patient is on animal diet, animal protein, about 80% of phosphates will be absorbed. So it's always better. Soybean is not a contraindication. It is, in fact, a much better protein than anything else. So if you want your patients to have a good amount of protein along with less of absorption of phosphorus, soya proteins are advisable. My question to Dr. Anita Jitana. Dr. Anita Jitana, you just said that you had a lot of patients coming with hyperkalemia because they were taking concoction of turmeric. So is it the turmeric as a whole? Because we know that we are using curcumin lozenges. Curcumin is the active yellow compound of the turmeric, and curcumin is cardioprotective. It is also renoprotective. It is anti-inflammatory and antiplatelet and all those things. So we are actually encouraging patients to be on curcumin rather than taking turmeric as such, because turmeric, if they have to take amount of turmeric to help them with cardioprotective effect or for renoprotective effect, has to be about 3 teaspoons a day. So that is a lot of this. So what would you advise your patients to go for? A curcumin, which is a concentrate, which is the active compound, and not to go for the turmeric powder?
Dr. Anita, I'll have to really see what is the potassium levels of that. But we don't stop our patients from taking turmeric in their food or taking a pinch of it. But this particular patient was overdoing it. So that is what was causing his problem. So we don't stop our patients from using spices. We don't talk about it at all as a potassium or phosphorus or anything. We tell them normal food cooking, enjoy your food, and we give them a lot of variations in their menu. I don't even stop their rajmas or peas. I just tell them have everything, unless the uric acid is really crazy for some time.
Just to add on here, curcumin extract usually does not have much of potassium in it.
Potassium,
so yes,
that's what I'm trying to.
Yes, they can be used as a replacement.
Yeah, that's what I'm trying to convey, that turmeric as such, the entire powder, we should not encourage. Rather, the curcumin, which is the yellow active compound of turmeric, should be advised to the patients, because it is cardioprotective and it is renoprotective. It is an antioxidant also. So it's very good. And turmeric as such, if it is taken like the way we do, it is not, the bioavailability is not about 100%.
Yeah,
it's
it's
about
not.
60%.
But Dr. Saxena, if you take it with milk, that is see how it today is
yes,
an answer.
and with little bit of
It's
pepper.
better absorbed when you take it with the fat. So don't take it with water. So what we're doing it in vegetable and all, it's not playing the purpose that we want. So that is why that haldi doodh wala phenomena still works today. So today we have an answer which we didn't have earlier. So how much of curcumin, since we're talking about it, is your advice to your patients for curcumin?
See, curcumin is 2% of the weight of turmeric. So it's a very small amount, very small
so
amount.
How much are we advising? So we could use that maybe.
See, the lozenges that we are using should be given at least twice a day.
Okay, so you've got a specific one. All right.
Yeah.
It's really available.
Oh yeah, if you want to have a look, this is the one. Turnover.
All right.
These are not to be chewed. These are to be sucked. This is delicious. It's absolutely delicious. It's just a very nice peppermint flavor, and it is very effective in absolutely everything.
And you don't have to take it with milk. It doesn't need a fat.
No. It has to be sucked. These are lozenges, so they have to be sucked. Yeah.
Oh, great.
Can I just add to one of the questions that Ashok
Thank you
was
very
asking
much.
previously? Sir, you were asking about the salt intake, the potassium intake there. So sometimes what happens, we have observed that there are many patients who come to us with a low sodium salt, like the Lona salt or the low sodium salts available in the market. And actually the patients end up having a high potassium level because of that. So that also needs to be checked when the patient is coming to you.
Yeah, these are unknowing.
Lona salt should not be taken. They are high in potassium. Yeah.
So this is self-education that we have from our patients and their relatives and their friends.
Okay.
So can we wind up
any
this
other
session
queries?
Now?
Are there any other queries? Okay. Then thanks a lot to all the speakers and
Dr. Sarin.
extremely.
Thank you, Dr. Anita.
Right.
Thank you very
thank
much.
you.
And we shall now close the session.
Yeah.
Thank you.
Thank you, Dr. Sareen, for moderating this session, and thank you all the speakers. The theme of our course this time is feeding well in chronic kidney disease. I think we start on the right note. We've been discussing about appetite. We've been discussing about the various tools for appetite. So now we are going to move on to the next session, which is on CKD progression. So may I invite Dr. M.K. Mitra to moderate the session. Dr. M.K. Mitra is consultant nephrologist and he was former head Department of Medicine, King George Medical University, Lucknow. He is a pioneer in nephrology, and also the way he treats his patients when it comes to feeding them, it is like he's just the right person to talk. He will convince you in not stopping your patient from eating anything. You just give them a month's dosage that this is much is required. Now you can do whatever you like. So right now he's a consultant nephrologist at the KK Hospital. Over to Dr. Mitra.
Thank you. Can you hear me, Dr.
Yes, sir. Yes, sir.
Thank you very much. First of all, congratulations to you for holding this advanced course in nephrology, dietetics and nutrition. And to you and the whole team of nephrology, including Dr. Narayan and the whole team. I congratulate you and also thank you for letting me in as a moderator for this important session. Thank you. Now the first session is, the first speaker would be Dr. Bhaumik. And Dr. Bhaumik is the professor, Department of Nephrology in the All India Institute of Medical Sciences, New Delhi, a very well-known figure in the field of nephrology in the country and abroad. And he would be speaking on dysbiosis and CKD progression, a very interesting topic, which is, dysbiosis being discussed in many situations, including that nephrology. Over to Dr. Bhaumik. Dr. Bhaumik, may I request you that you may please stick to 20 minutes time. And thank you very much. We are over to you.
Thank you, sir. I hope I am audible. Am I audible, sir?
Yeah, you are audible. You are audible.
I'll share my screen, sir. Good morning. Please excuse me for my bad throat and fever. So if there are any lapses, I'll try to make a quick presentation. I thank the organizing committee. It's not moving, the slides.
I wish you a very speed.
Oh, thank you, sir. I'm not able to move my slide. Can anyone help me, please? Yeah. So this morning I'll be speaking about dysbiosis and CKD progression and give a brief overview of this topic, which has now come into the limelight. So the normal colon receives about 1.5 liters of liquid effluent, and the proteins, there are about 6 to 18 grams of proteins and 20 to 60 grams of carbohydrates. And there's a large population of microbiota in the colon. So we'll speak about their role in dysbiosis and renal failure. So the healthy adult GIT harbors about 100 trillion microbes, and this is 10 times more than the number of cells in the human body. They are sterile at birth, and the baby colonization occurs during birth and thereafter. The gut microbiome is about 3.3 million genes, and they constitute bacteria, archaea, and eukarya. The anaerobic phyla, the Bacteroidetes and Firmicutes, mainly the Clostridium, they constitute more than 90% of bacteria. I'll show you a cartoon. And this microbiota is influenced by several factors. These include gender, ethnicity, immune status, nationality, age, very importantly, their diet, their geographical location, alcohol, and drug consumption. So there are many factors which influence which microbiota will take predominance in which individual. Here we've listed the microbiota in alphabetical order, the actinobacteria, which has the corynebacterium, the Bacteroides and the Firmicutes, they constitute 90% of all the microbiota and they are anaerobic. As you'll notice here, this constitutes the bacteroids, the Prevotella, which are very important, they're the good bacteria, the lactobacilli, and the Clostridium. And then we have the Fusobacteria, the Proteobacteria, and the Vericomicrobiota. So this is the whole spectrum, and let us, as you can see here, the stomach has very few. It is mainly Lactobacillus and Helicobacter. It is 10 raised to the power 2, that is just 100 to 1000. The duodenum has Lactobacillus Staphylococcus are about 1000. The jejunum has about 10,000 Lactobacilli and Enterococcus. And then as the environment becomes more and more anaerobic, the number of microbial organisms, they increase. So in the ileum, you have 10 raised to the power 7, Enterobacterius, Bacteroides, and Clostridium. And in the colon, which is a very large number, more than 10 raised to the power 12 microorganisms, constituting the Lactobacilli, Actinobacteria, Bacteroides, Clostridium, Fusobacteria, and Firmicutes. And as you can see, the normal stool has about 10 raised to the power 14 organisms per gram. So that's a huge number. And these microbiota weigh about 1.5 to 2 kilos, if you take it by the kilograms. They live in a symbiotic relationship with the host. The host provides them the anaerobic environment and the nutrition. And the microbiota, in their own way, they contribute in many ways. So as you can see, they help in the gut motility. And this is very important because as we'll see that in CKD, the colonic transition time increases and leading to constipation. They help in absorption of the complex carbohydrates. They are a very important source of micronutrients, and I'll talk in detail about the short chain fatty acids. They make the vitamin D, B components, vitamin K, which is required for vascular health and bone health, and some amino acids as well, and they make some antibiotics. They also form the secondary bile acids, and they play an important role in the immune system as well, balancing between the Treg cells and the T helper cells. Now coming to the short chain fatty acids, they are formed by the saccharolytic fermentation of the non-digestible complex carbohydrates. As I said earlier, the colon receives about 20 to 60 grams of carbohydrates depending upon the fiber richness of the food. Few amino acids can also lead to formation of these short chain fatty acids. There are mainly three: the acetate, which is 60%, butyrate, which is 15%, and they're very important, and propionate about 25%. The colonic cells themselves, they receive 70% of their energy from this oxidation of the short chain fatty acids. So they're very important. And this butyrate fortifies the intestinal barrier by forming mucus and the tight junctional proteins. They also enter the blood and act on the adipocytes to modulate host energy homeostasis. And they inhibit the production of the pro-inflammatory cytokines. So as you can see, the short chain fatty acids are of immense importance to us. I also said that about 6 to 18 grams of proteins enter the colon, and actually proteolysis of this leads to formation of uremic toxins, and this is mainly in the distal part of the colon. The saccharolysis occurs mainly in the proximal part of the colon. So in this cartoon, again, the same thing is shown, that how the amino acids, some of them can form SCFAs, and the complex carbohydrates, they lead to formation of the SCFAs. And they are a major source of energy for the colonocytes and the Treg cells. So this is the most important part of the slide. So as Professor Mitra mentioned, that gut dysbiosis is implicated in the pathophysiology of many chronic diseases, including diabetes mellitus, cancer, asthma, obesity, as well as chronic kidney disease. This is a complex mechanism, and this happens because of metabolic acidosis, immune dysfunction, oral iron use, uremic toxins themselves. So it's a vicious cycle actually. Frequent use of antibiotics, intestinal wall congestion because of volume overload, uremia alters the microbiome composition and epithelial barrier of the gut, and that is the gut-kidney axis. And as you can see here, dysbiosis in CKD is a vicious cycle. Now, what happens in CKD? First of all, there's reduced diversity, and I'll show the importance of this reduced diversity. So it's not a simple question of some good are reduced and some bad are increased. The diversity is very important. This is very important to remember. And this diversity is reduced in CKD. There is anaerobic bacteria overgrowth, and that is the increased enterobacteria, Acinetobacter, Firmicutes, and Clostridia, and decreased bifidobacteria and the lactobacilli. So as you can see in this very recent study here, they've shown that better the survival when there is higher diversity, and you have lower survival when you have lower diversity of the intestinal microbiota. And this is in a cartoon form again, as you can see here, that the Clostridium, they are increased very much, the lactobacilli are reduced, the Prevotella are reduced in CKD. Now, this interesting study, I thought it was quite interesting. They found that this dysbiosis actually occurs early on in CKD. So they studied the patients throughout the 5 stages of CKD, and they found that dysbiosis occurred early, and thereafter, there's not much change actually in the microbiota. So whatever change occurred early and then remained more or less stable. So as I said that the carbohydrate-based microbial metabolism reduces, and that leads to reduced short-chain fatty acid formation because of reduced saccharolytic end products. The protein-based microbial metabolism increases, and that is because of reduced diversity and because of the harmful bacteria leading to formation of these toxins, which you'll see in the subsequent slides. And that leads to CKD progression. Now, having understood the microbiota, let us see which are the gut microbiome derived toxins. Now, they can be classified as the free water soluble low molecular weight toxins. What happens is, because urea increases in the gut as a result of CKD, and this urea is converted by urease possessing organisms, which actually increase in number, and that leads to the ammonia formation. And ammonia is immediately converted to ammonium hydroxide, and that increases the gut pH. And that is very harmful. The other low molecular toxins include the methylguanidine from creatinine, homocysteine, and the D-lactic acid. The protein-bound solutes include the precresyl sulfate, which occurs as a result of the bacterial metabolism of tyrosine and phenylalanine, which form actually precresyl, and then they go to the liver, and then precresyl sulfate is formed. And this is the harmful uremic toxin. And similarly, bacterial metabolism of tryptophan, that forms indoxyl, and that is again sulfated in the liver to form the indoxyl sulfate. The other uremic toxins include indole acetic acid, phenylacetic acid, and the hippurate. The other very dangerous uremic toxin is the trimethylamine N oxide, and this is mainly from the animal-based foods, which contain choline, betaine, L-carnitine, and phosphatidylcholine. They form the trimethylamine, and that leads, in the liver, it's converted to the TMO. And these are very harmful, which lead to loss of the intestinal barrier integrity and also the tubulointerstitial fibrosis. Studies have shown, I've not quoted all the studies, that high levels of precresyl sulfate and indoxyl sulfate at baseline shows a worse CKD progression. And worse than that, they also have a worse CV outcome and all-cause mortality in patients of chronic kidney disease. So just to summarize, the important uremic toxins which are formed in the gut is indoxyl sulfate, which comes from tryptophan, the PCS from the egg, meat, and fish, and the TMO. And as you can see here, reduction by hemodialysis occurs, but only partially. The other important thing apart from these toxins is the bacterial endotoxins themselves. So the endotoxin is basically a phospholipid in the outer membrane of most gram-negative bacteria. And this translocates across the gut. They complex with the toll-like receptors and they lead to formation of the inflammatory cytokines, leading to atherosclerosis and CKD progression. And we'll see what happens subsequently. So as I mentioned earlier, this gut epithelial barrier is extremely important. And butyrate, which is one of the very important short chain fatty acids, it promotes production of both mucin and the junctional proteins, and thus contributes to the gut epithelial integrity. And as you can understand, when their formation is reduced, the integrity is harmed and they become leaky. And as a result, gut-derived bacterial DNA fragments and lipopolysaccharides are detected in the blood. So this mucus is extremely important and it covers the endothelial cells in the lower GIT. And the permeability of the intestinal epithelium is controlled by the tight junction proteins, which I mentioned earlier. These include the zonocludins 1, occludin, and the claudin 1, which are good, and claudin 2, which actually causes the pore formation. And in CKD, you have overgrowth of the bacteria, which reduce formation of the short chain fatty acid, especially butyrate, thus leading to a leaky gut. And in this, the ammonium hydroxide formation, which I showed you earlier, plays a very important role. So this paracellular movement leads to movement of the DNA fragments and endotoxin, and thus GIT is a very major source of systemic inflammation and oxidative stress. And that's why you have increased CRP levels and interleukin-6 in the blood of CKD patients. They also have reduced Klotho, which leads to overall cardiovascular disease and overall mortality. So put it here in this slide that there is in renal failure, there is urea accumulation in the body fluids, this urea influx into the gut, and urease possessing bacteria, they form ammonia and ammonium hydroxide, which is very dangerous. This leads to disruption of the epithelial junctions and the barrier, thus leading to influx of the endotoxins, leading to local and systemic inflammation. Same thing in a cartoon form, as you can see here, that there's reduction in the short chain fatty acids because of abundance of the proteolytic bacteria. Right? You have less of the saccharolytic bacteria. There's reduced gut motility. There's malfunctioning of the epithelial cells and loss of mucosa and the uremic toxins which enter the gut, which can be reversed to some extent, which will be spoken of by the subsequent speakers. This is from a latest review again, which shows the same thing, that a dysbiotic gut microbiota leads to CKD progression, and it is actually a vicious cycle. So what is the role of inflammation in immune activation? As I said, there is gut inflammation and systemic inflammation. In fact, human autopsy studies of uremic patients way back in the 80s showed that the whole gut was inflamed. And that time they were not sure why that was happening. But now we understand why that is so. And so why there is gut inflammation and there is systemic inflammation. And as you can see, this is actually an animal study where rats were nephrectomized and then some probiotics were given. And as you can see here, in these rats, they found when they took the biopsy of the colon, there was decreased HSP70 and claudin 1, which I mentioned earlier, increased claudin 2, leading to increased gut permeability, as seen here. And maybe there was some reversal after you give them some probiotics. Similarly, with the empty stain, they found that there was increased fibrosis and urine protein creatinine ratio increased in these rats. Coming to a few specific renal diseases. Sorry. So in diabetic nephropathy, there is increased E. coli, Shigella, and decreased lactobacilli and bifidobacteria. There's reduced short chain fatty acids. These patients have higher serum precortisol after adjusting for renal function and increased blood levels of phenyl sulfate from tyrosine. And it has been shown in various studies that it leads to inflammation within the kidney. So there is kidney inflammation, and the tubulointerstitial cells as well, they promote fibrosis, and the podocyte damage and albuminuria also occurs. So there is definite evidence in diabetic nephropathy. What about lupus? Lupus studies have been done, and as we know that basically the two T cell subsets in the lemon appropriate, I mentioned earlier, the T regulatory and the Th17. And Th17 causes antimicrobial peptides and neutrophil recruitment and cytokine formation. And the Tregs avoid excessive inflammation. And butyrides help in the Treg expansion. So this balance is extremely important. And they found in this classical rat model that there is marked depletion of lactobacilli in the gut, which may be reversed by the lactobacilli. And these beneficial effects were seen in the female and castrated mice, not the male mice. So this gut microbiota controls lupus nephritis in a sex hormone dependent manner. This was the conclusion of their study in a rat model. What about IgA nephropathy? This is actually quite obvious, because we know that the gut IgA plays a very important role in initiation and progression of CKD in IgA nephropathy. So the IgA nephropathy patients have gut dysbiosis, and this leads to disruption of the intestinal barrier, and experimental mice have also demonstrated this. So finally, in this slide, you can see here that in a healthy state, when there's a healthy microbiome, there is good production of enough short chain fatty acids. It leads to development of very good lymphoid tissues. There is enterocyte cell surface receptors. The balance of Th17 and Treg is maintained. There is production of antibiotics and bacteriocins, and the appropriate class switch occurs. Whereas in CKD, there's an altered microbiome, and that leads to immune-related kidney diseases. And as I mentioned about diabetic nephropathy, where there's podocyte damage, IgA nephropathy, and lupus nephritis. So to summarize, the normal gut microbiota play a very valuable role in homeostasis, both gut and systemic homeostasis. The CKD leads to upregulation of the microbiota producing uremic toxins. And on top of it, there is disruption of the gut epithelial integrity as well. So it is a double hit. So you have the wrong microbiota and a leaky gut. That leads to gut and systemic inflammation. It leads to renal inflammation as well and tubulointerstitial fibrosis. The CKD progression, which has been shown in diabetic nephropathy, lupus nephritis, and IgA nephropathy. And based on this pathophysiology, it's possible that once we've understood this pathophysiology, we could help in preventing the progression of kidney disease. I thank the organizers, the scientific committee of the
Thank you, Dr. Bhomik.
And Dr. Anita Saxena. Thank you very much.
Sir, can I say something?
Yes, madam.
Dr. Bhomik, I'm really grateful to you. He's down with COVID right now. And with the kind of sore throat and high fever, I really commend that you were able to deliver the lecture. It was excellent. And I'm really obliged that you really did it.
It is a
great
privilege.
favor.
It is a privilege. I'm thankful that I could at least speak.
Yeah,
something.
I must also thank Dr. Bhomik. Wish you a very, very speedy recovery.
Thank you, sir.
In spite of your illness, you have contributed so immensely here. And you have mentioned about the relationship of CKD and dysbiosis, which is bidirectional, as you have mentioned. And you have very interestingly pointed out about the role of dysbiosis in the progression of diabetic nephropathy, lupus nephritis, and IgA nephropathy. A very lucid talk. Thank you very much.
Thank you, sir. Kindly be excused now.
Thank you. Thank you very much.
Sir.
Dr. Anita, should we go ahead now? Dr. Anita? Should we go ahead?
Yes, sir. Please, the second talk.
Second talk? Yeah.
Yeah.
Second talk is of, a review of clinical trials on dysbiosis in CKD, Dr. Sanjay Srivastav. Sanjay Srivastav is named the Center for Kidney and Diabetic Care, Bangalore, Chief Nephrologist and Transplant Physician at Suguna Hospital, Rajaji Nagar, Chief Nephrologist at Shirdi Sai Hospital, Associate Professor Nephrology Department of Saptagiri Institute of Medical Sciences, and the Center for Kidney Disease, Diabetes in Bangalore, the hospital and institute affiliation. Over to Dr. Sanjay Srivastav for your talk of review of clinical trials on dysbiosis in CKD. I again remind, please stick to time, 20 minutes, and so that we have good discussion at the end. Over to you.
Good morning to all, and I thank the scientific committee and in particular Dr. Anita Saxena for giving me a chance to be in front of you. And in this difficult COVID times in Karnataka now there is a lockdown in Bangalore. So I am at home and trying to deliver the lecture to you. Am I audible clearly, madam?
Yes, yes, you are audible.
So I'm thankful for Dr. Bhaumik, who had given a perspective of how the CKD progresses when there is dysbiosis. Now, if you look at the progression of the nephrology in the field of nephrology past 2 decades, we have been doing maximum things only in transplantation. So it is over the last half a decade or one that we are looked into gut and its role in the progression of the CKD. It's interesting because we may be preventing many of them going into stage of end-stage renal disease. It has taken such an importance that even the newspapers have started reporting about the role of gut microbes and their role in developing major diseases. Now, in short, what Dr. Bhaumik had said, if you look, as human, we started as gatherers and then went on to become, non-vegetarians by killing or hunting. And towards this part of the century, it is more of processed food. So our gut has gone a lot of change, the kind of food that it is exposed to. To start with, because of the acidity of the nature, the organisms are less in the smaller intestine. It tends to build up towards the larger colon, because when you are a gatherer, you eat a lot of plant products and the gut motility is high. And it goes and stores itself into the colon, and it is the colon where the complex metabolism happens. And this is the reason why colon used to be with lot of bacteria which were helpful to the gut. And as the processed food and non-vegetarian diet has increased over a period of time, we see a great change with CKD setting in. And you see that more lower species coming in, and more of organisms are also found in the duodenum and the jejunum. Now, this is the normal gut, which was shown earlier by my previous speaker. You see there is an integrity of the gut that is maintained. And this integrity is very important, because if there is a break in this integrity, it induces inflammation, which is a major factor for progression of CKD. Now, if you look at the factors contributing to dysbiosis, there are numerous factors. And we also use many of these factors to treat CKD. For example, use of antibiotics, oral iron, the acidotic nature of the state, and the gut wall edema all adds to it. And then in what happens when there is a dysbiosis, there is a break in the continuity, and the toxins move in, they induce inflammation. In the end, the cycle is this, what we see. There is an inflammation which predisposed to cardiovascular disease. There is an inflammation which leads to progression of CKD, and also leads to insulin resistance and protein energy wasting. So this has been dealt. It was just an introduction. So now let us go into the targeted intervention in dysbiosis. What we can do. What we can do is probably modulate the gut microbiota, try to bring it more close to the normal as it is, and then help indirectly to attenuate the inflammation that the patients may have. In general, we use probiotics and prebiotics. Probiotics, as a definition, are the live microorganism which may be of health benefit to the host, and prebiotics are the stabilizers that are put in to potentiate the growth of these organisms, and also to give stability to the organisms. And a combination of these two, when we use it, is called as symbiotics. That is a combination of prebiotic and probiotic. Now, let us see whether we had any preclinical animal trials. Now, this trial was done by my team only, and where we looked at the role of nitrophage 4, which is a commercially available group. Now, I'm trying to figure out, because we use the combination which is there in this rather than any general combination. And here we looked at gentamicin-induced nephrotoxicity in the rats. And we divided the rats into 5 groups, where 3 of the groups used symbiotics in different blends. and the first two group for the controls. One is a positive control, one is the negative control. And if you look at the blends that were used, and this is a 30 billion in the blend one, where in a different concentration of lactobacillus, bifidobacterium, and streptococcus. Similarly, blend 2, again 30 billion, but in a different concentration for lactobacillus and bifidobacterium. And we tried to see whether the higher doses will help or not, with 50 billion dose in the third group. So group 1 was intraperitoneal saline injection, which is a control group, and the group 2 was gentamicin, was injected into it 100 milligrams per kg intraperitoneal for 12 days. And group 3 has various blend with gentamicin. So what did we see on a histopathology once the rat was sacrificed? And you see, this is the normal control where saline was given. Here the kidney looks normal. In the positive control where we use gentamicin, you see, as expected, there is severe necrosis of the tubules and there is a destruction. When we come to blend 1, there is a degree of destruction which is there, but it is comparatively less. Now, if you see the control group, which was gentamicin used was 100 milligrams, whereas when we used it on the other study group with blend, it was around 500 milligrams. So 5 times the dose. In blend 2, you see it is more or less the normal state, the very minimal damage to the tubules. And when we look at blend 3, again, there is an extensive damage. So what we found in this is the blend 2, which has around 30 billion units, coliforming units, showed a better response and its ability to withhold the destruction. And when we looked at the hematological reports also, blend 2 showed that the creatinine, burn, and urea were much more closer to the normal compared to the other groups. So what we found in this study was that it was effective in the rat model and it was very dose specific. If you look at the first study that came out, it was Natarajan's, Ranganathan's study, which came out and published in 2010. They looked at very small group, 5 centers, 4 different countries, and their study group was very simple. It was a crossover study, 3 months of, the product tested against placebo. So the side effects were very minimal. It was bloating, flatulence, and diarrhea in 10% of the patients. And what did they found? They found that 43% of the patients showed a decrease in creatinine, 63% in the bun. Remember, they only showed decrease in the creatinine, but what was the degree of decrease? It was not shown. I'll show you in the other study. So if you look at the quality of life index, which they were calculated over 1 to 10 scale, 86% of the patient responded. When they look at the fecal pH also, the one which were given the symbiotics, they showed a decrease in the pH and more towards the normal. The same group looked at the dose escalation, and they looked again, it was a 3 and 4 stage CKD. 28 patients completed out of 31, and they gave 30 billion first month, 60 billion second month, and the 90 billion third month. Again, the response was same. Creatinine was improved, and there was a reduction in the bun. But the degree of reduction was not. Whatever the p-values you are looking at, it is at the number of patients who showed the improvement. And there was one more study which was published in 2016. Again, they looked at only 31 patients. And this study also, they found that the PCS, that is peak cresol and the indoxyl sulfate reduced when the antibiotics were not used in this, a subset of this group. So in the end, what we came to know, if you are using antibiotics in association with this symbiotics, probably the effect comes down. This is a synergy study, again looking at the toxins, that the p-cresols and indoxyl sulfate. Again, the number of the patients was small. If you look, those who completed was just 31 patients in this group. And what did they find? They also found that the total indoxyl sulfate and the total p-cresol levels reduced. And it was more so in antibiotic-free completers rather than the patients who also required antibiotics for various reasons. And this is one study which was done by one of my colleagues, Mr. Pawan. He looked at around 24 patients in stage 3-4. He just gave the drug and looked at what happened to the creatinine at 12 months. He also showed that there was a slowing down of the progression of CKD by around 3 ml per year. Now, so all these studies just show that it helps reduce load of toxins. The role of retardation of the progression in the CKD still it is questionable because the number of the patients that were used were very less, and larger studies needs to be done. And one thing was sure, that if you use antibiotics along with that, probably it may not help. So it reduces the efficacy of the symbiotics. Now let us look into other. Now we have come into a stage where we are thinking that inflammation is the major factor which is leading to the progression. And we look at probiotics and anti-inflammatory effect. Now many studies have come forward which have shown that inflammation is one of the major factors for the progression of the CKD. And do we have any studies? Yeah, this study was done by me. It is called as a NIFTY study, which got published in 2017. And I want to give little details on this study because this is the first study from our country which looked into the inflammatory markers and the role of symbiotics. So this was a NIFTY trial. And it was a prospective open-label intervention study to evaluate the safety and efficacy of this nitrophage 4 in CKD 5D patient. I took the 5D patient because the various stage, earlier stage patients may not come to you regularly, or they usually go shopping, so may not be considered. So I looked at those patients who are on dialysis, not doing well on twice-a-week dialysis, or not doing well on thrice-a-week dialysis. We know that dialysis is an inflammatory state. So we looked at a sample size of 48 at our center, and we wanted to look at basically its role in the anti-inflammatory effect. That is, we looked at HSCRP, IL-6, and TNF-alpha. We also looked at improvement of the quality of life by assessing the SF36 and SGA scoring. Now, the inclusion criteria: whoever above the age of 18 years, written consent they should have given, and stage 5 CKD, undergoing twice-a-week dialysis, or those who are undergoing thrice-a-week and are not doing well. So exclusion criteria: any infections, any inflammatory state were excluded, and study was cleared by our ethics committee. Now, all these preliminary data were collected: height, weight, BMI, triceps thickness, SF36, SGA scoring, and investigations were done. And first analysis was done at the time of inclusion prior to dialysis, and patient was asked to take the symbiotic containing 30 billion CFU half hour before food mixed in water. And patients are advised to store the sample in the refrigerator because these are organisms and has to be maintained at a cold temperature so that their efficacy is maintained. So let us look at the study. What happened? Of the 48 patients, 38 patients completed the study. That is completion rate of around 79%. 4 did not complete the study or lost to follow-up. 5 did not take medications as per protocol. 1 patient was already on the same drug, so he was excluded. Treatment was given for a period of 6 weeks. And 1 patient, there was an improvement in appetite that he gained 12 kg. I'm not talking of the liquid weight. I'm talking about the general weight. His muscle mass increases significantly. So we actually had to stop. He was concerned, so we had to stop the treatment after 4 weeks. Side effect: bloating was seen in 2 patients. Rest all tolerated well. Now look at the results what we got. When we look at the HSP in all these patients, so there was an improvement, but the p-value was not significant. Now we tried to split the results and see what happened. See, 61% of the patients showed a reduction in HSCRP. So if you look at these 61% of the patient, there was a significant reduction in the HSCRP, and the p-value was significant. Now, when you look at IL-6 in all patients put together, you will not get the significance. But when you look at all those who showed a response, that is 46% of the patients showed a decrease in IL-6. When you looked at the significance, the p-value was probably would have got better if you would have continued it for a longer time, but definitely there was a reduction. When you look at TNF-alpha, around 56% showed a decrease, and it was significant. When you look at those who showed significant decrease and look at their values decrease, it was significant. So this is in the bar graph. And other factor is the weight gain. We want our patients to have a good weight gain. When you look at the weight gain, a significant 17% increase in the weight gain was recorded in terms of the muscle mass. And there is an increase in the albumin level by around 10.3%, and this is over a period of 6 weeks treatment, which was significant. I want you to concentrate on the parameters which are more important. That is, which determines the cardiovascular morbidity and mortality. Look at all the parameters of the cholesterol. LDL cholesterol decreased, triglycerides decreased, total cholesterol decreased. The HDL cholesterol increased, and all was statistically significant over this 6 weeks period of therapy. So, with all these parameters, now we looked at what happens to the SF36 scoring. SF36 scoring, you see the sleep pattern had improved in this patient and was probably going to become significant if you had continued it for next few weeks. there is an improvement in the general health, there is an improvement in the pain threshold of the patient, and the energy and the fatigue. That means the patient was getting more physically active. So to conclude with this study, we found that there is a reduction in the inflammatory status of these patients. There is an improvement in the lipid status, which may transform to improved cardiovascular outcome later. But improvement in the CV outcomes, again, we have to do a larger study. Improvement of the quality of life is there. Probably we need to continue it for a longer period of time. And its role in retardation of the progression, still we are not sure, because at present we are talking of only inflammation. Probably we may have to use it for a longer period of time. Now, one more thing which the paper I'm going to publish in another few weeks is its role in itching and Chiarel's disease. You know, when we started off, we saw that causes of itching in our 10 years back, we was told it is high phosphorus, high calcium phosphorus product, high PTH levels, and inadequate HD as one of the factors contributing to the itching. When you look at the DOPS phase 5, now the factors responsible for itching has been changed. Now they say that older the age group, higher the HSCRP, low albumin, hepatitis B. So these are all the factors which are contributing to higher inflammatory status that we think are responsible for the itching and development of Chiarel's disease in our group of population. So presently we feel that there is no great association of itching with calcium phosphorus product or PTH or KTIAV. Now, I'm sorry for the poor quality of the picture, but you see this patient whom we use, there are 2-3 patients in whom we use the Chiarel's disease was very bad, but this is over a period of 3 to 4 weeks, it started improving. And look at the hands in this patient and see what happens after 4 weeks. So this is in general, you know, there are not a great many studies, and even if the studies are there, the numbers are very less. And to take out a message that probably it is going to retard the progression of the disease, it is too early to tell that. But one clear-cut evidence what we have got now, they do have a benefit over reducing the inflammatory state of the individual, which in turn may translate into a better quality of life, better cardiovascular outcome, and probably a retardation in the progression of the disease when we looked at it at a longer period of time. So as of now, the take-home message, role in retardation of progression of the CKD, we are not sure. It has an anti-inflammatory effect. It probably improves the cardiovascular morbidity risk factors. It improves the nutritional status of the individual and improves the quality of life, which you have documented in 2-3 studies which you have seen. And it has been shown to be beneficial for resistant pruritus and Chiarel's disease. And one most important thing I want to put it is very dose specific and it is very strain specific. So all may not work, and it is very important that we when we market it, it has to be marketed with cold chain to be maintained. Otherwise, you lose the efficacy of the product. This is what I want to say. Thank you.
Thank you, Dr. Sanjay Srinivasan, for this very, very lucid talk. Congratulations.
Thank you, sir.
Work that you have also done, and you have shown your own work, so-called NIFT trial, and before that another trial in which you had done, and Dr. Ranganath. And in your NIFT trial, you showed that there was a definite beneficial effect of prebiotics and probiotics in reducing inflammatory state, as shown by decrease in TNF-alpha, IL-6, and CRP. And
Yes,
the increased weight gain, albumin level, which you know are very important markers for overall health. The lipids also improved, which was a very important slide, and that also shows that this will be also a protective effect on the cardiovascular system. And we know that end-stage renal disease is a very important risk factor for cardiovascular death. And again, and the last one that you mentioned was the itching. Right? Itching is a big problem in most of our patients. And what you have shown a very gratifying result. And congratulations to you for an lucid talk, Dr. Srinivasan, and doing that great work, research work. Thank you.
Thank you, sir. So can I put in just 2 lines?
Yeah, please.
So one thing is, I'm very, Madam, just 1 line. So, Madam, one thing I'm very sure that it doesn't work in 100% of the patients. So as my study had shown, it helps only in 60 to 70% of the patient. So to know which patient falls into the group where they're benefited, we should use it for at least 3 to 4 weeks in full dose. And if the patient shows a response probably there is a benefit of continuing it. If in those 3-4 weeks they don't show a response, probably there is no benefit in continuing it. That is what, as far as I know.
And you have also said, Sanjay, that you need more bigger trials.
Yeah, definitely, sir.
Already shown. Yeah,
Yes,
that's well taken. Now, Dr. Anita, shall we move to the next?
Yes, so we move on to the next, and then we can have good
Yeah.
discussion during the panel discussion.
Yeah. The next topic would be controlling inflammation and oxidative stress in chronic kidney disease, and Dr. Urmila Anand. Anand will be talking, and she is senior consultant and head Department of Nephrology, Yashoda Hospital, Secunderabad. Welcome, Dr. Urmila, and over to you.
Good afternoon. Am I audible? Because I'm in the hospital and I cannot take my mask out.
Yeah, audible.
Can you all
audible.
hear? I'll be a little loud. That's the only thing.
No, you are audible.
So, good afternoon. At the very onset, I would like to thank Dr. Anita Saxena and her team for giving me this opportunity to talk oxidative stress and inflammation and how do we control. This is the last talk and it has been made easier for me because there has been a lot of background information on this. So in the next few minutes, I will discuss briefly about oxidative stress in kidney and how do we treat oxidative stress. And finally, therapeutic interventions on inflammation in CKD, and briefly a little bit about gut dysbiosis and anti-inflammatory therapy. Now, we all know kidney receives almost 25% of blood without any antioxidant or anti-inflammatory defense mechanisms. And this imbalance between pro-oxidant state and antioxidant state is actually worsens over a period of time when the GFR declines. And this antioxidant pro-inflammatory state is responsible for the progression of chronic kidney disease and its complications. We all know that there is a imbalance between there are high level of oxidative stress, whereas very less antioxidants. And this oxidative stress leads to inflammation. And as was discussed before, this is responsible for the development of coronary artery calcification, atherosclerotic cardiovascular disease, heart failure, malnutrition, anemia, and all these things. And also realize that oxidative stress and problems can lead to increased cardiovascular mortality in chronic kidney disease. There is a complex and interlinked interaction between oxidative stress and inflammation in mineral bone disease, which we need to be aware of when we treat our patients with CKD, MBD. And we all know that inflammation plays a very detrimental role in the management of anemia in our patients. Now, how do we control oxidative stress and inflammation? It may be a very simple. All we need to do is have some antioxidant therapy or use some anti-inflammatory therapy. But it is not like that, because that also makes us realize that there are so many things we do because we still don't know how to manage this oxidative stress and inflammation. One of the major things that we bring is these various things, of smoking, dietary, antioxidant therapy, vitamins, minerals, and all these things. There are, of course, the drugs that we use regularly. We should use it.
Dr. Urmila, you're not audible.
I'm not being able to. Can somebody share it from me, madam? Because my I cannot move my slides also.
Yeah. So
I cannot. The screen is stopped, madam. I cannot share it.
No. The team is on the job. They'll just come to your rescue now.
They can share it if you want, ma'am. I can just say next
Yeah,
time.
I've just informed them. Mr. Sudhir, can you hear me?
Yes, ma'am. Yes, ma'am. Arnav,
Yeah.
Can you play Dr. Umila's PPT, please?
Yeah. Yes, sir.
Screen has stopped sharing. Stop sharing. Stop sharing. Sorry, ma'am. So the first thing that we actually do is talk of stopping cessation of smoking, because smoking has a predominantly inflammatory and oxidative stress in our CKD patients. So whatever we do, we should actually talk to our patients about stopping smoking. Otherwise, not most of it will not be useful. Shall I be sharing or you will be sharing?
Mr. Sudhir, who's sharing the screen? Are you or Dr. Urmila?
We are sharing, ma'am. We are sharing.
Madam, after I have done it, and then there are various dietary interventions we can actually look into it. That is that we look into dietary patterns, encourage healthy dietary patterns. And as Dr. Anita Saxena was saying, there are lots of plant-derived metabolites which have very important antioxidative and anti-inflammatory role. So the first thing we ask our patients is to actually shift to a better or a positive dietary pattern. And most importantly, plant-based diets, and that actually helps in improving the dysbiosis, which was discussed by Dr. Bhomik, and which actually interacts or counteracts the inflammatory and the oxidative state in our chronic kidney disease. Besides dietary pattern, there is a large amount of in literature on plant-based diets where there are lots of active substances in these plants which actually are either improve their endothelial function or actually antioxidant or even anti-inflammatory. A word of caution that we should be careful about when we use these things in declining GFR. One important thing is using iron tablets. So it's better to consider diet, if allowed by our nutritionists, in iron supplementation in our patients. Now, this is what I have been discussing. There is a whole lot of literature in which there are various plant metabolites, which are like curcumin, resveratrol, allicin, epigallocatechin, ursolic acid, quercetin, and various flavonoids. They can be sourced with various plants products, and they can be used depending on the kind of GFR they are on, and they have shown to have tremendous antioxidative therapy benefit. And this is all these bioactive compounds actually activates a nuclear factor 2, Kelch-like ECH associated protein 1. These are anti-inflammatory transforming factors in our patients. Besides antioxidant therapy, there are various vitamins and minerals and then various drugs in the market which can be considered. This video shows that various minerals, vitamins like magnesium, selenium, vitamin C, D, A, all have some kind of antioxidant or anti-inflammatory role. But there is a dose of caution, and it was discussed before, that we should look into very cautiously when we use these substances, because their levels may reach nephrotoxicity when the GFR declines. Vitamin D, of course, is been shown to have a role in chronic kidney disease, metabolic bone disorder, but it has been shown to have in various studies an anti-inflammatory role. And these are all various studies which has shown its beneficial effect in inflammation. How is it by? It is by reducing the pro-inflammatory transforming growth factor NF-kappa beta, which leads to reduction in pro-inflammatory cytokines. Besides vitamin D, even vitamin D receptor activators can have a beneficial effect in improving the anti-inflammatory milieu in our patients. These are studies and human studies where vitamin D has been studied in CKD patients for its role in inflammation, and many of them have shown beneficial effects in inflammation in chronic kidney disease. Use of vitamin D receptor activator, that is in a clinical study, has shown improvement in TNF-alpha, in IL-6, the pro-inflammatory cytokines in our patients. There are various drugs which look into the mitochondrial oxidative stress, and they have been used, like Trolox, which is a vitamin E mimetic, omega-3 fatty acids, N-acetylcysteine, allopurinol, coenzyme Q10. These are all been shown to be useful, but in studies, for their antioxidant benefit. Now, what is important for all nephrologists is we should be using these drugs liberally if not contraindicated in our practice, because besides the indication that they have been used for, they are also very good anti-inflammatory agents. RAS blockade and statins reduce the pegylated proteins that are inflammatory. RAS blockade has shown that it has a beneficial effect in reducing CRP levels, and this benefit has got nothing to do with its antihypertensive effect. Sevelamer we all know, has pleiotropic effects. Besides all this effect, which is benefits cardiovascular stability, it also anti-inflammatory. It also reduces oxidative stress. The new kid on the block, the SGLT2 inhibitors, not only help us in benefit in our blood pressure control, retardation of CKD, anti-hyperglycemic agent, but because of its effect, it has been shown to reduce inflammation in kidney patients. It inhibits NF-kappa beta signaling pathways, and it improves the inflammatory milieu in our patients. Now, there are multiple factors in inflammation in CKD: uremia, stress, immunity, multiple infections, some known, some not known, dyslipidemia, malnutrition, volume overload, the comorbid illness like diabetes mellitus, the autoimmune diseases that lead to CKD, and dialysis related. All of them contribute to inflammation. So when we think of inflammation, and when we actually don't think in nephrology practice, but we should be thinking of this more often and use various therapeutic targeted to improve inflammation. That includes, of course, treating infections. A decaying tooth needs to be treated. Subclinical hemodialysis access needs to be treated. Dyslipidemia should be taken care of. Nutrition is very important. Malnutrition and inflammation is a vicious cycle. We need to keep our patients as less wet as possible. We treat the underlying comorbid disease of smoldering autoimmune disease like lupus. If you don't treat it, the inflammation is more worse. Use compatible membranes, and of course, treat anemia. This was discussed. There is an important role in inflammation, and that it does by increasing endotoxin levels. It worsens the immune system of the CKD patient and worsens infection and insulin resistance, leading to development of diabetes. All this leads to inflammation. So if you want to treat inflammation, you need to treat the dysbiosis in CKD. I will not go through it. We know a symbiotic gut actually has better barrier integrity and improves inflammation. Whereas the gut in a CKD patient is leaky, has less barrier integrity, and has more of inflammation. And the modifying the gut, the first and which we all should do is to modify our diet. We should preferentially move into a fiber-based, plant-based diet, which actually helps in improving the saccharolytic pathway rather than the proteolytic pathway, increase short-chain fatty acid production, which improves our gut integrity, improves the pH of the gut, and helps in inflammation, cutting down inflammation. Besides the dietary pattern that we should encourage, we should also look into the anti-inflammatory effect of probiotics, which is multifarious. One is it acts with the innate immunity cells and leads to a FOXP Treg cell pathway, and which leads to anti-inflammatory, which was discussed by Dr. Bhaumik, improves the gut barrier, and it also has various roles in inhibiting the NF-kappa beta pathway. So probiotics used properly in our patients also help in our inflammation. Besides that, there are various other interventions which we do by improving our gut dysbiosis. We had discussed with prebiotics like inulin oligosaccharides, which improves the saccharolytic pathway, fermentative pathway, increase short chain fatty acids, use of high dietary fiber. We have also discussed we need to enrich the gut with lactobacillus bifidobacteria, which will reduce the NF-kappa beta pathway. Acarbose, by inhibiting glucosidase, will reduce precresol and will reduce the hepatic transformation into precalcyl sulfates. Essential oils are useful in maintaining the gut microbacteria. There are certain adsorbents which have been used, like AST 120, which are shown to reduce inflammation. The only problem is this use may also absorb beneficial substances. You can block the lipopolysaccharide, that is the endoxin, by using sevelamer, statins, and then there are various experimental drugs now like eritoran, lipidemimetics, and CRX526, which can actually interact and intervene at the gut level and improve the dysbiotic environment. There are various studies which have been done in uremic toxins, and there have been various meta-analyses. Some of these trials have been discussed. One synergy was discussed by my previous speaker. There was another which was published in JL, which did not show much improvement in HD patients. This is because all these studies don't look into the dietary intake. No point using pre-pro probiotics when your diet is very rich in non-vegetarian food. You also need to look part of the gut are you looking at. Does your patient have constipation? No point getting drugs when you have not been able to correct the gut dysmotility. Also, using these drugs and have a simultaneous use of antibiotic use, you have already reduced the amount of symbionts. And which part of the intestine are you going to target your prebiotics? And dosage and composition, that is very important. What billion? 4.5 billion, 9 billion, how long, 2 weeks, 4 weeks, 8 weeks? These are all methodological issues which we need to discuss before we take up in these drugs for its role in anti-inflammation. And some of these symbiotic compositions, like you use a lot of yeast. The yeast uses the carbohydrate for its own use, and hence you have very little left for saccharolytic fermentation later. So these symbiotics should also be symbiotic. They should be useful for the gut microbiota rather than for themselves. And then this is something which is very important, the yin and yang effect in our gut. Whatever we use, symbiotics, prebiotics, is actually in a healthy gut, where Dr. Bhomik has shown how they, and Dr. Srinivas has shown how they improve the inflammatory milieu, they reduce cytokines, they reduce NF-kappa beta activation. But what is actually true is this gut, the CKD gut, where there is lot of urea, and then there are urease containing microbiota, leading to very high levels of ammonia. And this ammonia and ammonium hydroxide actually through toll-like receptor leads to nitric. So when you're thinking of probiotics, the probiotics should be designed in such a way that it is good for the CKD gut, not the healthy gut. So probiotics with less of urease production may be useful in our patients. Briefly, last minute, about exercise and inflammation. There are various studies now that showed that exercise is very anti-inflammatory, and it has been shown in a study from C. Jason that walking leads to improvement of anti-inflammatory markers, and there is a lot of studies to show these are being useful. And there are actually now trials being started all over the world this year onwards on the role of physical activity and inflammation in kidney patients. Interestingly, there is a trial being starting within about a couple of months in UK. They're using a combination of prebiotic supplementation and aerobic exercise to improve the inflammatory state and oxidative state in chronic kidney disease patients. So, ladies and gentlemen, oxidative stress and the progression of chronic kidney disease and the cardiovascular disease risk in our patients. Dietary modification and diet rich in antioxidants have shown limited benefit. Patient should have a multi-targeted clinical and nutritional approach. Gut dysbiosis is a theme of this session, and it has been shown that it plays an important role in inflammation. But whatever we use, pro symbiotics, have shown early promise, but we need randomized controlled trials addressing the issue of microbiota modification or enrichment in the CKD gut. Physical exercise has also shown to improve gut dysbiosis and inflammation in our patients. Thank you very much for your attention.
Thank you. Thank you, Dr. Urmila, for the very lucid talk and a lot of good knowledge we have received. And you have mentioned about the oxidative stress, inflammation, chronic kidney disease, access. You have managed by the antioxidant therapy, anti-inflammatory therapy, stop smoking, dietary interventions. You recommend more of plant-based proteins, antioxidant drugs, etc., etc. Now we have a panel discussion. It's my great pleasure to invite and join, request to join Dr. Harsha Babu and Dr. D. Chavakar to this panel discussion, please. We will be enlightened by your illuminating knowledge and all that. So let us go to the panel discussion and welcome Dr. Harsha Babu and Dr. Harsha Babu is Professor and Head Department of Nephrology, Vaidhi Institute of Medical Sciences Research Center, Bangalore, and Dr. Deod Shafakar is Nephrologist, Supreme Kidney Care, Nasik. Welcome our esteemed panelists to join, and let us go over to the discussion.
Yeah. Can I say? Yeah, thank you.
Yes, sir.
Yeah, Dr. Mitra, can I start by making some comments?
Yeah, please do, please do, please do.
Yeah, so I think we had a very extensive discussion on the role of pre and probiotics, inflammation, as well as the pathophysiology. Therapeutically, I think all that is theoretical, but therapeutically, I have a few thoughts. One is that, can we think of using this probiotic therapy in AKI? Now, the question is, because the pathophysiology may be different, but then if there is a role of dysbiosis of the gut in AKI, and we don't really have any drugs for AKI anyway. So therefore, one wonders whether we can use this therapy in AKI. The second comment which I would like to make is that this therapy is highly dose and strain specific. So I think that is something which we should remember. And it is already mentioned by Dr. Sanjay, I think, that the dose is very important, the strain is very important, and the right combination should be there. The third point which I would like to make is that we have talked of so many additional medications in order to prevent inflammation, to treat inflammation, or sort of a polypharmacy. So for example, we have talked of role of vitamin D, then some drugs like say statins, sevelamer, some other drugs to reduce inflammatory markers, etc., etc. Personally, I feel that this therapy can be individualized, because otherwise the patient will be having many drugs to swallow at one particular time. Anyway, our CKD patients, they have to swallow so many drugs. So I think that we'll have to individualize therapy as far as this is concerned, and then try and find out whether how much is the amount of inflammation in this particular patient with CKD, and then try and find out which drugs are going to benefit. And it cannot be say a polypharmacy of all the drugs cocktail put together for every patient. And the last point which I would like to make is, in CKD 3 and 4, many people are now using these medications for preventing the progression of CKD. And what happens when you combine it with alpha-keto analogs? Again, that's a question. So therefore, these are the points of discussion, I think, which all of us need to consider.
Thank you, Dr. Shafakar, for the great idea that you said. I think I have seen one or two comments and write-ups regarding protection of AKI with probiotics. I'm not too sure, but I think I have seen that report, and you are very right. This should be tried there also to, check the progression in case it does so. And dose specific also you have mentioned, that's also very important. And at the end of the day, the guidelines are there, whether it's a treatment of diabetes, hypertension, but it has to be individualized according to the patient who is sitting in front of you. So I totally agree with you that individualization of the supplementation of whatever you would like to, whether dietary modification or whatever, has to be individualized. That's a very right thing. Yeah. Great points, Dr. Shavkar. Dr. Harsha Babu, would you?
Yes, sir. At the outset, I would like to thank Dr. Anita Saxena and SRNM for giving me this opportunity. Most of the things have been already been covered by the eminent speakers. What I would like to know is like how long are we going to use in CKD stage 3, stage 4, and stage 5? How long are we going to use this medication? That is one thing. And most of the times the patients think that since these are all costly medication, they think probably it will reverse the disease or it will stop the progression of the disease. So that we need to educate the patient that irrespective of how costly these medicines. So they should be aware that in spite of this medication, there can be a progression of the kidney disease, and ultimately they may land up in dialysis. Most of the patients think that because we are giving a costly medication, they may not end up in dialysis. That is one thing. Thank you, sir.
Can I add something?
Yeah, Dr. Nita, please do.
Yes, sir. Yes, ma'am.
Sir, what to me, what we can actually think of is fiber has a great role in modulating dysbiosis, and because CKD patients are usually given refined diet because of the risk of getting into hyperphosphatemia or hyperkalemia, so that is a very important factor that has to be taken that has to be considered while a dietitian is prescribing the diet. So I think as it is, what is the recommendation here is that in the general population, it is about 15 grams per 1,000 kilocals fiber should be given. And in CKD patients, you can go up to 25 to 30 grams of fiber per 1,000 or 1,500 kilocals. So one has to find out ways of increasing fiber in a way that the patient it doesn't affect hyperphosphatemia like the phosphorus levels and also hyperkalemia. So fiber has to be introduced in the diet, and the best possible way is like to introduce something like a soluble fiber in the diet, which will be really, really good. And secondly, we've done a study which we had presented it at ACE in the Renal Week in the late breaking clinical trials. It was a randomized clinical trial on enzobiotics. What we found is that we have to stop production of uremic toxins, the precresol and indoxyl sulfate. So for that, what we did, we gave enzobiotic, a combination of probiotic and protein digestive enzyme to the patients, and we found that the protein which should be digested within stipulated time was being digested, and so the formation of uremic toxins really came down by 23%, and the quality of life improved. The serum albumin levels also improved, as Dr. Srinivasa has also presented NIFTY trial and other trials, and the inflammation also came down. So to me, I think these medicines, though are expensive, but the main problem is gastroparesis. The patient may not be diabetic, but gastroparesis is definitely a comorbidity in CKD. So because of this, the digestion of protein is delayed. Now, because the digestion of protein is delayed, so therefore more it is fermented and the uremic toxins are produced. So we have to find a way. These medications are expensive, but if they can help in reducing production of or formation of uremic toxins and therefore reduce inflammation and cardiovascular disease, and also may delay progression of kidney disease. So if it is affordable for the patient, we should not think of not prescribing these drugs to the patient, because the clinical trial that we presented at ASN is really got wonderful results.
Thank you, Dr. Saxena. And yeah, these are costly medicines, and as Dr. Harsha Babu mentioned, that these patients, our patients of CKD, are also most of them are diabetic and hypertensive. They have a cardiovascular disease. They are hyperlipidemic. So they have already a long list of drugs to control blood sugar and control their blood pressure and statins and whatnot. And so obviously it becomes a little costly. And these are, of course, the prebiotics and probiotics. These are also costly. So we have to balance, and as Dr. Shavkar said, it is the patient who is sitting in front of us, and how much his pocket suits.
That's it. That's it.
Yeah, that's true. But science is there, as you have mentioned, and we have to take that science and see how best we can pass on that science to that patient who is sitting in front of you as an individualized treatment. That's a great thing.
Can I make one more point, please?
Yeah.
Can we individualize therapy by looking at the inflammatory markers before starting this kind of therapy? We don't really do it right now.
Yeah.
However, maybe we'll have some markers and then probably look at the individualization of therapy, those people who need it and those people who do not need it.
That's right. Yeah, yeah. Dr. Sanjay, would you like to chip in? Yeah, please do.
Yeah, as I said, sir, that when you start these symbiotics to the patient, so usually I said that you should give it for a period of at least 3 weeks, because that is the minimum period that I have seen which shows a response. And if the response is good, I'm telling you, many of the patients, they come back and they say, I need that medicine because my quality of life improved. Even, and suppose you don't see a response over 4 weeks or 3 weeks, then probably it may be better to withhold the drug yourself. Because as in my study, we showed 60 to 70% only respond, the rest don't respond. Now, what is the reason behind that? Many of them not responding, I'm not very sure. But definitely we are looking into it. As Madam said, we were thinking probably the protein intake was much higher. So we thought of adding a protein digestive enzyme with the probiotic. That's how the concept of symbiotic came in. And my center and Madam center, apart from another 2-3 centers joined together, we did the study. And to our surprise, when you are using a protein breakdown enzyme, the response is much better. Because probably it is the undigested protein which is giving rise to all the problem in the dysbiotica.
So what do you estimate to be the duration of therapy?
To me, sir, wherever I have tried to stop, the patient has done well. They slowly start declining their, the quality of life. And automatically, many of them, they come back to me and say, why don't you restart me on that? So to tell you frankly, I don't know what is the duration of therapy, but those who can continue, I continue them on that.
In fact, the same thing happened with us also. When we started giving this enzymatic to our patients, we gave it for 90 days. You remember the trial was for 90 days only. And after that, because this is an expensive drug, patients came to us and said, no, please prescribe us this medication because we are feeling much better. I mean, they had glow on their face. I could make out that the nutritionals, forget about nutritionals, their activity factor had gone up so much. They really were doing very well. So I'm very confident on this drug. I know about the pill burden on our patients. 15 to 16 drugs they have tablets they have to take every day. But this is definitely going to help them with lot of quality of life and of course inflammation and cardioprotective. Definitely it is.
Dr. Anita, can you name the drug? Can you name what is the proprietary preparation that you have been using in your trial, where the patients felt very better as far as quality of life was concerned? What's that? That's
we use nitrophage food.
Sorry?
Nitrophage food.
Oh, I see.
So even I use nitrophage food because we had the animal study and then only I started using. So animal study was done also by my group only. So we saw the response and then started. I was never a believer of probiotic initially. But once I found this, to tell you how exactly how happened is, I had one patient, he had Chiarel's disease involving the whole of his body, the back, the legs, the extensor aspects of the hand. The fellow could not lie down. He was telling he was feeling like a Bhishma lying on the arrows. So he was contemplating committing suicide. And fortunately on that day, the company person came and said, why don't you try this? And he gave me supposed to be sample for 3 people, 1 week each. I said, I will not use for 1 patient. I will use only for 1 patient. And I gave it to him. And within 3 weeks, I saw the change in the patient. So I thought there is a potential. That's how I created the first study that I wanted to do. And I believe it was mainly inflammation.
Great,
that's
you
how it
saved
has
one
gone.
suicide. You saved one suicide.
No, it was very bad, sir. He was.
Yeah,
it was really frustrating for me because he had received everything from PUA therapy to everything that you can think of, local applicants, everything. It was very disheartening to see him.
I know. Very gratifying.
So can we wind up the session so that we
I
can break
think
for
if
lunch
there are-
now? And
you don't have any questions from the audience, I believe. So anyway, I am very, very grateful for the honorable speakers, and big thanks to them. And I'm also thankful to our two panelists who have joined us and with their great points. And once again, we wind up this. We had a great session. And thanks, Dr. Anita, for the wonderful organization of this conference. Congratulations again. Thank you very
all
much.
right, thank you, sir.
Thank
And we
you,
look forward to you monitoring the as moderator for the next session also. So we'll now break for lunch. Yes, we'll break for lunch for 15 minutes, and we will join again at 1 o'clock. Thank you very much.
Oh, but it's already 1:45.
Yes, the lunch break was only for 20 minutes, sir. 12:40 to 1300 hours.
Okay, I'll be there. I'll be there. Okay.
All right, thank you.
Thank you, Dr. Anit.
Hello and welcome back to 7th Advanced Course in Renal Nutrition and Metabolism post-lunch session. So we now move on to the third session, that is delaying progression of chronic kidney disease. And for this, I invite Dr. M.K. Mitra, consultant nephrologist and former head Department of Medicine, King George Medical University, Lucknow, to moderate the session. Let me remind you that Dr. D.S. Ray is not available because he had to rush to Delhi because one of his close relatives is admitted with COVID in the hospital. So he will not be available for panel discussion. Over to Dr. Mitra. So can you hear me?
Yes, ma'am.
Can you just see if Dr. Mitra has joined in? Because I just spoke to him. He said he's going to
Dr. Mitra is already online. Actually, he's muted himself and the video is off.
I'm sorry?
Ma'am, Dr. Mitra is available on the Zoom only. सर ने वीडियो एंड ऑडियो ऑफ किया हुआ है. मैं यहाँ से कमांड भेज रहा हूँ सर को, प्रॉम्प्ट कर रहा हूँ.
Please call him, no? Manas, please call him.
Yes, sir. Yes, sir. I have already called him, sir.
Can you hear me now, Anita?
Yes, sir. Sir, I've already introduced you. Please.
Okay.
You can start the proceedings.
Yeah. Welcome to this session of delaying progression of chronic kidney disease. And the first topic would be preserving residual renal function by Professor Amit Gupta. We all know him very well. He's the former head of nephrology at SGPGI, and currently he is the director of nephrology and renal sciences at Apollo Medic Super Speciality Hospital, Lucknow. It's always a pleasure to listen to you, Professor Amit Gupta. Over to you.
Thank you, sir. Good afternoon, sir. And I would like to thank the Society of Renal Nutrition and Metabolism for giving me this opportunity to participate in this advanced course. Residual renal function is a very important thing for all nephrologists because our patients with chronic disease have a tendency of losing their kidney functions over a period of time. And as I'll sort of take you through my slides, we try and show you the importance of residual renal function and some of the steps that we can do or strategies that we can implement to keep or to preserve the residual renal function as far as possible. Residual renal function has been defined as the ability of the kidneys to eliminate both water and uremic toxins. And in clinical practice, it is considered to be synonymous with the daily urine output and the glomerular filtration rate. But unfortunately, there is still no optimal method to assess or to measure the residual renal function till date. Now, the attention or the importance of the residual renal function was actually brought to light by Mallorca and colleagues working in Italy. Actually, it was in the field of peritoneal dialysis that they were working in. And what they observed was that patients who had a residual renal function, better residual renal function as compared to those who were almost anuric, had a better survival. And this observation, which they published way back in 1995, was actually again collaborated by many other authors over the years. And in 2002, we had this, the CADUSA study, which was published, was reanalyzed by Joanne Bargman and colleagues. And Joanne actually showed the predictive power lay exclusively in the residual renal function, not in the peritoneal component of the clearances of the solutes. And the data actually showed that if the patient had a urine volume in excess of 250 ml per day, it was associated with 36% lower mortality. And then so it was observed that the presence of the urine output actually displaced the renal small solute clearance from multivariable Cox regression model. So the indirect evidence that the degree of sodium and water removal by the diseased kidneys is very important in determining the survival of these patients. And this was more acutely observed in patients who were anuric and when they were compared to those who had some residual renal function. And Angela Wang from Hong Kong had published a study way back in 2005, where she showed, as you can see from this graph, that those with residual renal function had a better survival as compared to those who did not. And she said that anuric patients had more adverse metabolic and cardiovascular profiles. They had more severe anemia, more resistance to erythropoietin. They had increased calcium and phosphorus product, increased inflammation and malnutrition, more severe hypertension, and greater cardiac hypertrophy. This is a busy slide again published by Angela Wang in KI in 2006, where she showed the reasons why residual renal function is important, particularly in dialysis patients. And she said that loss of residual renal function is associated with increased inflammatory response, and the presence of this inflammation actually accelerates the decline of the residual renal function. So therefore, it can lead to loss of this residual renal function, can lead to malnutrition, it can lead to cardiac hypertrophy, atherosclerosis, vascular and valvular calcification. And this loss of residual function is associated with more severe anemia, greater hypoalbuminemia, higher arterial pulse pressure, which are important risk factors for cardiac hypertrophy. Residual renal function, better residual renal function improves the removal of uremic toxins and therefore limits the cardiac hypertrophy. Peritoneal dialysis patients with residual function had better phosphorus control as compared to those who were anuric patients. And vascular and valvular calcification were important complications observed in dialysis patients, and this who had lost their residual function, and this predicts the mortality as well as increased cardiovascular death in dialysis patients, both on hemo or on peritoneal dialysis. Again, residual function has been shown to be linked to the nutritional status of the patient. And it's been seen that loss of this RRF leads to significant malnutrition both in peritoneal and hemodialysis, because the resting energy expenditure accounts for almost 60 to 80% of the total energy expenditure. And sustained increase of the resting energy expenditure would lead to malnutrition, which is a predictive of higher mortality as well as higher cardiovascular deaths in peritoneal dialysis as well as the hemodialysis patients. When they looked at, people compared the residual renal function in both hemo and peritoneal dialysis, what they found, as in this study, which was done way back in 1991, they found that residual renal function was better maintained in peritoneal dialysis patients as compared to those on hemodialysis. And then we have a host of other studies, and all these studies actually showed that there was a difference in the rate of decline of the residual function between the two dialysis modalities, and all of them actually favored peritoneal dialysis that had a slower decline of the residual function. Comorbid diseases associated with the decline of residual function included diabetes, obesity, atherosclerotic cardiovascular disease, and congestive cardiac failure. And it's been seen that mortality and the decline of the residual function is greatest among all diabetics, regardless of the modality of dialysis that they are on. Now, what are the possible mechanisms for better preservation of the residual function in patients on PD as compared to hemodialysis? It's been suggested that avoidance of renal ischemia secondary to intra-treatment hypovolemia and or to the nephrotoxic effects of the inflammatory mediators of extracorporeal circulation in hemodialysis. People have also studied the predictors of the decline of residual function as well as anuria, in particularly in patients on PD. And this was a publication made by Seto and colleagues from Hong Kong in PDI in 2015, where in a multivariate analysis in about 640 odd patients, they found that patients who had massive proteinuria or who had a lower baseline residual function at the time when the PD was started, or patients who required the use of large doses of diuretics had a rapid decline of the residual function. Again, when they looked at by a Cox proportional hazard model at the predictors of developing anuria, again, they found that proteinuria, that each 1 gram per day, there was a 13% increased risk of developing anuria. If you had larger exposure, if you needed higher concentration dialysate bags, you had a greater chance of developing anuria. So each 10 grams of glucose increase in the glucose exposure per day had a 2.5% increased risk for developing anuria. And if you had a tendency to develop higher number of peritonitis episodes, again, there was a 4% increased risk of developing anuria. So they emphasized that we need to sort of the role of anti-proteinuric therapy and also measures to prevent peritonitis for better preservation of the residual function has to be done. Then we had this BALANCE trial, which was published in 2016. The 160 odd patients were followed up for about 20 odd months, and they found that better preservation of the residual function was independently predicted by male gender, higher baseline residual function, higher systolic blood pressure, the use of biocompatible dialysis fluid. And what they again showed, which is important, is that if you had to do lesser amount of ultrafiltration, that is, the patient had some residual renal function, he was making reasonably good amount of urine output, and therefore you needed to ultrafilter less, there the RRF decline was lower, and the use of lower dialysate glucose exposure. If you look at the patients on hemodialysis, the frequent hemodialysis network nocturnal trial, they examined the effects and of the assignment to 6 compared to 3 times per week of hemodialysis. These were patients who were getting hemodialysis 6 times a week, and they compared these patients to those who were on 3 times a week. And they found those who were getting lesser number of dialysis sessions, again, their decline of residual renal function was lower as compared to those who were on more frequent dialysis. And this was just to show the same thing, that those who were in the conventional group and those who had a frequent nocturnal, the black bar is ones who had zero urea clearance. The white is the empty bar is where they had more than 2.7. And if you look at this at the end of 1 year, when they compared conventional and those who were in frequent nocturnal dialysis, you can see the number of patients who had almost negligible urea clearance was much more in the patients who were in frequent nocturnal dialysis as compared to those who were in conventional. As well as on those when they started, you had almost similar type of patients. So if you gave hemodialysis more frequently, more than the conventional, there was a greater chance of more rapid decline of the residual renal function. Again, this is another study from Spain, where they had some patients on twice a week hemodialysis, some patients on 3 times a week hemodialysis, and then they had some patients on peritoneal dialysis. And they found that the rate of decline in GFR was similar in those who were twice a week hemodialysis and peritoneal dialysis, but was much higher in those who were in 3 times a week of hemodialysis. And this, if you can look at these numbers, the group A were those who were twice a week, the decline in rate was 0.18 per month, whereas in group B, who were in 3 times, was almost twice as much, and in peritoneal dialysis group was similar to the ones who were in twice a week hemodialysis. And the end of 2 years, there was a more rapid decline in the ones who were on 3 times a week as compared to those who were in twice a week hemodialysis or those who were on peritoneal dialysis. This was a Chinese study which again showed that the percentage of patients with residual renal function loss was significantly lower in those who were in twice a week hemodialysis as compared to those who were on more number of hemodialysis per week. And they suggested that the first year, if you have some residual renal function, maybe you could consider putting these patients on twice a week hemodialysis rather than starting off with 3 times a week immediately, in order to try and preserve their residual renal function. And then subsequently, when they lose their residual renal function, you can increase this frequency of dialysis. So the choice of dialysis modality, as I showed you some data, that patients on peritoneal dialysis have the lower rate of decline of residual renal function as compared to hemodialysis. So it may be preferentially, it may be better to put patients on PD to start with and then transfer them to hemodialysis when their residual renal function is lost. In patients on hemodialysis, it's been seen that if you are using biocompatible membranes, you're able to preserve the residual renal function better. If you're using ultra-pure dialysate, again, the residual renal function was preserved better as compared to those who were using the usual RO water. Hemodiafiltration was again found to be more useful in maintaining the urine volume for a longer period of time. So again, there have been recommendations that in patients on hemodialysis, if you use high flux biocompatible membranes or ultra pure water, if possible, you may be able to preserve the residual renal function better. And this was a publication in 2002 where they looked at compared patients who are on a high flux biocompatible membrane in hemodialysis and those who are in peritoneal dialysis. And they found that the rate of decline of the GFR was almost identical in the 2 groups of patients. So again, the authors were suggesting that use of biocompatible membranes in hemodialysis patients may be able to preserve the residual renal function better. The use of icodextrin in peritoneal dialysis again has been suggested to be able to preserve the residual renal function. And you have this study, and there's several other studies also, where this found that the use of icodextrin, you were able to maintain the residual. This is the ones in the closed circles are the ones, the patients on icodextrin, those with the open circles are those on the conventional glucose solutions. And they found that patients who were on icodextrin again had their residual renal creatinine clearance better preserved. The daily urine output was again better in those who were on icodextrins compared to those who were just on conventional glucose packs. What about neutral pH and low GDP solutions, as some people have suggested? Again, there have been 11 trials, and there have been some more subsequently, and they found unfortunately the trials generally are of poor quality. They found that those who were using the neutral pH and low GDP PD solutions, their residual renal function is better preserved. A word about the decline of residual renal function in diabetics, because diabetes is one of the most important factors which cause chronic kidney disease. And it's seen that in diabetics, the decline is much more rapid as compared to non-diabetics. And this was a study where they looked at 400 odd patients who were diabetic or those who were non-diabetic. And they found that in diabetics, it's almost twice as higher. The decline of residual renal function is much twice as higher in diabetics as compared to non-diabetics. And again, non-diabetics who had smaller declines in glomerular filtration rate also had a better survival. And they found that for each fasting plasma glucose level of 10 milligram per deciliter increase, the risk of death, the hazard ratio, was increased by almost 1.6%. Now, what could be the reasons? Again, endothelial dysfunction and inflammation are recognized as pathogenic mechanisms for diabetic nephropathy, and these in turn would lead to, they can produce inflammatory, they can reduce to inflammatory cytokines, which are released in larger amounts. And these markers of inflammation are present in diabetics, which correlate closely with the decline of the GFR. Blood pressure control, both hypo and hypertension, are risk factors for decline of residual function. Mean arterial pressure of greater than 110, it particularly seen in patients on peritoneal dialysis, associated more rapid decline of GFR, and higher MAP actually could occur because of volume overload. Again, on the other hand, hypovolemia has been also seen to adversely affect residual function. Although the BP goals have not been very clearly established, but we need to be clear that we have to avoid excessive swings and prolonged hypotension or hypertension in our patients on dialysis in order to try and maintain their residual function. So what are the other strategies that we could use? We should sort of try and avoid use of contrast unless it's absolutely essential. You avoid nephrotoxic agents such as NSAIDs or aminoglycosides. The use of diuretics, again, some people have suggested that improves the fluid balance in patients on dialysis, but there is no evidence that it protects residual renal function. The use of ACE inhibitors, angiotensin receptor blockers, we'll just talk about it in a little more detail later. Try and maintain good blood pressure control. Avoid overzealous ultrafiltration and intradialytic hypertension. And there was this controversial recommendation made by the Chinese that patients on dialysis, we generally give high amounts of protein. But what this author suggested is that if you give low protein diet on days when the patient is not receiving dialysis, perhaps you may be able to preserve the residual renal function better. So this is something that many of us may need to sort of look at it in greater detail. The RAS inhibitors, there have been 6 open label studies. One study compared ACE inhibitors with other antihypertensive drugs. The 3 compared ARBs with other antihypertensive drugs, and 2 studies compared ARB with ACE inhibitors. And it's been shown that long-term use of angiotensin receptor blockers shows significant benefits in preserving residual renal function. One study which compared with other antihypertensive drugs, long-term use of ACE inhibitors, particularly ramipril, showed a significant drop in the rate of decline of residual renal function in patients on PD, and it also delayed the time in which the patient developed anuria. So ACE inhibitors and ARBs again are very useful. So there is prudent to use these drugs in patients on dialysis to slow the decline of the residual function. And what could be the pathogenic mechanisms for the benefit of these drugs is that these drugs are found to mediate glomerular sclerosis. ACE inhibitors and they lower the TGF beta, which actually mediates the glomerular sclerosis and promotes glomerular cell regeneration. And they, again, the ACE inhibitors or ARBs have been found to ameliorate the fibroblast activation, which is stimulated by TGF beta. And in patients on hemodialysis, we've seen that those who were given ACE inhibitors or ARBs had lower markers of inflammation and of endothelial dysfunction. Obesity is again something which has been shown that leads to more rapid decline of residual function. And this was highlighted in the NECOSAD study, where they looked at over about 1,000 odd incident dialysis patients, of which about 60% were in hemodialysis. And they found that patients who had a higher BMI of more than 25 had a more rapid decline of GFR. And the mechanisms that they suggested, which could lead to this more rapid decline, was that glomerular changes, which occur more in obese patients, renal hemodynamic dysfunction, insulin resistance, hypertension, hyperfiltration, and inflammation. And there has been observations that if you could induce weight loss after by dietary methods or after bariatric surgery, you could reduce the proteinuria, and there are some patients who have shown to have improvement in GFR. And so stabilization of the GFR after normalization of weight suggests a contribution of obesity to the decline of GFR. Fluid balance in dialysis patients again has been seen to have an impact on residual functions, and patients with volume overload had a more severe cardiac hypertrophy, dilatation, and worse systolic and diastolic functions. The DOP study published in 2007, which looked at a large number of 16,000 odd patients on dialysis, showed that use of diuretics was associated with lower interdialytic weight gain, less hyperkalemia, better preservation of residual function. But we are still not there's no consensus as to whether diuretics really help in the preservation of residual renal function. A last word about maintenance of residual function in a failing transplant kidney. And there is, most of us have a tendency of stopping most of the immunosuppression except for steroids once we find that the creatinine has increased beyond a certain limit. So people have debated whether it would be wise to continue or stop these immunosuppressions till the time these patients go on to dialysis. And there have been some publications in this regard, and they've shown that if the residual function reduced more rapidly in patients whose immunosuppression was stopped totally as compared to those who continued on small doses of the immunosuppression. So we need to again look at our patients on transplant who have a failing kidney, whether we need to stop almost all our immunosuppression together or continue on a small dose of the immunosuppression so as to preserve the residual function. So in conclusion, ladies and gentlemen, we know that residual function is important for solute clearance as well as important and effective at removing toxins which are not cleared well by dialysis. And additional benefits of preservation of residual function is an increase in the urine volume. So it allows your patients to have a little more liberal fluid intake. And guarding and preserving the residual function in both in patients who have yet to reach dialysis and those who are on dialysis is extremely important and should be of high priority for us. And in order to do this, we need to have a better understanding of the potential risk factors for the loss of GFR, which, as I showed you, should include diabetes, BMI, the modality of dialysis, volume depletion, and the various treatments that we are using for treating our patients of chronic kidney disease before they reach dialysis. Thank you very much for your attention.
Thank you, Professor Gupta, for the very lucid talk and a very comprehensive talking about preserving residual renal function and how it is linked to better survival and how it leads to anemia, hypoalbuminemia, CV protection, and the loss of renal function is also, overall betterment of the patient. And you talked about PD slightly better doing to preserve renal function than hemodialysis. And you also talked about the treatment of diabetes, blood pressure, volume overload, obesity, and the useful effect of ACE inhibitors and ARBs. Thank you very much for the great talk. And we will have all the, uh, discussions later in the during the panel. I would now move on. Thank you, Dr. Gupta, for the excellent talk.
Thank you, sir.
Thank you very much. It was a big, comprehensive talk. Now we move on to the next speaker, management of anorexia and CKD stages 2 to 5, Dr. Rajiv Medanki. Dr. Medanki, consultant nephrologist, Sunshine Hospital, Hyderabad. Welcome, Dr. Rajiv Medanki, and over to you for your talk. Please stick to time, 20 minutes. Thank you.
Yeah. Good afternoon, everybody. At the outset, I'd like to thank SRNM and Dr. Anita ma'am for giving me this opportunity. I hope my screen is visible.
Yeah,
and I'm audible. Yeah. So my topic is management of anorexia in CKD stages 2 to 5D. So coming to this problem, we all know that anorexia is quite common in CKD. And one of its effects is that it contributes to uremic protein energy wasting. And this is the pathway that we are all looking at when we are trying to modulate appetite. I think all of you are familiar with this pathway when we are trying to look at diabetes. And there are quite a few drugs in diabetes that are now modulating this pathway, but they go in the opposite direction. We are trying to decrease appetite in diabetes. Whereas in CKD, we are trying to improve appetite, and the chief culprits are ghrelin, leptin, insulin, CCK, PYY, all these hormones. So let's see how we can modulate these hormones and result in a better appetite for our patients. So coming to anorexia, we all know that decreased intake of protein starts quite early in CKD, but the symptom of anorexia, which is reduced appetite, is reported when GFR is somewhere around 10 to 25% of normal, which means that quite a few patients will develop anorexia in CKD stage 3B itself. And obviously, as CKD worsens, the anorexia keeps worsening and it increases in severity towards ESRD to the extent that 30 to 50% of patients on dialysis will have anorexia. And we measured this by using a visual analog scale. And there's also a FACT-A scale. These scales are better studied in cancer patients, but there is increasing use of these scales in dialysis patients. So this is how anorexia is in dialysis patients. And you can see that 50 and more than 50% of patients in various studies have reported anorexia. But it's also there in pre-dialysis patients who are yet to start dialysis. And it's also there in PD patients. This is the relationship of protein intake and GFR in the MDRD study. And as you can see, once you enter CKD stage 3 and the GFR starts declining, the intake keeps reducing, and this problem gets worse and worse. So what are the clinical consequences of anorexia? Now, I would like to make a distinction between the feeling of anorexia and the objective measurement of protein intake. It's quite possible that the two are different in the sense that intake of protein or intake of calories is not a good surrogate of anorexia or vice versa. I'll give you an example. It's quite possible to have poor appetite and yet eat a lot. You will often see people sitting in front of the TV and even without appetite, they just go along and eat a lot. But the specific feeling of worsening appetite is associated with increased mortality. And it also increases hospitalization risk by 22%. And there are studies which show that even a single reported symptom of low appetite is associated with increased mortality over a period of 1 year. And the same effect is found over a period of 2 years. So this symptom, when it is reported by our patients, is very, very important. And we should take time to analyze it and figure out what is going on. and we should try to correct it if possible. So coming to the pathophysiology of anorexia, we can study this under 4 broad categories. One is disrupted molecular signaling. And as GFR goes down, there are altered hormone levels and function of various hormones. Cholecystokinin, PYY, ghrelin, cytokines are retained, and these have a profound effect on inflammation and anorexia. Very interestingly, low levels of branch chain amino acids have a profound effect on tryptophan and serotonin levels in the brain. And anorexia is supposed to be a hyperserotoninic kind of state. There are factors inherent to the dialysis procedure itself. The presence of glucose in dialysate, and this is something which we see quite prominently in PD patients. Glucose is a profoundly anorexic molecule. The retention of middle molecules has been theorized to cause anorexia. And of course, if you look at the various organs in a particular individual, especially in the GI tract, if somebody has poor dentition, if somebody is having metallic taste secondary to various drugs, if somebody has gastroparesis, poor digestion, GI infections, all these things tend to affect appetite. And there are various other reasons like depression, the access to good quality, palatable food, all these things can affect anorexia. And of course, comorbid conditions. It's not that our patients with CKD and ESRD suffer from only that condition. Many of them have cardiac issues. Many of them have issues related to other organ systems. For example, heart failure is very much linked with anorexia. So we have to look at other conditions also in our patients. So if you look at the various effectors of appetite and satiety, from the GI tract, you have these stimulants. Ghrelin is supposed to be a hunger hormone. Cholecystokinin suppresses appetite. Neuropeptide YY suppresses appetite. GLP-1, which is now a target of many diabetic drugs, suppresses appetite, as does leptin, which is a hormone produced by fat. Neuropeptide Y, agouti-related peptides stimulate the appetite. Serotonin is a suppressor of appetite. And as I said before, anorexia is supposed to be a hyperserotoninic state. So if you look at the way uremia affects the hypothalamus and the altered levels of these hormones, the rise in cholecystokinin, interleukin-1, rise in inflammatory molecules, all these things tend to affect the levels of branch chain amino acids, which tryptophan especially crosses the blood-brain barrier, and it leads to altered signaling of leptin and other hormones. And there is an increase in serotonin, and this in turn leads to anorexia. This is the association between inflammatory molecules, interleukin-6 and CRP. Of course, now we hear a lot about this in COVID times, but these are elevated in all inflammatory states, and they are associated with poor appetite. The presence of glucose in PD solutions is also associated with a decreased intake. So how do we manage anorexia? There are a few general principles of managing anorexia. You have to support food intake, and we'll talk about what we mean by that. You have to counteract anorexic agents which the patient might be taking. A lot of these are drugs which may be used to treat diabetes, which may be used to treat phosphate balance. You can use appetite stimulants in very few cases, select cases. And of course, dialysis dose has a very important effect on anorexia. And you have to manage associated conditions. Like, as I've mentioned before, if somebody has heart failure and they have anorexia related to that, it won't get corrected unless you treat their heart failure. So you begin with a comprehensive dietary screening and assessment and identify what is the reason for the anorexia. You have to assess the GI tract, right from dentition onwards to their gut function. They need an in-depth nutritional counseling, and I'll talk about the importance of this. And you have to treat comorbid conditions. It doesn't really work if you just tell the patient to eat more. And one thing we now know is that if you limit fat intake, it doesn't really help. So anorexia is multifactorial, and the treatment also needs to be multifactorial. So what do we mean by supporting intake? So studies have shown that if the patient actually spends time with a qualified nutritionist and undergoes intensive dietary counseling, this is more effective than giving them ONS. And this was shown by Akpeli and Bailey in one study in hemodialysis patients. And there is also objective evidence that when patients make dietary changes initiated by counseling, their serum albumin and total cholesterol levels improve over time. Um, Very excitingly, in the last few years, data has come out about the effect that physical exercise, intense physical exercise, has on appetite. Um, Intense exercise is an anti-inflammatory kind of uh, condition, or rather it engenders an anti-inflammatory kind of state, and it leads to signaling by muscles which kind of depress your anti-inflammatory molecules, improve your appetite. Now, this is a head-to-head comparison in a small study between just nutritional education of a patient and oral supplementation. And you find that nutritional education and the changes that you affect as a result of that is as important as, at least is as effective as oral supplementation when it comes to treating anorexia and improving your appetite. And if you see below, it actually has an effect on the serum albumin levels also. Of course, all these studies tend to be short term, but it's very interesting nevertheless. Most of our diabetic patients have diabetic gastroparesis, and in the management of diabetic gastroparesis is a specialized topic by itself. But there are a few general principles that we as nephrologists can follow to encourage our patients to eat small, frequent meals, because high volumes will tend to slow gastric emptying. As a last resort, they can eat pureed ground foods to kind of increase their calorie intake. One should not limit fat intake unless there are other considerations. It does help if the patient is able to stand up for 1 hour after eating, because that improves GI transit. And you can use medications to increase the rate of GI emptying, especially drugs like metoclopramide, domperidone, and erythromycin. Coming to oral nutritional supplementation, as I've described before, branch chain amino acids have a very important effect on the brain through their signaling via tryptophan and their effect on serotonin levels. And there was a small study conducted in PD patients which showed that the supplementation of branch chain amino acids to the tune of 12 grams per day for a period of 6 months improved nutritional status and spontaneous food intake in one study. And oral nutritional supplementation does improve serum albumin in various studies, but the effect on the symptom of anorexia as such is a little bit variable. Poor compliance is a limiting factor when it comes to ONS supplements because they tend to be quite expensive. But we do know that at least in the short term, 6 months to 12 months, the combination of these things, branch chain amino acids, oral nutrition supplements, they do tend to have positive effects on various parameters that we are looking at, like your body fat percentage, lean body mass, the amount of protein intake that we are able to achieve, calorie intake, and serum albumin levels. If the patient cannot eat, despite whatever you do, IDPN may be a last resort. And again, in the short term, it does improve protein and energy homeostasis. It increases body weight, improves nutritional parameters. There are retrospective studies which show that it improves mortality, but we don't have hard evidence from RCTs yet. So coming to dialysis dose, we do know that when you increase dialysis dose, it has very important effects on quality of life parameters. And quality of life parameters do include appetite, feelings of well-being, the calorie intake, and all these things. The most important studies that we have are the studies which are conducted on short daily dialysis and nocturnal HD. And these studies have shown that there is significant improvement in anorexia. Patients do have better volume control, better phosphate control, and they do tend to be subjected to fewer dietary restrictions when the dose of dialysis is kind of compensating for what they are eating. And you find that the nutritional laboratory parameters like the albumin levels, and of course the subjective parameters like the calorie intake and the protein intake that you're able to achieve is significantly more when somebody has an increased dose of dialysis. So if your patient is stuck at a plateau and they are not able to eat, it may be worthwhile trying a spell of daily dialysis, of course, which is a big challenge in this COVID time when we are all actually trying to reduce the number of times our patients come for dialysis. So coming to appetite stimulants, these are more well studied in cancer cachexia, but there is small but limited experience in dialysis patients. Chief among the drugs which are studied is megestrol acetate. Ghrelin is increasingly being studied. Cannabinoids, the use of anabolic steroids. Of course, people have used anabolic steroids in the past to improve muscle mass and also as a kind of adjunctive treatment for anemia. And of course, various antidepressants and appetite stimulants like ciprofloxacin, mirtazapine, thalidomide and melatonin have also been tried. But I would probably say that the two drugs that we have the most data for are megestrol acetate and ghrelin. So megestrol acetate is a synthetic progestin used in short periods. It does improve appetite, weight, serum albumin, and food intake. It has an effect on the brain. It's a class of drug called an orexigenic, which is the opposite of anorexigenic. It has an anti-inflammatory effect, and this drug tends to improve appetite by acting directly on the brain. There are all these studies wherein the drug has been tried for up to 6 months. You start off with a low dose, around 160 milligrams per day. The maximum dose that has been studied is around 800 milligrams per day. And patients do show increased appetite, increased weight, increased albumin and protein catabolic rate. Thromboembolic complications are an important side effect that we should all be aware of. And coming to ghrelin, which is the so-called hunger hormone, which is produced by the GI tract, especially the stomach. Again, short-term administration of ghrelin, 12 micrograms per kg over a period of 7 days, is known to improve appetite and nutritional parameters. And again, this drug too acts by its effect on the hypothalamus and its effect on growth hormone. So among all the interventions that we've studied, which one would we pick? Well, there are levels of evidence. Pretty much the only thing that has some A-grade level of evidence for its use is the administration of branched-chain amino acids. The increasing the dose of dialysis, nutritional counseling, the use of oral nutritional supplements, and ghrelin, these are probably next in line in terms of the evidence that we have. Other things like IDPN and the use of anti-cytokine drugs and anti-inflammatory drugs, there is really not much evidence to recommend them at this point. Thank you.
Thank you very much, Dr. Rajiv Madanki. You have very nicely elucidated the various causes of anorexia. You have mentioned about the pathophysiology of anorexia regarding by saying the altered hormone levels, branch chain amino acids, ghrelin especially. Then you have talked about that management of anorexia by appetite stimulants, drugs, nutritional counseling, exercise, diabetic gastroparesis. All these can be tried, and this might help in the anorexia. Anorexia is a big problem. There's no doubt about it, and it triggers the nutritional deficiency, which again goes to the overall cardiovascular mortality in our patients of CKD. Thank you very much. We will have the discussion at the end. Now we have the third topic.
So can I?
Yeah.
There's a little change. Actually, Dr. Namrata Rao, I knew was down with COVID. Right now, she's just moved on to oxygen. So she just informed us. So I'm going to take up the lecture now. Okay. And you know, while these two lectures were going on, I was preparing my own lecture. So it's like totally unprepared, but I'll try and convey the message.
Okay. Thank you. It's a pleasure and privilege to have you, Dr. Anita. Let's have your considered opinion, experience. Yeah, thank you.
Sure. I'll share my screen.
you'll be talking about the conservative management of nutritional recommendations for CKD stages 1 to 4.
Yes, sir.
Okay. Thank you.
So and I was in the middle of preparing this lecture,
Yeah.
but anyways, I'm sure I'll be able to give the message.
Yeah.
Okay. So let me just remove this bar. Okay, I'll bring it down. Right, so I'm going to talk to you, good afternoon, ladies and gentlemen. I'm going to talk to you about conservative management in CKD stages 1 to 4. Okay. Now, we know that the term renal disease embraces a number of clinical conditions whose common feature is decrease in GFR. Another common feature that these conditions share is malnutrition, and that is the whole concept of this course. We are trying to prevent malnutrition from setting into the patient. And because this is the most common feature of chronic kidney disease, so therefore this society has taken a major role in trying to prevent and spread the message how to prevent malnutrition in these patients. Now, what is the etiology of protein energy wasting syndrome? We've heard in the first lecture itself, Dr. Georgie did touch upon this. Let me just close my video. Yeah, because that's better. Right. So we know that because of uremia, there is an imbalance in the hormones leptin, ghrelin, tryptophan, and serotonin, which causes anorexia. And you were just hearing from the previous speaker about anorexia, so I'm not going to talk about it. And then because of anorexia, the patient is not able to eat very well, and there's a decreased calorie and protein intake. Along with this, what uremia does is there's retention of middle molecules and uremic compounds, and then metabolic acidosis ensues, inflammation ensues, and metabolic acidosis causes accelerated catabolism of protein, leading to loss of lean body mass. Inflammation, on the other hand, causes acute phase reactant proteins to increase the CRP levels, etc., the IL-6, and that reduces production of or synthesis of protein in the liver, which leads to hypoalbuminemia. So both metabolic acidosis and inflammation put together, they cause muscle breakdown and eventually hypoalbuminemia. And on one hand, the patient is not eating very well. On the other hand, there's an increase in the resting energy expenditure from 12 to 20%. So the patient has gone into a negative energy balance, which causes malnutrition in these patients. And we're not talking about dialysis here because the dialysis is not part of the conservative management. So when does malnutrition or protein energy wasting set in? The dietary protein and energy intake diminish long before end-stage renal disease develops. And as you can see, this elegant experiment by Ikizer et al. Has shown that as renal function declines, there is spontaneous restriction in the dietary protein intake. And also the MDRD study has shown, I was not able to pull out the slide, the MDRD study has shown that as GFR declines below 60 ml per minute, there's a decline in not only the serum albumin protein intake, but also there's decline in the serum albumin levels. So protein energy wasting most likely occurs during CKD stage 3 or even earlier because of inadequate nutritional management in pre-dialysis phase, and which becomes clinical evident when GFR declines below 10 to 15 ml per minute. Now, as kidney disease progresses, the capacity to respond to changes in intake of nutrients and water becomes less flexible, and solute and water excretion per nephron increases, but the fewer number of functional nephrons leads to a more restricted range of solute and water excretion. So if you have a look at this figure is showing you an imbalance in the protein intake and the kidney mass. So when there is loss of nephron mass and there's excessive protein intake, what is going to happen is going to be uremia. So when diet exceeds daily protein requirement, excess protein is degraded to urea and other nitrogenous wastes, which accumulate in the body and cause uremic symptoms. And therefore, the patient is not able to eat very well. So, and deterioration of clinical nutritional status is characterized by progressive weight loss, wasting of fat and skeletal muscle tissue, and reduction of serum proteins. So in kidney failure, medical nutritional therapy has a very important role because this can allow a good control of several consequences of disease like nausea, vomiting, anorexia, and can even delay initiation of dialysis, which I'll show you in the later slides how it happens. Now, in chronic kidney disease, the postprandial hyperfiltration is associated with subsequent histological lesions and decreased glomerular filtration. So the aim of medical nutritional therapy is to prevent progression of chronic kidney disease to end-stage renal disease and maintain nutritional status. Now, what is the role of protein in renal hemodynamics? Excessive protein intake when nephron mass is reduced again causes damage to remaining nephrons. Increase in single nephron GFR and increased glomerular capillary and transcapillary pressure after renal mass reduction is a cause of accelerated glomerular injury. Now, the dietary protein we know causes postprandial hyperfiltration, that is increase in GFR, which induces or increases proteinuria and leads to glomerulosclerosis and renal insufficiency. So low protein intake lowers high hyperfiltration and retards onset of proteinuria and glomerulofibrosis. So in conservative management, we always look towards low protein diet in these patients. Now, even the source of protein is very important, whether it's coming from the plants or it is coming from the animals. So plant protein should be preferred over animal protein because there's less 20% less proteinuria in soya-based diets compared to animal-based diets, that is the casein-based diet, where proteinuria can be as much as high as 45%. And fibrosis is also lower in the soy group compared to the casein group. So reduced animal protein intake would reduce glomerular hyperfiltration. If you have a look at this figure, this is a beautiful figure showing you the effect of low protein diet on afferent arterioles and the efferent arterioles. So low protein diet causes vasoconstriction of afferent arterioles and vasodilation of efferent arterioles, thereby reducing intraglomerular hypertension and thus preventing decline in renal function through angiotensin modulation. Along with that, if sodium is also reduced, then you have even better results. So what are the specific requirements of CKD patients? So a patient who is in CKD stage 2 to 5, a low protein diet is preferred to improve uremic symptoms and slow progression of renal dysfunction. Protein restricted diet may result in essential amino acid deficiency and this deteriorate the patient's nutritional status. Therefore, one can supplement these patients with keto analogs. And I'm not going to talk about keto analogs or very low protein diet because in the next lecture by Dr. Ashwini Gupta is going to cover this up. But I would say that whenever the patient is put on low protein diet, there is always a risk of energy malnutrition. So you should give high energy foods to the patient. So if you have a look at this table I just compiled, which says that in conservative treatment management of CKD stage 2 to 5, prescribe to 0.5 to 0.6 gram per kg body weight per day of protein, and at least 50% of this protein should be of high biological value, and recommendation should be based on ideal body weight. Now, in very low protein diet, we have to supplement with keto analogs that Dr. Ashwini will be taking up. Energy intake for these patients should be 30 to 35 kilocalories per kg body weight per day. If the patient is less than 60 years, give him 35 kilocalories, and if he's non-diabetic. But if the patient is more than 60 years of age, give him 30 kilocalories per kg body weight per day of protein, of energy. Otherwise, because these patients tend to be more sedentary, they'll start putting on weight. It's not that weight, they'll start accumulating fat in them. But whenever a patient has acute illness, even if though he is in CKD stage 2 to 5, you have to increase the amount of protein that you're going to give to your patient. So it has to be increased to 1 gram per kg body weight per day. Fat has to be restricted because our patients do have the tendency towards cardiovascular disease. It's actually the kidney disease never kills the patient, it's the cardiovascular disease that causes mortality in our patients. So one has to restrict fat to maintain the lipid profile to prevent atherosclerosis. So the preferred amount of fat for these patients is about 15 to 20 grams per day, because the fat is of two kinds, the visible and the invisible fat. Invisible fat is what comes naturally with the food, and visible fat is what you add to cook the food. So if you restrict fat to 20 grams per day in these patients, then the actual fat consumption will go up to 60 grams per day, keeping in mind the invisible fat that is coming with the natural food. So, and always try and use the combination of oil, that is peanut oil with mustard oil or rice bran oil or sunflower oil, and at least 30% of calories should come from the fats. Otherwise, protein will be utilized for giving energy, and the patient will undergo more of muscle catabolism. Now, if you have a look at this figure, this is our randomized control trial on keto analogs, which showed that when you supplement patients with keto analogs, the decline in GFR is definitely lower compared to the patients when you do not supplement them with keto analogs. And so this figure is showing you the annual rate of change in GFR from baseline to 58 months. And you see that there's an increase in GFR initially in these patients, but after you stop giving keto analogs, still these patients are able to maintain a low, to maintain their GFR, maybe because of some memory or something like that, but their GFR doesn't drop as fast as the control groups. And here you can see that the rise in serum creatinine in the supplemented group is low compared to the rise in creatinine in these control patients. Now, moving on to salt. Salt has been declared as a dysfunctional food. Although most diagnosed hypertension has no obvious direct cause, but dietary salt has been suggested to be an important etiological factor. Now, in Paleolithic times, the ancestors evolved on a diet containing relatively modest amount of sodium that was less than 50 mmol per day. But sodium intake in present time has exceeded to an extreme amounts of 100 to 200 mmol per day. Now, blood pressure is directly proportional to the amount of sodium intake, that is the sodium content of the body. So usual sodium intake is about 3.5 to 5.5 grams per day, which corresponds to 9 to 12 grams of salt per day globally. So excessive sodium consumption of more than 5 grams per day causes increased fluid volume and consequently hypertension and rise in systolic blood pressure with age. And we know that our patients are hypertensive, and hypertension is an important factor that can accelerate decline in renal function. So blood pressure, and if you have a look at this figure is showing you that blood pressure increases when people on low salt diet with normal blood pressure switch over to Western diet and increase their sodium intake. So excess salt intake induces oxidative stress in salt-sensitive hypertension, and high salt intake, either alone or in combination with angiotensin II, increases superoxide formation. So it is going to increase oxidative stress and at the same time volume and then hypertension. Of course, so which is really not really very good. So sodium intake is associated with changes in circulating metabolites, including gut microbiomes. And this figure is a very interesting figure which shows you the effect of age on salt. So if a patient is taking 100 mmol of salt, if a person is taking 100 mmol of salt and is between the age of 20 to 29, then there's an increase in systolic blood pressure by only 5 millimeters of mercury. However, if the patient is between 60 to 69 years of age here and is still taking 100 mmol of sodium intake, the increase in systolic blood pressure will be 10.3 millimeters of mercury. So which means that salt has an important role to play in hypertension and also in the progression of CKD. And here we can see that there's an incremental association of sodium intake with mortality. So one has to advise patients to stick to less than 2 grams of sodium for better control of blood pressure and for controlling edema. GNC recommends less than 1.5 grams of sodium per day, along with reduction in the intake of salty processed food, cheese, and meat. So patients have to avoid canned foods, fruits, pickles, fruits, and jam. And also they have to go from lifestyle modifications like 40 minutes of exercise or walk 5 days a week, and dietary interventions as prescribed for hypertensive CKD patients. Now, moving on to hyperkalemia, we know that the renal function, with decline in renal function, patients can actually have high potassium levels, which can be really detrimental to the cardiac health. So we know that 1 gram of protein contains 1 milliequal of potassium. So it's very easy to calculate how much protein you're giving to your patients and how much potassium they're taking. And the dietitian can always help you with how much, fruits and vegetables the patient is taking, so how much potassium the patient is taking. Now, potassium intake should be less than 1 milliequal per kg body weight per day for our patients. Prescribe low potassium foods, and that is foods containing less than 100 milligrams per kg of potassium per 100 grams. If serum potassium is more than 5 milligrams per deciliter, one has to stop giving fruits, and one has to advise patients to leach, potassium from the vegetables. So the ideal combination for our patients is apple, banana, guava, pear, papaya, and pineapple if the serum potassium level is less than 5 milligrams per deciliter. Patients will have to avoid green leafy vegetables, tomatoes, sweet lime, lemon, carrots, raw salad, mango, dry fruits, fruit juice, vegetable soup, coconut water. And of course, as I said, they have to leach potassium from the vegetables, which is very, very important. Then another comorbidity that really plagues our patients is hyperphosphatemia. So phosphorus retention plays a pivotal role in the onset of mineral and bone disorders and cardiovascular disease in chronic kidney disease patients. Phosphorus retention occurs as a result of net interstitial absorption exceeding renal excretion, or if the patient is on dialysis, then dialysis removal. So phosphorus is ingested primarily in foods, in sources of protein and dairy products, as well as preservatives, additional which are additives in soft drinks and enhanced cheese and meat. So if you have this figure is showing you the diurnal variation of phosphorus in blood and urine studies in meat versus vegetarian diets. So in patients who are on a meat-based diet, the phosphorus, calcium, and fractional excretion of phosphorus is higher for the meat diet compared to the vegetarian diet, and even the pH levels are lower in these patients. So prefer vegetarian-based diets for control of phosphorus homeostasis, because only 50 to 60% of phosphorus will be absorbed in these patients. And also increasing protein intake increases phosphorus also, because protein has a linear relationship with phosphates. That is, 1 gram of protein contains 13 to 15 milligrams of phosphorus. So one can very easily calculate how much the patient is taking phosphorus, and it should be between 800 to 1000 milligrams, should not exceed that. And also some portion of phosphorus is also coming from medications. So that accounts to about 10% of the phosphorus intake in our patients. So these patients will have to be put on phosphate binders with meals to control hyperphosphatemia. And remember that remember to restrict protein-rich foods like dry fruits, hard cheeses, egg yolk, meat, poultry, fish, cola beverages, snack bars, and instant products like refrigerated bakery products, etc., because these are very high in phosphates. And then equations are available to estimate the content of phosphorus based on the amount of protein of a mixed diet. So we have equations from Boas, from Kalantazade and Cupacity. These can be used for calculation. And also prescribe foods which are low in protein to phosphorus ratio, because the ideal ratio that you should be of protein to phosphorus is 12 or less than 12, and it can be between 12 to 14, but nothing beyond that, because the moment the phosphorus to protein ratio increases beyond 16 milligrams per gram, the risk of mortality increases twofold. And the patients can be advised to use phosphorus pyramid to choose low phosphorus containing foods. So the take-home message of my talk is prevent, monitor, and treat complications, prevent malnutrition from setting in, correct uremia and acidosis, monitor closely nutritional status and nutrient intake, individualized diet prescription, closely supervise low protein diet treatment as a treatment for early stages of uremia, but do give them high energy diet so that protein is utilized for building the muscles and not for this thing, and restrict protein intake to 0.5 to 0.6 grams in pre-dialysis patients, advise ketone loss with low protein diet, and control hyperphosphatemia. And thank you for your attention.
Thank you, Dr. Anita, for the wonderful talk you have given, very comprehensive talk. And
I just prepared in 20 minutes, sir.
Yeah, I know. And you have focused on the protein, energy, malnutrition has to be avoided by the dietetic tactics that you have mentioned. And medical nutrition therapy has a big role in both from all stages, 1 to 4 and beyond. Protein should be restricted to 16, 1 gram per kilogram per body weight. Medical low protein intake, salt restriction has to be there. processed food should be avoided, hyperkalemia has to be avoided, and the strategy for recommendation of the various intakes of the various food you have mentioned. Thank you very much, and I think we'll have a fruitful panel discussion later at the after the end of the all the talks. Now, thank you again once again. Now let us move on to the next talk, that is how effective are keto analogs in retarding progression of renal disease. And Dr. Ashwani Gupta, a very well-known nephrologist, senior consultant in the Gangaram Hospital. Dr. Ashwani, over to you. Thank you for joining us. Over to your talk.
Sir, sorry to say you, Dr. Ashwini is not able to join due to COVID in their families. We can go to the next talk, sir.
Okay. Okay. Anita, then we go to the next talk.
Yeah, yes, sir. Sure, sure.
Plant protein versus animal protein in CKD. Dr. Bharat Shah, another big name in nephrology. Dr. Bharat Shah is the director of the Institute of Renal Sciences, Global Hospital, Mumbai. Bharat Shah, hope you are safe in Mumbai. I can see mask on. Yeah, please. Over to you. Over to you.
I'm not starting anything without putting my mask on.
I know.
Setting an example for everyone. But I'm not sure whether I'm audible clearly with the mask. If not, you tell me.
Yes. Yeah, you are very well audible. Very well audible.
Okay. So I will continue to keep my mask on. And my talk is on plant versus animal protein for patients with chronic kidney disease.
That's right.
And I am going to keep my talk at the level of the nutritionists. So my colleagues, please excuse me for the simplicity of the talk, because I am under the impression that this is supposed to be more for the nutritionists. So let me start with my presentation. I will share my screen now. Okay, is my screen well seen?
Yeah, it's fine.
Fine. So as I said, I'm going to talk at the level of the nutritionists. Now, we all know that the most important function of the kidney is to eliminate the waste products which are produced as a result of protein breakdown. If the protein intake is increased, as an adaptive measure, the glomerular filtration rate will increase. And if the protein intake is decreased, the glomerular filtration rate will decrease. Now, this is a normal phenomena which happens in all normal subjects. It is an adaptive phenomena, and the kidney adjusts itself according to the requirement. So we all know that we have two kidneys, and each kidney has about 1 million nephrons, which are like this. And on an average, about 1 liter of blood flows through the kidneys. It eventually reaches each functioning unit called the nephron through this efferent arteriole, and then a glomerular filtrate is produced. As this filtrate passes down the tubule, the filtrate is further modified so that eventually the urine that is produced takes care of the end products of protein breakdown. Generally, out of 1 liter of blood which flows through the kidneys, 100 ml of filtrate is produced. This is called as the glomerular filtration rate. Normal glomerular filtration rate is about 80 to 120 ml per minute. Let us say on an average it is 100 ml per minute. If a person has a glomerular filtration rate of 100 ml per minute, if he increases the protein intake from 1 gram per kilogram per day to 1.5 gram per kilogram per day, there will be an increase in adductive increase in the glomerular filtration rate to throw out the extra waste products which will be generated from an increase in protein intake. And if that 1 gram per kilogram per day is decreased to 0.5 gram per kilogram per day, then the glomerular filtration rate will decrease. This is an adjustment that a normal kidney makes. Now let us see the situation in chronic kidney disease. In chronic kidney disease, particularly when there is a reduction in glomerular filtration rate, the number of functioning nephrons are reduced. So in such a situation, when you continue to use the same food and the same amount of protein in your food, for the reduced number of nephrons, the load on the kidneys is relatively increased. So the protein intake is relatively more for less number of nephrons. So let us say the number of nephrons, the functioning nephrons, have reduced to 50%. Now when you continue to eat the same amount of protein, it is like a healthy person who was eating 1 gram per kilogram per day of protein is taking 2 grams per kilograms per day of protein. So there is a relative increase in the protein intake for the number of functioning nephrons available. What happens in such a situation? We know that the kidney will have to work more. There will be an adaptive increase in glomerular filtration rate in the remaining nephrons to throw out the waste products. But there is a limit to which this can happen. So what happens when the number of functioning nephrons are reduced? So there were excellent experimental studies carried out in 1970s by Dean and his colleagues, where they looked at Munich Vista rats in whom about 85% of the renal mass was reduced. And then they carried out the hemodynamic studies. They found that in the remaining 15% nephrons, there was an increase in the renal blood flow because of afferent arteriolar vasodilatation. At the same time, there was an efferent arteriolar vasoconstriction. There was an increase in glomerular capillary pressure, and there was an increased filtration in each remnant nephron. So the single nephron glomerular filtration rate increased as an adaptive mechanism. In other words, supposing if out of 100 nephrons, if now we are left with 50 nephrons, these 50 nephrons will try to work more, and your kidney function will not reduce to half, but your kidney function will still be about 75% because the remaining nephrons are working better. Now, what is the significance of these hemodynamic changes? So then a year later, these two pathologists, Shimamura and Morrison, they performed a similar experimental study of removing 80 to 85% kidney mass in adult rats. And then they carried out serial histopathologic studies. And they found that there was no underlying kidney disease, and yet progressive glomerulosclerosis developed in initially normal remnant glomeruli. And the rate of development of glomerular pathology was directly proportional to the degree of ablated kidney. Putting these two things together, that there are hemodynamic changes, there is progressive glomerulosclerosis, they said that this glomerulosclerosis was a result of the hemodynamic changes. So then in 1981, Hostetter and his colleagues, they took rats with 90% of kidney mass ablated. In one group, the control group, the rats were fed usual protein diet, and in the other group, the dietary protein was restricted. In the study group, the hemodynamic changes were significantly less, and this was associated with less of proteinuria, less of hypertension, and retardation in the rate of decline in kidney function. So this shows that when there is an extra load on the kidney, that itself is responsible for progressive nephron loss. Putting all these studies together, Brenner and his colleagues put up a hypothesis, which was a landmark article in New England Journal of Medicine in 1982. They said that if you continue an unrestricted protein intake in the face of decreased number of functioning nephrons, there will be an increase in glomerular blood flow, increase in glomerular capillary pressure, and these two adaptive changes will lead to progressive glomerulosclerosis. This will lead to further reduction in nephron mass, and the vicious cycle will continue. This is the basis for resurgence of interest in dietary protein restriction in management of chronic kidney disease. Until then, the main purpose of restricting dietary protein restriction was to reduce the generation of uremic toxins. But this study shows that reducing dietary protein not only reduces generation of uremic toxins, but it slows down the rate at which the kidney function can go down. Now, as your kidney function deteriorates, you develop chemical changes, you develop azotemia, you develop acidosis, you develop hypokalemia, you develop hypophosphatemia and hypocalcemia. And these changes also add to the rate of decline in kidney function. There are studies which show that correction of acidosis retards the rate of progression of kidney disease. There are studies which show that correction of hypophosphatemia retards the rate of progression of kidney disease and reduces the risk of cardiovascular morbidity and mortality associated with chronic kidney disease. And these chemical changes can again be reduced by lowering the proteins in your diet. Above changes also play a role in progression of chronic kidney disease. This means restricting protein can minimize the hemodynamic and chemical changes. Now, this is all that was hypothesized. Does it happen in practice? So there was a large study called as modification of diet in renal disease study, the largest study ever to have been done in patients with chronic kidney disease to look at the effect of dietary protein restriction on the progression of kidney disease. And although initially the interpretation was that it has no impact, when a secondary analysis was done, it was observed that lower the protein intake. This was the group of patients 13 to 24 ml per minute, study A performed in 585 subjects. They found that when your achieved protein intake was less than 0.6 gram per kilogram per day, the cumulative incidence of renal failure or death, was significantly less than if your protein intake was more than 0.75 gram per kilogram per day, suggesting a beneficial effect of dietary protein restriction. In study A, which included patients with glomerular filtration rate 13 to 24 ml per minute, each 0.2 gram per kilogram per day lower achieved protein intake was associated with a 10% slower mean GFR decline, which was significant, and a 35% reduction in the risk of end-stage renal disease. In study B, each 0.2 gram per kilogram per day lower achieved protein intake was associated with a 30% slower mean GFR decline and a 50% reduction in the risk of end-stage renal disease or death. A meta-analysis of the role of low-protein diet in patients with both diabetic and non-diabetic kidney disease, Pedrini et al. Conducted a meta-analysis to assess the efficacy of dietary protein restriction. A total of 1,413 patients in 5 studies on non-diabetic renal disease and 108 patients in 5 studies of type 1 diabetes were included, and they concluded that dietary protein restriction effectively slows the progression of both diabetic, and non-diabetic renal disease. So far we have discussed about the efficacy of low protein diet in management of chronic kidney disease, and everyone agrees that a low protein diet can help in retarding the rate of progression of kidney disease. This is one of the measures. Certainly, treating the primary kidney disease, if possible, is the most important thing to do. Hypertension control is an extremely important thing to do. But also, if patients are otherwise stable, lowering dietary protein intake can retard the rate of progression of kidney disease. Now the question is, as regards the protein, does it matter whether you consume a plant-based protein or you consume animal protein? Studies have shown that plant protein intake is associated with less of hemodynamic changes than animal protein. Further, plant protein intake is associated with a lower load of sodium and phosphorus. So we just saw what happens to the kidney when it is subjected to a higher protein load. It causes increased glomerular capillary blood flow and glomerular capillary pressure. These changes are less with plant-based protein, and then because of lower sodium load, the degree of hypertension could be less, and because of lower phosphorus load, the chemical imbalance will be less. And all of this can help in slowing down the progression of kidney disease. Individuals with high plant protein and low animal protein intake consume a greater proportion. There is a difference in amino acids in plant-based proteins and animal proteins. Cysteine, proline, glycine, alanine, and serine, and smaller proportion of other amino acids.
See, your voice is not audible.
Not audible? Seminal studies, is this better?
No, you are audible.
Seminal studies dating back 25 years suggested that these differences, particularly the glycine
Hello,
and the
your
alanine,
voice is not.
But Dr. Mitra says it is
Yeah,
clear.
Dr. Bharat, I'm very clearly.
Sir, his voice is audible.
Yeah, audible. There is problem, Dr. Anita, with your end?
Possible. Yeah.
Okay.
I think Dr. Sudhir needs to fix that up for you.
Okay. Seminal studies dating back 25 years suggested these differences, particularly in glycine and alanine content, may make protein sources impact differently on the kidneys. So it is likely that this difference in the amino acid content results in less of hemodynamic changes on the kidneys. A diet with a higher plant-based protein intake was found to be associated with higher bicarbonate levels and improved phosphorus balance in patients with chronic kidney disease, which we know are factors which determine the rate of progression of kidney disease, and when corrected, slow down the progression of kidney disease. Does it really have an impact on the outcome of patients? So this was a study which looked at the association of plant protein intake with all-cause mortality in chronic kidney disease. In this study, they analyzed health information from 1,065 subjects classified as having chronic kidney disease, that is estimated GFR less than 60. Dietary information was gathered through 24-hour dietary recall interviews. After adjusting for age, gender, race, smoking, alcohol abuse, comorbid conditions, body mass index, physical inactivity, total protein and calorie intake, it was observed that with each 30% increase in the ratio of plant to total protein in the diet, there was a significantly lower risk of death. Hazard ratio 0.77 in the CKD group. Thus, every 33% plant to total protein ratio increase was associated with a 23% lower risk of mortality in those with chronic kidney disease. So yes, even in practice, it has been observed that a plant protein intake is associated with a lower rate of progression and a lower overall mortality in chronic kidney disease. So to summarize, plant protein intake is associated with less of hemodynamic changes. Plant protein intake is associated with less of hyperphosphatemia and acidosis, and a combination of these two changes seems to be associated with a slower rate of decline in glomerular filtration rate and a lower overall mortality. Thank you.
Thank you, Dr. Bharat Shah. An excellent talk with a lot of clarity and the beautiful build up to the talk. And lastly, mentioning about that why plant proteins are better to protect the residual renal function in patients with chronic kidney disease. Thank you very much for this very lucid, beautiful talk. Thank you.
Thank you. Thank you, Dr.
Now I think we have to go to the panel discussion. And I have great pleasure in inviting our other panelists, Dr. D.S. Ray and Dr. Manasar Patel.
So Dr. D.S. Ray has had to rush to Delhi because one of his relatives is critically ill.
Okay.
And Dr. Manasar Patel will be joining. I'm sure he must.
Good afternoon, sir. Myself, Manas, have already joined.
Welcome, Manas. Good to see you on the screen. You are assistant professor of nephrology at SGPGI.
Yes.
And we'll be very looking forward to your opinions in the panel discussion about this particular group of talks. Okay. Now, Manas, would you like to chip in and say some words?
Yes, sir. Summarizing, sir, whatever has been discussed on this topic today. So we have now several modalities coming from initial older methods like keto analogs, then plant proteins versus animal protein. Then came ACE inhibitors and ARBs. And then came now SGLT2 inhibitors. So now we have some one or two things to retard the progression of CKD, which we can advise to the patients. Otherwise, this is still a difficult management issue for all nephrologists. So, and other things which we have not discussed here is risk factors, management of risk factors, adequate hydration, and avoidance of nephrotoxicity. So, so if we pool all these things together and advise to the patient, and patient is somehow compliant to all this, then we may succeed to some extent to retard the progression of chronic kidney disease. Evidence-wise, most of the drugs, most of the evidence are expert opinion based. Probably nothing has grade A evidence, level 1 evidence. So still whatever we have, we can advise to our patients. And nutrition management of this nutritional component, especially protein restriction and salt restriction, is obviously cornerstone. Even if we advise ACE inhibitors or SGLT2 inhibitors, this thing comes first, followed by pharmacotherapy and other management issues. So,
thank you, Dr. Manas. Professor Amit Gupta,
yes,
I heard you talking about the role of keto analogs, and that was the talk which was missing. Could you just briefly, inform about the role of keto analogs in chronic kidney disease? I have heard your talk, and that's
keto analogs actually, there is a double two points of using keto analog. One is that when you are restricting protein, particularly low protein intake that we are all talking about, there's a possibility that there could be a deficiency of essential amino acids, which are essential for the well-being of the person. So keto analogs in that respect would be able to replace some of the essential amino acids. The second is that there's some data, although we need larger studies, which suggests that ketone analogs help in slowing the progression of the disease. So that's the second benefit supposedly for using ketone analogs. The problem with ketone analog is that the number of tablets that are required would be about 5 milligram per kilogram, which means almost 9 tablets of ketone analogs per day. And the ketone analogs are expensive as such, and they occasionally cause some GI discomfort. So that is a major limiting factor for using ketone analogs. However, many of us are using it, and we are using it in smaller doses with supposedly beneficial results. Would like to have the comments from other panelists and other speakers as well.
Yeah, Dr. Bharat Shah, would you like to chip in? Dr. Professor Anita, would you like to chip in?
Yeah, sure. Sir, as I showed you our study, which was on randomized clinical trial on ketone analogs, we had excellent results. And even studies from abroad, like Liliana Garnieta's study, has very clearly shown that with the use of ketone analog, we do not still know the kind of chemistry that goes on. There is better control of blood pressure, the insulin sensitivity increases, the insulin resistance goes down, there is improvement in HDL, the triglycerides go down, hyperphosphatemia is much better controlled, and metabolic acidosis gets much better controlled with the supplementation with ketone analogs, because you're eventually bringing down the protein intake and you're supplementing essential amino acids which are required for. So I'm a great proponent of keto analogs, because I have myself experienced my patients' blood pressures came down, their blood sugars came much under control. They were diabetic, but they were much higher, glucose levels. But after this, they had very good profile. The lipid profile, everything was very good. And I'm still kind of continuing to follow up these patients. It's been over 70 months since we've been doing this study, and the patients' creatinine has gone up, but they're still not as bad as the other, the control group, which is already on, it's ESRD. A lot of patients are already ESRD, and they've taken to dialysis now.
Thank you. I only want to say one thing, that in our patients of chronic kidney disease, majority of them are hypertensives and diabetics. So I, for one, whenever I deal with a patient of chronic kidney disease, I say, look here, your target is that your blood pressure should be 130 by 80, that your HbA1c should be around 7 in case there are no many comorbidities, and your LDL should be below 100. एटलीस्ट ये 3 चीजें को तुम करो, और ये आयुर्वेदिक दवाएं और नेफ्रोटॉक्सिक दवाएं ये जरा भैया मत खाओ. उस आज फिर डाइट के ऊपर आके, and now I feel no diet comes into nowhere in the realm of clinical medicine. Diet comes in a more sharper focus than in our cases of chronic kidney disease. And therefore, dietetic restriction, about which we have been talking from morning till now, even in this, is a very important factor. But the only thing is that I would like that the nephrologist should also interact with the patient personally about the diet. And I always maintain that there is a science behind the diet restriction, but there is also an art in delivering the diet to the patient and make the diet more palatable. For example, if Dr. Anita says that there is 2 tablespoonfuls of unsaturated fat should be allowed to cook food for 24 hours in this patient, so us particular applying in that particular quota of 2 tablespoons, in case he takes 2 puris instead of 2 chapatis, or 2 parathas instead of 2 chapatis, I have no objection. So what I'm trying to say is that you have to innovate. If there is a cup of curd you are giving, add a little bit of ginger, add a little bit of small pieces of onion, a small slices of tomato, और ऊपर से जरा काली मिर्च छिड़क दो, so it becomes a diet. What I'm trying to say is, in the art of giving diet to that particular patient, you have to try to tickle the taste buds by doing all these things. To, the science is fine, and we have to respect the science. The guidelines are there, but we have to innovate the diet a little bit. अगर उसी 2 बड़ी चम्मच ऑलिव ऑयल में और वो डायबिटिक नहीं है, और अगर है भी, एक आलू की टिकिया बना के उसके थाली पे रख दिया जाए, तो heavens will not fall, but the man will eat better. So that's what I wanted to say.
This comes with experience and maturity, sir. What you're saying is absolutely right. It's only with maturity and experience like you have, sir.
So even I'd like to say, so when I see the patients in the OPD, they are almost kind of psychologically broken down, because the dietitians, they tell them, you take no spices, nothing like that, take simple, almost close to boiled food. And I literally feel pity on the patient that, look, this is not something. Indian diet is very, very scientific. It is so scientific that if you take yogurt with puri, it is going to cut down on your cholesterol. This is a scientific. I always tell them, look, whoever has told you is a wrong thing. You should eat properly, but the only thing is we have to avoid giving you things which are going to harm you. So you have to be open and kind to the patients, and not like blindly telling a patient, don't eat this, don't eat that. That is not a very good approach. Giving a holiday once, giving a holiday to the patient once in 15 days is very healthy. They look forward to that 15th day when they'll be able to eat everything they like to have. That kind of a thing, that attitude has to be inculcated. And they really come in a very shattered form. Mentally they're shattered, because actually every time you see the patient is going to say, what can I eat? What can I eat? Food is the most important thing, and we live for it. And it is a life giver. And you are just abstaining your patient from all goodies because of a certain disease. But then that can be readjusted. Everything has to be given in such a way that the patient also feels good. He doesn't feel that he's been deprived of. And the way counseling has to be done has to be really, really very nice.
That is right. You have to be sympathetic. You have to be innovative. You have to talk to him and see how best you can. You have to respect the science, but at the same time, by respecting science, you have to innovate the diet also. The pickles are prohibited. Fine. What I do is, जो नींबू का अचार पानी में बनता है, उसके you take out the pulp, take out a small piece of the skin, rub it off in the running water as much as you can, and then put it in on the side of the plate. Look at what wonders it will do. The sight of that will help. You see, so अच्छे बढ़िया क्रॉकरी में बढ़िया सजा के खाना दो, थोड़ा सा कुछ make it a little more palatable to look at, and I think that will do wonders. Because anyway, after having spent 50 years of my clinical practice, I very strongly feel nutrition is the cornerstone of all treatment. How you modulate that nutrition in your patient of CKD, there are lots of no's and don'ts. That is for you to see how best you can give it within that framework. Dr. Bharat Shah, you wanted to say something.
I just wanted to add about the keto analogs.
Yeah.
Dr. Amit Gupta said that it works in some cases, and Anita was very happy with the use in majority of the cases. But I think, and both have their own experiences, large experience. What I have found is that we have to use this only in selected cases. The effect of dietary protein restriction will be best seen in people who have a slowly progressive kidney disease. If you have someone with rapidly progressive glomerulonephritis, it makes no sense to put all this. Similarly, some diabetic nephropathy patients who come to you at an advanced stage of kidney disease, they are progressing rapidly. It really doesn't help when you put them on a very strict diet. So you have to have patients who have a slowly progressive kidney disease to be able to appreciate its benefit. You have to have people who have a good appetite and a good nutritional status. If you ask someone, sometimes patient comes to us saying that their appetite is poor, they have lost weight. It really doesn't make sense to put them on a stricter diet. And third, when you put them on keto analogs, you have to make sure that they are following a very low protein diet. What I find in practice is that many patients are prescribed one keto analog tablet 3 times a day or 2 tablets 3 times a day without having been given a diet which is low in proteins. So that would be essentially a waste of your money, because you are adding more of protein to whatever the person is eating. After all, these are very expensive tablets. So we have to be very selective in using this keto analogs.
Absolutely, absolutely, absolutely. Professor Amit Gupta, would you like to chip in anything more that you want to say?
No, I think that's perfectly all right, sir. I think the points are well made by each one of them. And the point that you made, I think, is the most important, that you need to be innovative. You need to sort of counsel your patients and perhaps not be too rigid about the dietary restrictions, because in the end, what will ultimately happen is that the patient is not going to eat and will get wasted. So the whole purpose of dietary modification would be lost. And if he gets more emaciated, it really doesn't help.
Yeah.
So I think this comes with experience, as you said, and I think that would be the way that the art is more important. The science is there.
Thank you, Dr. Amit Gupta. Now I have a question to all the panelists, and that question is: our patients of CKD are getting COVID, right? And the rigmarole of the drugs that we have, I think we should have a session where to modulation of the various drugs. No, it's all right. Azithromycin is fine. What ivermectin, how it is being excreted, then remdesivir, or for that matter, 1800 milligram of flavipiravir twice a day for 24 hours, then 800 milligram twice a day for 14 days, and then about Zincovit, zinc, heavy metal. What are your comments on this zinc for our chronic kidney patients to boost the immunity in COVID? So I think we want to know, we have to find out, and there should be some guidelines regarding the drug dose in COVID patients of the various antiviral drugs and the immunization augmentation by drugs like zinc. I would like to know your valuable experience and comments about this.
So, the point is well taken. Zinc actually has been shown to help in improving the taste. I mean, there have been a lot of literature in the past, way back from the early 80s, that zinc helps in correcting hypoglycemia, particularly in patients of chronic kidney disease. Now, whether giving zinc in very large doses has adverse effects needs to be seen.
As a heavy metal, as a heavy metal, that's why, because you and all of us, I think we have been at the receiving end of a lot of Ayurvedic treatment that some of our patients come before they come to us, having had. I was talking about, therefore I was thinking about zinc. And the second point is the drug dose, of these various antiviral drugs being given in very heavy doses, especially flavipiravir.
The thing about this antiviral drug is that it may have some nephrotoxic effects. It has hepatotoxic effects, but so I don't know how safe it is to use it in patients with advanced, particularly post-transplant patients.
Moderate, I think, advanced kidney failure, it's fine. That whether best to avoid. But those who are in a mild chronic renal failure and getting COVID, and when the CRP level is high, and when the IL-6 is high, transferrin level, LDH is held, D-dimer is high, then we have to move in with a lot of heavy dose of steroids, flavipiravir, because patients are not getting admitted, So when they are in home quarantine, they are left with this immunocompetent stuff, and then with the flavipiravir, Then steroids in heavy dose, especially if the COVID score in CT chest is, more than 9 or 10, where a severe COVID score, then it becomes a little problematic and sometimes double-edged. And you are giving steroids almost 36 to 40 or 50 milligrams per day in serious cases, with a lot of flavipiravir and antibiotics and all that. So that is a thing I think is still a little bit of gray zone, but life is more important. So therefore we have to give it. And how much they will be nephrotoxic in the long run or even in the short run of 14 days, we have to perhaps see. That's the area where we need to be watchful and see. I think if there are no comments, I think we have had a very fruitful discussion on this particular, and I am very, very grateful to Professor Amit Gupta, to Rajiv Medanki, Professor Anita, Dr. Ashwini Gupta, and Dr. Bharat Shah. Thank you very much, all of you, for your...
Sorry to interrupt, sir. One question, I think one of the attendees, Vidita Shah, has asked, can you alternate, question is can you alternate day advocate LPD and VLPD with keto analogs? So we should answer that.
So do you want me to answer this question?
Yes, ma'am. Yes.
Okay, well, that's a very interesting question. You see, like I'm going to take up a talk tomorrow on irregular dialysis during lockdown and what do you do. So there are studies which have shown that you can have your patient on very low protein diet, and on, like, I'm just talking about the dialysis. If a patient is on dialysis, on irregular dialysis, then on a non-dialysis day, you put him on a very low protein diet or zero protein diet, that's what they say. And on a dialysis day, you bring the patient up to 1 to 1.2 grams per kg body weight per day of protein, so that the catabolism which is caused by dialysis is like, the patient is able to face that. So on a similarly, you can always alternate your patient with your low protein diet and a normal diet. That's not a bad idea at all. It is possible if the patient is on conservative treatment.
That was a suggestion made by Tang from China. Tao had made the suggestion that patients on dialysis, on the day that he's not on dialysis, you can give them low protein diet. And on the day of dialysis, you give them the protein, the extra protein that you deserve. The question is that if patients, the pre-dialysis period, can we sort of alternate between low protein diet and very low protein diet, along with keto logs. Now that I think has not been looked at, because the advantage, as Bharat was mentioning, is that if you give them the low protein, standard low protein of 0.6, then and plus ketone logs, you're going to give them extra additional protein. So these patients have to be on very low, which is about 0.3 to 0.5 grams per kilogram body weight. And then you can supplement them with ketone logs, and then only can you have the advantage of the ketone logs supposedly taking care of the absence of the essential amino acids, which maybe not be there in adequate amounts in a very low protein diet, and also helping in controlling of their blood pressure, etc., as Dr. Anita had pointed out. So VLPD, or very low protein diet, is the thing that you combine with ketone logs, and not low protein diet as such.
Yeah, see, the concept of very low protein diet is also changed. Like the latest KDOKI guidelines, they say that low protein diet is 0.5 grams to 0.6 grams per kg body weight per day. And in the previous ones, which were published in 2000, the KDOKI guidelines, they recommended 0.6 grams. Now, with time, in 20 years of time, the recommendations have come down to 0.55. So with very low protein diet, if you want to give 0.5 grams per kg body weight per day, it is not going to make much of a difference. So it's like keto analogs will supplement with supplementation of keto analogs. It will be really nice, whether it's 0.5 or 0.55, which is a normal, recommendation now according to latest guidelines, is not going to make much of a difference. But the patient is definitely going to benefit with supplementation of keto analogs.
Ma'am, Himani this side. Can I just put in a point here?
Sure.
Yeah, so I have been practicing a high protein diet for the patient on dialysis and a low protein diet on the days when the patient is not on dialysis. But then sometimes what happens is the patient is losing around 4 to 6 hours when on dialysis. As a result, sometimes on days of dialysis, the patient actually ends up eating lesser as compared to days when the patient is not on dialysis. So it becomes actually impractical sometimes to follow up with a 0.6 gram on non-dialysis days and on a 1.2 gram on dialysis days.
Okay.
Right. So can we wind up now?
Yeah, I think we have had a very fruitful discussion. And once again, thanks to all our esteemed speakers and our panelists, and of course to Anita for having arranged big advanced course in nutrition and chronic kidney disease. Thank you very much. Thank you, everybody. Thank you. Thank you all.
Thank you. Thank you.
Thank you, Dr. Manas. Thank you, sir, for moderating the session, and thank you, speakers. And well, it's a little bit of bad news that some of our speakers have come down with, as Dr. Namrata is on oxygen now, right now. Till morning, she had sent me a message that, well, she's not too good. She won't be able to take part in the panel discussion, but she'll definitely come and deliver. But suddenly she had to go on oxygen. So it's not a good day. And even for the next session, I received a message from one of our speakers that probably they will not be available. One is on the COVID duty right now. So anyways, this session was very, very productive because the theme of our advanced course is feeding well in chronic kidney disease. So the more clearer we are in our minds as to what to give to our patients, the better way would be to feed, the better ways we'll be able to find to feed our patients. So now we move on to the fifth session, that is the best clinical practice guidelines, KDIGO and the JNC ASPEN. And for this session, I invite Dr. Sudeep Kumar to moderate the session. He is professor in the Department of Cardiology in our institute, Sanjay Gandhi Postgraduate Institute of Medical Sciences, and he needs no introduction. Actually, he has been an active worker for our society because I have previously invited him over for talks, and today, Dr. Sudeep, we have two absentees because of COVID. One is Dr. Manish Malik and Dr. Vinant Bhargav. So we won't be able to take these talks today. So may I ask you to request you to carry on with the proceedings.
Yeah, thank you, Dr. Anita, and thanks again for inviting me to moderate this session. And this is very interesting session regarding guidelines regarding hypertension and various other aspects of management of kidney disease. So along with me, there are two more moderator, I think Dr. Deepak Diwan and Dr. Manas Patel. So yes, before wasting any time, so I will invite the first speaker, Dr. Kirmani, to start his deliberation. So we'll have question and answer and panel discussion after completion of all the lectures. Over to you, sir. Dr. Kripalani, I'm sorry.
Thank you, sir. I'm just trying to share my screen. Just give me a moment, please. Yeah. Yeah, sorry. So am I visible? My slides are okay? Yeah. Okay. Good afternoon, dear friends and colleagues. At the outset, I'd like to thank Dr. Anita ma'am and all the organizers for giving me this opportunity here today. I'm going to be speaking on the management of hypertension and chronic kidney disease vis-a-vis what guidelines advocate. So this is just the definition of hypertension in general as given by ACC-AHA, the latest definition, and it says that the normal blood pressure should be less than 120 systolic and less than 120 systolic and less than 80 diastolic. And if you have a persistently raised blood pressure of 130 or more systolic, or if your diastolic is 80 or more, then you have hypertension in stage 1. So coming to the scope of my talk, I will be talking on the guidelines regarding method of recording blood pressure, guidelines on the target blood pressure, guidelines on lifestyle modification, and then briefly on preferred drugs for hypertension in CKD, what the guidelines advocate. So first of all, the KDIGO has clearly given certain definitions as to what is routine and what is standardized office BP. Routine office blood pressure is the blood pressure measured in the provider's office. Preparation before measurement and the device used are not parts of the definition. The values are often inconsistent between clinics and providers performing the measurements. And very importantly, this routine office blood pressure, or ROBP, if I may call it, does not bear reliable relationship with the standardized office blood pressure, which we will call the SOBP. And these are given by the latest KDIGO 2020 guidelines. So standardized office blood pressure, or SOBP, what is it? This is a recommended method for measuring blood pressure in the current revised guideline. Blood pressure measurement following all guideline recommended preparations as presented in table 1 in chapter 1, which I'll show in the next slide. Again, the device used is not part of the definition. And this is a very busy slide, and this is there in the guidelines, but for want of time, I'll just go through the broad headings. This is table 1 in chapter 1 in KDIGO guidelines. And it clearly says that if you want an SOBP or a standardized office BP, you have to properly prepare the patient. You have to use the proper technique for measurement. You take the proper measurements needed for diagnosis and treatment of elevated BP, one of which very important is that you deflate. If you're using sphygmomanometer, you deflate the cuff pressure at 2 millimeters per second, not faster than that. Otherwise, you'll miss the sounds. You also properly document accurate BP readings. And then you take, very importantly, an average of 2 or more readings obtained on 2 or more occasions to estimate the individual's level of BP. So this is what is SOBP. Now, here we have the old sphygmomanometer, which we still use. And more often than now, most of us are switching to these oscillometric devices and trying to take more than one reading to get as close to the SOBP as we can. So what is the KDIGO 2020 guideline for blood pressure measurement? It says standardized office BP or SOBP is better than routine office BP or ROBP. This is a 1B recommendation. Oscillometric devices are better than mercury. A new term has been coined, AOBP, which is automated office BP, which is the preferred method of BP measurement if possible. And of course, a 2B recommendation that 24-hour ambulatory BP and home BP monitoring complement the standardized office BP for diagnosis and management of high BP. And very briefly, what is AOBP or automated office blood pressure? It is a BP obtained in the provider's office using an automated device that is programmed to start only after a set resting period and measured several times with fixed intervals between measurements. And then an average reading is provided as the output. Again, preparation before measurement is not part of the definition. For AOBP, we could use this BP True instrument, which came from Meditronics Canada many years ago. And now, because Omron has come with better devices, BP True has fallen out of favor. And most of us are trying to use this oscillometric device. And the best one is the one used in the sprint trial, Omron 907. Now, that's about measuring. What about guidelines for the target BP, which is always controversial? So we remember JNC 7 in 2003 had said 140/90 is the target for essential hypertension, and 130/80 or less is the target for CKD and also for diabetes. And JNC 8 in 2014 came and contraindicated everything. And it said that if you're 60 years or older with essential hypertension, you need to target less than 150/90 and 140/90 if you're younger than 60 years. But for CKD, it changed everything, and it led to confusion in the minds of all of us, including us nephrologists. And it said for CKD, target of 140 or less is good enough. And it also said that if you have hypertension and diabetes, which is basically essential hypertension, then also 140/90 is good enough regardless of age. Then, of course, came the sprint trial in 2015, which completely rubbished what JNC 8 had said, because it came to a very low target of 120 systolic. And I'll come to that in the next couple of slides. Before that, the ACC-AHA in 2017 clearly said that whether you have CKD of any etiology, whether you have CKD without diabetes with proteinuria, or CKD with diabetes with or without proteinuria, or your post-renal transplant, you have to target less than 130/80. So this was the American guideline in 2017. And then the next year, 2018, the European Society Cardiology and European Society Hypertension again made things a little confusing by saying that irrespective of your age, whether it's below 65, 65 to 79, or above 80, if you have CKD and hypertension, you target 130 to 139 if tolerated, and diastolic of 70 to 79. In 2020, last year, the International Society of Hypertension came out with the guidelines saying that in CKD, blood pressure should be lowered if it is more than 140/90, and it must be treated. Now, this is very important. It should be treated to less than 130/80, but only less than 140/80 in an elderly patient. And clearly, RAS inhibitors were the first line agents to be used because they reduced albuminuria, as we all know. CCBs and diuretics are the other first line agents. And of course, if your GFR is less than 30, then you can't use thiazide like diuretics. So you use loop diuretics in CKD, as we all know. Very importantly, electrolytes, creatinine, eGFR, and microalbuminuria and blood pressure, of course, should be monitored. And around the same time, the Kidney Disease Improving Global Outcome came up in 2020 with the BP target in CKD, and they based their recommendation and guideline on what SPRINT trial taught us. So this was a 2B recommendation that, as per KDIGO, that you try to reach in CKD a systolic of less than 120 systolic, but using the standardized office BP. So here is where the confusion starts. It clearly says that if you use the SPRINT method, then you target systolic less than 120. But if you use a non-standardized clinic BP and you target such a low target, then you may produce undesirable, hazardous, hypotensive effects, side effects. And clearly it gave a practice point that less intensive lowering was required for those with CKD who are prone to postural hypotension, who are frail, those who have autonomic neuropathy, or those who have terminal non-renal illness. So this is a tightrope walk for the physician or the nephrologist. What target do we go by in the CKD patient? If we go by standard control, then we may not be doing justice to the patient vis-a-vis protecting him from macrovascular complications like stroke. So we must try and target a lower systolic of 120 or less as told to us by SPRINT trial. But if we go too tight, then there's a danger of falling the other way, and there's a danger of having falls and hypotension. So we need to balance it out, and we need to also individualize as per the patient. Now, very importantly, SPRINT was a great trial, but it had its caveats, especially with reference to CKD. And what we learned from SPRINT trial, I have just summarized in the next 2 slides. The lower target of BP, that is less than 120 systolic, recommended by SPRINT, is beneficial to protect the heart and brain in some patients of hypertension. And there is no apparent convincing evidence that over-aggressive lowering of blood pressure is beneficial for renal protection because we have microvascular disease in CKD. So this low target doesn't necessarily apply to all patients of CKD. SPRINT trials recommendation applies only to some patients of CKD, and that too only from cardio and cerebroprotection point of view. Very importantly, we must not forget that SPRINT did not include diabetics. SPRINT did not include people lower than 18 years of age, and it did not include polycystic patients, and it did not include those with CKD stage 5. So these recommendations don't apply to diabetic kidney disease, which, as we know, constitutes over 40% of all our CKD. So we have to take some of these recommendations with a pinch of salt. Very importantly, what I learned is that these guidelines to be followed based what SPRINT has said, only if the method of measuring the office BP is AOBP. That is what the SPRINT had said. The method of office BP measurement must be modified to AOBP, not only in SPRINT type patients, but at least by us nephrologists in all patients of chronic kidney disease. And until AOBP becomes uniformly utilized, those utilizing the random or the routine office BP, ROBP, would be justified in adhering to a systolic target of 130 as recommended by most guidelines, because all data shows that there is a concordance between AOBP and ROBP. So an ROBP, which is the random or the routine office blood pressure, that 130 systolic is approximately equal to the or approximately equivalent to the AOBP of 120. So see what method is being used and then go and decide what target you want to use. And why sprint targets cannot be applied to CKD care in India today? Because the use of BP, AOBP is not practical routinely. Devices currently available for AOBP are expensive, but more importantly, doctors don't have the time and patience to do it. And the good thing is that the new KDIGO 2020 guidelines provided a compromise between routine office BP and automated office BP, and they called it as standardized office BP or SOBP, which approximates AOBP. And therefore, it allows us to abandon the old method of routine office BP. Now, what are the guidelines very quickly for lifestyle modification? KDIGO says patients with CKD should undergo moderate intensity physical activity for a cumulative duration of at least 150 minutes per week or to a level compatible with their cardiovascular and physical tolerance. 2C recommendation. Very importantly, what about salt? So in non-dialysis CKD, you need to restrict to less than 85 or 90 milliequivalents of sodium or less than 5 grams of table salt or less 5 grams of sodium chloride is roughly equivalent to 2 grams of sodium. This is a 2C recommendation. But another very interesting practice point here, 10 to 15% of CKD patients have salt losing nephropathy. They are what we call salt wasters. So this guideline of 5 grams salt restriction cannot be applied to these patients who are wasting salt. Therefore, we need to identify these patients upfront before we base our recommendations to them. DASH diet, which was given to us by JNC 7, is inappropriate for advanced CKD because it has a high potassium content. And according to new American dietary guidelines, people who have CKD should reduce their sodium intake to not just less than 2 grams per day, but less than 1.5 grams per day. What about which drugs to use? Very briefly, RAS inhibitors are the cornerstone in CKD. We know that. Strong recommendation for using them in CKD with diabetes in CKD stage G1, G4, and A2 and A3. A2 and A3 meaning you have micro and macro albuminuria respectively. If you have high BP in a non-diabetic CKD, then again RAS inhibitors are the drug of choice. But here the recommendation is weaker. It's a 2C recommendation. Very importantly, monitor the GFR, BP, potassium within 2 weeks after initiating or increasing a dose of RAS inhibitor. Reduce or discontinue the RAS inhibitor if symptomatic hypotension occurs or if there's uncontrolled hyperkalemia despite being on potassium binders and while getting ready for renal replacement therapy. Mineralocorticoid receptor antagonists help in refractory hypertension, but use with caution in CKD. And this is what KDIGO has said. Close monitoring of potassium, creatinine, and BP. Dual RAS blockade, definitely not recommended. 1B recommendation. Lastly, high blood pressure and kidney transplant recipients. First line agents are dihydropyridine CCB or RAS inhibitors with the usual precautions. This is a 1C recommendation. And I'm conclude on my last slide by saying that different guidelines give slightly different recommendations for target BP in CKD. This is confusing for us treating physicians and nephrologists. KDIGO guidelines are what we as nephrologists would like to follow. As explained earlier in my talk, the target BP will differ depending on which method of BP measurement is used. Some patients with CKD, especially the elderly, will not be able to tolerate the low BP targeted as suggested by SPRINT trial. One size, remember, does not fit all. Guidelines only help to guide the physician regarding management. Individualizing therapy is important, and individualizing the target BP for each and every patient is crucial in our day-to-day clinical nephrology practice. Thank you.
Thank you, Dr. Kripalani. Now I like to request Dr. Manas to introduce the next presenter.
Hello. I introduced Dr. Abhilash Sagra, who is now head of the department, associate professor in Ram Manohar Lohia Institute of Medical Sciences, Lucknow. He will be deliberating us an update on CKD MBD management in chronic kidney disease. Abhilash sir, please.
Good afternoon, everybody. I'm honored to be a part of this program, SRNM 1. Today, I'm really presenting the clinical practice guidelines on management of MBD in CKD and kidney transplant recipients. These are based on KDIGO, published way back in 2017, and this was the last update. The outline of my presentation is like this, starting from biochemical abnormalities, then discussing about some bone pathology, vascular calcification, targeting the levels, and finally ending with some recommendations on kidney transplant recipients. To define MBD, it's a systemic disorder of mineral and bone metabolism manifested by one of or a combination of the following: abnormalities of calcium, phosphorus, PTH, or vitamin D metabolism, abnormalities in bone turnover, mineralization, volume, linear growth or strength, and finally vascular or other soft tissue calcification. So we move ahead, and the first part is about biochemical abnormalities. The levels of calcium, phosphorus, PTH, and calcium phosphatase are supposed to be measured at the baseline starting from CKD stage 3. In children, we start a little earlier. I'll discuss it later. Why? We start at a stage of 2, CKD 2, and future monitoring is based on the baseline values which we get out of these investigations. This is a suggested guideline as to how we can program or schedule our investigations, future investigations. You can always change, or we can do it a little more frequently if desired and if being treated actively. Vitamin D has to be measured at the baseline from starting from CKD stage 3 to CKD 5D, and repeated on the basis of baseline value as well as therapeutic interventions that have been planned or done. The guidelines primarily follow the same one which are advised for the general population. And what is important is to see the trend of these values. Again, the values of serum calcium and phosphorus, again, with corrective serum calcium values, have to be seen and followed on a regular basis as advised. So how do we diagnose CKD? And an important aspect of diagnosing bone mineral disease is by BMD. It is an update from 2009 recommendation, where it was not routinely advised, but now it is said that you should do BMD testing to assess the fracture risk, and if you think the results are going to impact your treatment decisions. You can perform bone biopsy as well if you need to know about the renal osteodystrophy, and of course, if the results are expected to impact your treatment decision. But the problem is with bone biopsy is the availability of the low availability of experts to do this kind of biopsy as well as to read these biopsies. So it's still a lesser practice modality. In addition, serum parathyroid hormone levels or bone-specific alkaline phosphatase can be used to evaluate bone disease. But they are useful, but particularly in the high or very low values. When it comes to children, their growth have to be measured on a quarterly basis, and in terms of infants, and when in terms of older children, the growth has to be measured on an annual basis. Now, when it comes to vascular calcification, it has been advised that lateral abdominal radiograph is a useful modality to detect vascular calcification. It can be supported by an echo, which can detect absence or presence of valvular calcification, and these are reasonable alternatives to CT scans. And as has been seen, that valvular and vascular calcifications do reflect the amount of the cardiovascular burden which the patient has, the morbidity which he's facing, and in addition, they're also so reflective of the renal bone disease that is there in the patients. So the next part is about targeting the values. It is said that you serially measure the phosphorus, calcium, and parathyroid hormone levels, and they should be taken in together. Whenever you manage, you are not supposed to look at one particular value of phosphorus and then start phosphate binders. No, you have to take all the values in consideration at the same time and then decide what is the best modality. It is said that you should avoid hypercalcemia. The elevated phosphorus levels are supposed to be kept at the normal range. And in children, it is important to maintain serum calcium levels in the age-appropriate normal range. Why is it so? Because it has been seen that serum calcium levels were independently associated with low cortical bone mineral density. So it becomes important because the growing skeleton needs calcium. You need to maintain a little higher calcium levels in pediatric population. Decision about phosphate binders. I mean, it is said that you should not be using calcium-based phosphate binders to a great extent. But when it comes to pediatric population, the calcium-based phosphate binders are the preferred drugs. When it comes to choosing between non-calcium-based phosphate binder versus calcium-based phosphate binders, it has been seen that non-calcium-based phosphate binders have been shown to reduce mortality as a whole, whether it comes to pre-dialysis population as well as in the dialysis population. Consider the fact that, I mean, as I just said, the growing bones need calcium. So that's why the calcium-based phosphate binders are the preferred drugs or preferred phosphate binders in pediatric population. We should, when it comes to managing hyperphosphatemia, the dietary aspect has to be considered first. It is reasonable to consider as to what is the source of that phosphorus. Animals, those eating animal-based diet are likely to have a higher phosphorus load, as well as those who are used to having, say, ready-made food, which usually contains a high amount of phosphorus. Whereas when it comes to the vegetarian diet, these are of course considered to be the low phosphorus ones. And when it comes to dialysis population, of course, increasing a number of dialysis sessions can very well take care of the persistent hyperphosphatemia. When it comes to abnormal PTH values, it's not exactly what the optimum value is not known. So the KDO has given a very wide range, say from 2 to 9 times the normal PTH values. And what is important here is to see for the trend of parathyroid hormone levels. You see a persistently rising trend, you better get alert and see for the secondary causes like hyperphosphatemia, hypocalcemia, high phosphorus intake, and vitamin D deficiency. You correct these, many times you won't need to start a specific therapy for hyperparathyroidism. So what is to be treated? Severe and progressive hyperparathyroidism, and you can use calcitrol and vitamin D analogs in these patients. In addition, senic acid can be used in dialysis population. In children, again, calcitrol and vitamin D analogs can be considered. As I earlier said, the parathyroid levels, the range is pretty wide, 2 to 9 times the upper normal limit. And again, as I said earlier, the calcium antibiotics can be used in dialysis population. When it comes to pediatric population, the evidence in favor of senic acid is not that great. So whenever you're contemplating using senic acid in pediatric dialysis population, you better be very cautious because it can lead to some degree of hypercalcemia as well, which can be detrimental to their growth. When it comes to treating osteoporosis, it is said that in the earliest stage of CKD, say CKD 1 to 2, or maybe up to CKD stage 3, if you have a high risk of fracture or an osteoporosis, the guideline is similar to the general population. But when it comes to later stage of CKD, say CKD beyond CKD stage 3 to CKD 5D, it is important to take into consideration the magnitude and reversibility of the biochemical abnormalities and the progression of CKD as well when you consider planning for treatment or a bone biopsy. When it comes to children, use of growth hormone is advisable when there is a high deficit, provided that we have taken care of malnutrition and other biochemical abnormalities simultaneously occurring. When it comes to transplant recipients, not much data is there. In the first, say in the immediate post-transplant period, the weekly measurement of calcium and phosphorus levels is advised until they stabilize to a value which is within the normal range. Later frequency of monitoring is based on those baseline values and the rate of progression of CKD. The frequency is almost similar to the general CKD population, and the frequency can be modified whenever you are actively treating the abnormality. Again, vitamin D levels have to be measured similarly as to the CKD population, and it has to be treated as per the guidelines suggest for general population. And it's almost similar to the recommendations for CKD population. BMD testing again follows the same rules as the general CKD population. Unfortunately, there is not sufficient data to recommend treatment beyond the first 12 months of transplant. But in the initial 12 months, if the GFR permits, like it's above 30 mils per minute, the treatment comprising of vitamin D, calcitrol, and anti-resorptive agents like bisphosphonates or denosumab, these can be considered, provided the GFR permits. The low BMD management is again in the transplant recipients is almost the same when it comes to advanced degree of renal failure. So what are the key messages? Key messages are BMD testing is advisable when you are planning to actively treat it or the results are supposed to impact your future management. It's important to emphasize that the values of serum calcium, phosphorus, and pathormones are interlinked, so interdependent. So the clinical therapeutic decision has to be made considering them together. And that hyperphosphatemia is supposed to be treated when it is progressive and persistent. Excess exposure to exogenous calcium in adults is harmful across all CKD stages. And it is reasonable to consider a dietary phosphorus intake evaluation while managing hyperphosphatemia. And the prime and opera studies have reiterated that we cannot be using calcitrol in every other patient or its analogs in CKD beyond CKD stage 3. So it's not recommended. And the vascular calcifications are associated with high cardiovascular mortality. Thank you.
Thank you, Dr. Abhilash, for concluding lecture in time. So may I request Dr. Manish Malik to be ready with his slides. I was told that Dr. Vinand Varga is not available at this moment.
Even Dr. Manish Malik is gone for COVID duties, so he will not be able to take up the talk.
Okay,
we
so
can
then
move on to the next one.
So we'll go to the Dr. Anurag Gupta.
Yeah.
So can I have his introduction slide? Yeah, Dr. Anurag Gupta is a senior consultant nephrologist at Sir Gangaram Hospital, New Delhi, and he will be deliberating on a very important subject, that is hypo and hypernatremia in patient of CKD. Let's hear him, and we'll have question and answer after all the talks are over. Thank you. Thank you.
Dr. Anurag Gupta, have you connected?
नहीं मैम अभी तक सर नहीं आया।
अच्छा तो next we can move on to the next talk then.
I think Dr. Abhilash Chandra again for management of anemia.
Yeah.
Yeah, Dr. Abhilash, we are lucky to have you again at this forum. Please start your presentation.
Yeah, just a moment. I'll be setting it. a little earlier.
Dr. Anita, Dr. Shruti Topawala is going to present his next topic, I think. After Dr. Abhilash. Dr. Abhilash, you can share your screen, please. Thank you.
Yeah, thank you, sir. My next topic is the management of anemia in CKD population. Again, the guidelines which I mentioned is primarily from KDIGO guidelines, we published way back in 2012, and I'll add subsequent recommendations by other societies which have occurred over in the last 2-3 years as well. So this is how I'm going to proceed in my talk, starting from introduction to magnitude of the problem, etiology, clinical features, diagnosis, and finally treatment. So first we need to define anemia in CKD population. Starting from in men it is beyond 15 years of age, it is 13, in women it is 12, and if you go back to say a younger population, say between 6 months to 5 years of age, it's just 11. So whenever you are diagnosing and managing anemia in this population, it's important that you should know whether they are actually anemic or not, and then you start your management or investigations. Why is a few words about anemia in CKD? The prevalence is pretty high, and it's an important predictor of cardiovascular mortality. Is a risk factor of death in a number of studies. It's more common in diabetics, relatively uncommon in earlier stages, and as the CKD stages progress, as the CKD worsens, the problem becomes worse, and the screen should begin at CKD stage 3. Coming to the magnitude of the problem is a big one. So I have just one slide on this section. As you can see, with the creatinine value of just 2, the population with the hemoglobin of less than 10 is just 14%. And as the creatinine goes up and up, just beyond creatinine 4, almost 60% of the population is having a hemoglobin of less than 10. So that shows the burden of anemia in CKD population. Coming to the etiology and clinical features, before we move ahead, we should know what is happening over here in the erythropoiesis section, starting from stem cell to burst cells, burst forming unit, erythroid cells, and colon forming units. I mean, the earliest, what I mean to say is that the earlier stages are dependent on erythropoietin, which is coming from the kidneys, and the later stage from erythroblasts to reticulocytes, these are RN dependent. So these are two very important things which are going to matter a lot when you're managing anemia. This is how the activation of receptors occurs via erythropoietin. A few words again about erythropoietin. The primary production is in the liver in the fetus, and soon after birth, the kidneys take over and they become the primary site of production. To some extent, it's also secreted in liver as well in the later stages of life. And the site of production is peritubular capillary endothelial cells and peritubular fibroblasts. So the reason why you have a lesser production of erythropoietin is as the CKD progresses, there's more and more fibrosis and the more and more destruction of these cells. So you have less erythropoietin. It's pretty straightforward. Coming to the causes of anemia, you have a long list of causes. The first and the most important one is the erythropoietin deficiency, followed by iron and blood loss. There is reduced erythrocyte survival duration, maybe to the extent of 1/3 reduction in the erythrocyte survival. There is an inflammatory milieu in CKD population. A number of infections happen in their life, and it goes on to considering the fact that they are also immunosuppressed. You do encounter a number of infections, and every infection has a chance of further lowering down the hemoglobin. Simultaneously, they can have a hematological disease. They have hyperparathyroidism, which is more pronounced in the dialysis population. There is hemolysis, and concomitantly there are nutritional deficits, and there is high level of hepcidin. So the causes are many, and we need to identify the particular cause to be able to treat and manage anemia well. This is how the inflammatory markers affect your blood production, the RBC production. First, they increase hepatic synthesis of hepcidin. What hepcidin does is it decreases the absorption of iron in the GI tract, as well as release of iron from the reticuloendothelial cells to the RBCs. So, and it again inhibits erythroid proliferation. It inhibits erythropoietin release from the kidneys. So it's a multi-dimensional thing, and the effect is at various levels. So come to the potentially correctable and the non-correctable factors. The easily correctable ones are like the iron deficiency, vitamin B12 deficiency, hyperthyroidism, ACE inhibitors, and non-adherence. You can stop ACE inhibitors. Anemia improves. Treat hypothyroidism, anemia improves. Now there is another group which is partially correctable, like the inflammation one. We can take care of the inflammation to an extent, but at times it remains to a certain level. Under dialyzed patients can be dialyzed to a little later frequency, but to higher frequency, but there is a limit to it. Hyperparathyroidism can be taken care of. So, and malnutrition, these are correctable to a great extent, but may not be completely correctable. And then there's another group which is very difficult to correct. It's almost impossible, like concomitant hemoglobinopathies, or if there's a bone marrow disorder like aplastic anemia or such, which is almost like it's very difficult to manage CKD population with these disorders simultaneously occurring. So what is the consequences of anemia? It reduces the quality of life by causing easy fatigability, the exercise capacity decreases, the cognitive function declines, and there is a left ventricular hypertrophy, which at a later stage leads to high degree of cardiovascular mortality and morbidity. There can be progressive renal damage by way of hypoxia, and per se anemia is related to increased mortality. So when do we investigate? We investigate in all CKD stages, and it is done annually. I'll describe it in my later slides. Yeah, this is it. It's very simple. Like you investigate them manually in CKD stage 3, then you can continue increasing the frequency. And if the anemia is not being treated with an erythropoietin, the frequency is again on the lower side, say every 3 months or at least monthly in CKD dialysis population. The frequency, of course, increases when you are actively managing anemia. These are the basic battery of tests which you order at the first point: hemoglobin, peripheral blood ischemia, reticulocyte counts, ferritin stores, transferrin saturation, reticulocyte, hemoglobin content or percentage of hyperchromic RBCs, folic acid, vitamin B12. So coming to the treatment part, as we saw in the consequences of anemia, you correct anemia and you improve the overall quality of life. The cardiac indices improve, mortality improves, decreases. All the problems with anemia subsides as you manage anemia successfully. So you correct the nutrition deficiency, you prevent any blood loss, you provide erythropoietin, you correct the uremic environment, you dialyze them adequately, the anemia is going to improve. And if at times there's anemia is of very severe degree, you may require blood transfusion as well. Iron is very important. I'll be discussing among these subsections. Monitoring, as I just discussed, it has to be every month during initial erythropoietin treatment, and at least every 3 months in stable erythropoietins, erythropoietin treatment and hemodialysis CKD non-treated with erythropoietin. Targets ferritin in hemodialysis population, the ferritin is kept a little higher at around 200 nanograms per ml. Transfer saturation is more than 20%. Of late, in the newer studies, even transfer saturation of more than 40% has been targeted. In non-dialysis population, the ferritin can be kept, should be kept above 100 nanograms per ml. Recommendations for when to treat with iron. Now, adult CKD population with anemia who are not actively being treated with iron or erythropoietin, it is advisable that you give a trial of IV iron who are on actually oral iron therapy, and who are not taking iron at all. You give them a 3-monthly trial of oral iron therapy. You target a transfer saturation of more than 30% and a ferritin of more than 500. Things do improve. Patients who are on erythropoietin therapy, the recommendation is almost the same. The balance shifts towards IV iron when you are dealing with the hemodialysis population, and a trial of oral iron therapy for say around 3 months who are non-dialysis dependent, and things do improve. These are the couple of oral preparations like ferrous sulfate, fumarate, or you can choose either depending upon the availability, tolerability, and the cost. Parenteral therapy, dextran is almost obsolete now. The prime agents that are being used are iron sucrose. Is cheap, but the doses are a little, the frequency of doses is a little higher. Carboxymaltose can be used at a larger dose, say 1000 milligram at one particular setting. Iron isomaltoside can be given at a pretty fast rate, say 1000 milligram in a span of say 20-30 minutes. So can you use either? This is how the erythropoietin developed. It started way back in 1989, and darbepoetin was introduced in 2002, and sera was introduced in 2007. So virtually, what is important is that they are almost the same. They act on the same EPO receptor, but they differ in biophysical characteristic, the receptor binding affinity, and their longer half-life as you progress towards sera. So that defines the frequency of administration. So if you are starting erythropoietin therapy, this can be the starting dose, say 20 to 50 international units per kg 3 times a week. Darbepoetin can be given just once a week, and in stable hemoglobin levels, it can be given once every 2 weeks. Sera, it can be given every 2 weeks, every 4 weeks. So it says that what I'm trying to say is that as you progress towards sera, the half-life increases. That allows you to give a lesser number of injections and becomes comfortable for the patients. So now, coming to the KDU guidelines, as I said, treat all the possible correctable causes. Whenever you encounter anemia, first treat the correctable causes before moving towards erythropoietins. If you are, what you are trying to do is you are trying to reduce the number of blood transfusions. And when it comes to managing anemia, you also need to look into the some high-risk population, like the population who has had a history of a stroke, who had loss of vascular access in dialysis, who have uncontrolled hypertension. These are at a little higher risk when you are using erythropoietins. I'll tell you why in later of my slides. Again, erythropoietin is advised to be used with great caution whenever you are encountering a malignancy in which cure is the anticipated outcome. So try to avoid erythropoietin in those set of population. When it comes to non-dialysis dependent CKD population, hemoglobin concentration of more than 10, you do not use erythropoietin. More than 10 is good enough. Whenever the hemoglobin falls below 10, you look for the symptoms attributable to anemia. If there is complaining of fatigue, he's complaining of poor quality of life, then you can still try between a hemoglobin of 9 to 10. You can give erythropoietin to improve the hemoglobin. When it comes to dialysis population, the recommendations are almost the same, but you do ensure that hemoglobin concentration doesn't fall below 9. So you start your therapy above 9 grams of hemoglobin. What is important is that you individualize your therapy. Some may have a higher quality of life at a hemoglobin concentration of more than 10. So at times you may have to use erythropoietin in those set of patients as well. When it comes to dealing with pediatric population, you have also supposed to look at other aspects of his life, like the overall quality of life, the school attendance, the performance, and how are you going to avoid using blood transfusion. So all these things are taken into consideration whenever you are managing a pediatric population. Coming to the maintenance therapy, what we target a hemoglobin concentration of somewhere around 11.5 in almost across the CKD population. We generally tend to avoid letting the hemoglobin cross the level of 13 grams per DL. There are related side effects, increased number of strokes, increased cardiovascular mortality. So do not allow hemoglobin to cross beyond 13. In pediatric population, the target hemoglobin range is roughly the same, between 11 to 12. How frequently do you measure the hemoglobin by erythropoietin? You measure it weekly when the hemoglobin is on the lower side. Once the hemoglobin is stabilized, you can increase the decrease the frequency of monitoring. What is the goal? Goal is somewhere an expected increase of 1 gram per DL in the first month of treatment. If it is beyond this in the first 2 weeks itself, then you reduce the erythropoietin dose by 25 to 50%. But while increasing the erythropoietin dose, do not forget to measure the blood pressure as it may increase. What if there is hyporesponsiveness? You check the erythropoietin dose. Is it an appropriate dose on the weight of as per the weight of the patient? You continue increasing the dose, but do not go beyond the initial weight-based dose of erythropoietin. It should not go beyond 2 times. Those who remain hyporesponsive to erythropoietin, individualization of therapy is advised. You check for the decline in hemoglobin concentration, at what dose the erythropoietin has to be continued, and does he require blood transfusions as well if you're not able to increase the dose of erythropoietin. So when do we transfuse blood? We tend to minimize because there are risks associated with blood transfusion, as we are all aware of. When you are contemplating organ transplantation, is on the organ transplant waiting list, you would generally avoid blood transfusion because there is a risk of allosensitization. But at times, the benefits of blood transfusion outweighs the risk. So when does it happen? When there is ineffectiveness of the erythropoietin therapy, or when there are concomitant hemoglobinopathies, or there is bone marrow failure of blood cell production, there is high degree of erythropoietin resistance. In those cases, you may need to give blood. Or suppose there is a concurrent malignancy or history of recurrent strokes, you tend to avoid erythropoietin, and then you'll have to resort to blood transfusion. Whenever you're transfusing blood to a CKD person, do not use any arbitrary hemoglobin threshold, like I'll use 8, I'll use 7. Use your judgment, clinical judgment, whether he has symptoms associated with anemia and how significantly the symptoms have improved after blood transfusion. So do not forget to clinically observe the patient for the symptoms of anemia. When it comes to adjuvant therapy, I use vitamin C, vitamin D, vitamin E, L-carnitine, pentoxifenone. These are not advisable as adjuvant therapies. Whenever there's an acute situation where you need to transfuse blood, again, benefits outweigh the risk. Like there's an acute hemorrhage or unstable coronary artery disease. And whenever you require a rapid correction of hemoglobin, you can go for blood transfusion. So this is a scale. So we can see that there is clearly no benefit beyond a hemoglobin concentration of 12. So there's an increased risk of a stroke or cardiovascular risk. And allowing the hemoglobin to fall below 9, we again increase the risk of mortality and subjecting the patient to a poor quality of life. So before concluding, I'd like to take you all through this case. This is a 54-year-old gentleman with diabetes, hypertension, and coronary artery disease. He's been treated with CKD. His estimated GFR has declined in the last 2 years. Any reports of increased fatigue? You check his blood cell indices, hemoglobin, iron concentration, folate, and vitamin B12 has found to be normal. What do we do? And what is the likely cause of this anemia? So is it just diabetes? Less likely. It would have been managed pretty well. Whether it's iron deficiency, as I just said, iron levels are normal. Multiple myeloma, nothing suggestive of multiple myeloma. So there is a relative erythropoietin deficiency. You treat him with erythropoietin. That is the best approach in this patient. We take up another patient who is on hemodialysis, has a long course of she's a lupus patient. On erythropoietin treatment, her hemoglobin is 7. It increases to 9.8, but fails to increase beyond this. You check her for her lupus activities, the disease is inactive. Serological tests are normal, but when you check the erythrocyte indices, you see a ferritin concentration of 26 nanogram per ml and TSAT is just 13.7. So what is your next step? Lupus treatment drugs, it's already under control. Increased dialysis time, it may help to decrease the uremic milieu, but is it the best? Let's see, increase the erythropoietin dose. She's already on good amount of erythropoietin dose, so less likely to improve further on it. Increase of dose. Change to ferritin dialysis is not the best option. Treat with IVIRN. Yes, IVIRN has to be given in a dialysis population with such poor iron indices. This is a flow chart when we are managing anemia in these patients. Check him if it's normal, don't go and do anything. If yes, follow the workup of CBCs, indices, retic counts, TIBC, ferritin, transfusion saturation. It's normal. Treat with erythropoietin. If it's not, treat the iron deficiency. If it's not there, look for other rare causes like blood loss, hemoglobinopathies, B12 levels, folate levels. And if there's iron deficiency, treat with the iron. Anemia gets corrected, it's fine. Not corrected, you again can resort to erythropoietins. To conclude, it's a widely prevalent issue. Anemia in CKD is progressive. Iron deficiency and erythropoietin deficiency are the two most common causes of anemia in this population. Correction of anemia improves both morbidity as well as mortality. Iron and erythropoietin, again, the mainstay of treatment in this population. Different erythropoietins vary in duration of action, and therefore the frequency of administration also varies. So you target the appropriate hemoglobin levels and things improve. Thanks for patient listening.
Thank you, Dr. Abhilash, for a wonderful lecture. And now we move on to the last lecture of this session, that is lifestyle modification, which is very close to my heart. And Dr. Shruti Topiwala is a consultant nephrology, and he's working at Global Hospital Mumbai, and Dr. Sir H.N. Reliance Foundation Hospital and Research Center. So over to you, Dr. Shruti, and she very interesting topic, obviously, for lifestyle modification, especially in the sick patient of CKD.
Thank you so much, Dr. Sudeep, for introducing me. And I would like to start off with thanking the organizers for thinking me for this really good topic. I mean, see, sometimes people think, array, lifestyle modification, there's not much. but there is a lot, because as nephrologists, when we look at patients, we feel that why did this happen? So the starting is lifestyle, ending to everyone knows, but we have to see that we don't enter the mess rather than creating a mess. So that is why I would like to take you through the journey of patients where, you know, at every step as a multidisciplinary team, me and you, along with our dietary team and our social worker teams, can help our patients. So a typical case, 35-year-old male, manager at a multinational company, family history of diabetes and hypertension, which everyone has nowadays. He is occasional smoker. He is a social alcohol intake person, wherein there are multiple parties. Now because of COVID, it's a different thing, but otherwise a fully social life. Intermittent headache because of the stress which the patient says, and he requires painkillers. BMI is 30. Blood pressure is 140/80. Lack of exercise routine, saying that there is no time. Health check, which is done every year for every multinational corporate person. There is a little hyperlipidemia. The HbA1c is 6.8. Urine routine is normal. So if you see this, I can see a potential of this person blooming out into a cardiovascular disease or a kidney failure or a cerebrovascular accident. So I would want to first take you, today we are in advanced renal nutrition course. So let me first tell you what is chronic kidney disease. It is a type of kidney abnormality where a marker such as a protein or there is a decreased kidney function for more than 3 months. So this is a very subtle definition that you have a structural or a functional defect for more than 3 months and you categorize in a chronic kidney disease. What is the incidence? Quite a lot. 1 in 4 Indians have chronic kidney disease. Less than 10% are even aware that they have a CKD. You can lose up to 90% of your kidney function before you even experience any symptoms. Major independent risk factors for cardiovascular disease, because if you have a CKD, you will have a cardiovascular disease. Lifelong dialysis transplantation becomes the only option when you reach end-stage kidney disease. And believe me, many patients reach end-stage when they come us, because when they meet us, they are like, डॉक्टर किसी ने बताया ही नहीं कि हमको ये करना चाहिए. हमारे घर में यही प्रथा है, हम यही करते आए हैं, ऐसे ही खाते आ रहे हैं और ऐसी ही रहन सहन है. So this is very difficult because somehow in our country the lifestyle takes a back seat. This is a common disease. It is harmful, but it is treatable. It is preventable. So that is why this becomes a very important topic. Now, what are the leading causes? Diabetes, blood pressure, glomerulonephritis, cystic kidney diseases, and others. Now, if you see these others, the others is going up nowadays because people are obese, people are smokers, people are taking multiple alternative medications because they feel that alternative medications are going to help them to prevent diseases or to manage the disease they have. Like this person we have taking painkillers. So what people do, people have headaches, they may have high BP and that must be giving a headache. But what they do is that they will take a painkiller and have the headache subsided and they will continue with their work, because work is more important than their health. They have to understand that we all need to balance ourselves. Today's doctors, even we need to balance ourselves, that we have to keep working, but we have to balance. That doesn't happen. And sometimes there's overdose of drugs because there is a painkiller in there. There are alternative medicines there. There are recurrent UTIs because people don't use washrooms. People don't drink enough liquids and they have recurrent UTIs, renal stones. So see, our lifestyle has so much to play with our organs inside. Obesity, if you look at being overweight, it does not increase the risk of CKD. But when you're obese, when your BMI is more than 30, it increases your risk of getting a chronic kidney disease. Similarly, smoking. So if you have a 25 to 49 pack year history, you will have a 42% increased risk as compared to non-smokers. And if you have more than 50 pack years, then you have 105% increased risk of decreased GFR. So that means that, you know, every small injury or insult we do to our body, somewhere or the other goes and affects our organs. So we should be careful not to abuse our system or our body because we live in it. Now, CKD and CVD risk. Now, obviously, if you have a bad lifestyle, you will have a parallel chronic kidney disease coming up, and you will have a cerebrovascular event or a cardiovascular event. If you have a chronic kidney disease, again, it is a milieu to cause a vascular event. So CKD and cardiovascular disease go hand in hand. So if you have a CKD, as it progresses, your risk of CVD increases. And what are the stages of CKD? I'm sure most of us know about this, but we have to remember this, that at early stages of CKD, every lifestyle modification will help. It will prevent, it will reverse. But once you are at stage 4 and 5, there will be no reversal, but there might be stabilization. There might be a prevention of maybe a heart disease or a brain disease, given that, you know, there are multiple things happening with CKDs. So the next question is, can it be treated when you have a chronic kidney disease? It can be treated, it can be stabilized, but it cannot be reversed. That reversal is a very important thing. You find any treatable cause, you treat it. But you see to it that your lifestyle first improves. So lifestyle. This is the first and the foremost for any and every disease today. Prevention is possible because if you detect CKD very early, you can reverse it. When you are at a later stage, it becomes very difficult to reverse. And sometimes it is difficult to stabilize also because you have crossed those borders. So who are the patients at risk? Because we need to understand who is to be targeted. People with family histories like our patient has. People with low birth weight. People with impaired fasting glucose or impaired glucose tolerant test. People who are obese like our patient. People who have lack of exercises and sedentary lifestyle. Dietary patterns, having non-vegetarian food, high fatty foods, sweets, desserts and salt intake which is high. So these are the typical type of populations who will be at risk of multiple other things. So what is a lifestyle disease? Lifestyle disease is simply associated with the way a person or a group of people lives. Because every family has a lifestyle, I would say. It will not be that a person in the family will be very fit and very health freak and the others are careless. One is careless, the entire group is like that. So, you know, you have to understand it's the way we live. What are these lifestyle diseases? Now, these lifestyle diseases are the diseases which are going to be a harbinger of CKD or CVD or a cerebrovascular disease. So, obesity, metabolic syndromes where you have diabetes, you have obesity, you have hypertension, type 2 diabetes, atherosclerosis with heart disease and stroke, chronic obstructive pulmonary diseases, diseases associated with alcohol and smoking. So these all are lifestyle related diseases. This is what we have done to our body. Genetics has nothing or nature has nothing to do with this. So what are the risk factors? We all know this at the back of our mind: unhealthy eating, lack of physical activity, alcohol, smoking, drug abuse. Now, if you see, all these things were present in our patient and he is just at the brink of getting some kind of a damage which has already started in his body. Now, what are the lifestyle effects on the blood pressure? See, because the main things which these lifestyle will affect is your blood pressure. It will affect your sugars. It will affect your organs. Okay. So now, what is the modification you need? Suppose you have a high BMI. You have a weight reduction. So if you every 4 millimeters of mercury drop in BP is noted for every 5 kilos weight loss, which is a very positive feedback for our body. A dietary sodium restriction, you reduce the dietary sodium restriction to 2 to 2.4 grams per day, and it will bring your BP down by 4 to 7 millimeters mercury. So see, medications may not be required if your lifestyle is proper. DASH diet. You have fruits, you have veggies, you have low saturated and total fats. And what will happen is that 5 to 11 millimeters of mercury, the BP will come down. Hence, a DASH diet is prescribed for BP patients. Physical activity, if you do an aerobic activity of 30 to 60 minutes a day, it will bring the BP down by 5 millimeters of mercury. Moderate alcohol consumption, that is no more than 2 drinks per day, and what you can do is you can restrict it and your BP will come down by 3 millimeters. So very important understanding this requires. So salt, how does it work? if you have a decreased sodium intake, and this evidence is very high, that you will have a decreased systolic pressure. Ultimately, understand that sodium molecules are going to bring your BP up, and it will increase the systolic BP and the diastolic BP. It will decrease, it will have a positive effect on decreased cardiovascular disease, stroke, and progression of CKD if you reduce the salt intake. Because ultimately, if your blood pressure reduces or it becomes normal, the pressure inside these organs, like the glomerular pressure, the intracerebral pressure, the cardiac vessels, are all protected. But the evidence is moderate for these things because it's an indirect association. What are the lifestyle modifications suggested for CKD and cardiovascular diseases? I've merged this from the KDIGO guidelines and the Indian CKD guidelines, that it is SNAP: smoking, nutrition, alcohol, physical activity. So you stop smoking, you take a low calorie diet, you take a low salt diet, reduction in the alcohol intake, physical activity, weight reduction. This is a lifestyle modification which is supposed to be there with all of us, but we mutilate it and we just abuse our body to no end, wherein all these balance gets spoiled. Now, what does Indian CKD guideline? This is the last guideline release and still valid. It recommends achieving and maintaining a healthy weight. See, overweight is not a very big risk factor, but obesity is a risk factor. So maintaining your weight is required. It improves your insulin sensitivity. It improves your lipid profile. Lowering your salt intake to less than 2 grams per day. Now, this 2 grams is recommended also by the KDIGO guidelines in 2020. So they have looked at what is the salt intake of the population, and Indian population, you will not believe, is 11 to 12 grams per day as a normal salt diet. So unless we consciously reduce it, it will not come down. And 2 grams per day is the ideal salt recommendation for any person at any age to prevent target organ damage. Recommend undertaking exercise program compatible with cardiovascular health. Very important. We have to tell the patients to exercise at least 30 minutes 5 times a week or 150 minutes a week. Why this is important? That it is going to help maintain your weight, it is increasing your basal metabolic activity, it is also helping you maintain your sugar levels. But we have to be careful, we have to look at the cardiovascular health and then only advise exercises. So in MDRD, post hoc has clearly shown that the physical activity is directly related to mortality and morbidity. Alcohol intake, no more than 2 standard drinks per person, and no more than 1 standard drink per day for women. So it has shown to reduce both acute and chronic increases in the blood pressure. So this is a correlation which has a moderate grade which is given, so which is very important. Now this is the KDIGO guidelines, like I have written, long and short, less than 2 grams of day of sodium, so less than 90 millimoles or less than 2 grams per day of sodium is important to maintain the blood pressure in a CKD patient. This is the work group recommendation, and the cardiovascular endpoints, the CKD endpoints, mortality, morbidity endpoints, everything demands 2 grams of salt. For children also, this is what is important, is what has been told. Now for children, some papers have said that more than 2 to 5 grams, you can try to juggle between them, but you have to see to it that by any means you have to control the blood pressure. There is a little bit of a caveat that for the DASH diet, you need to control the salt substitutes, because sometimes a potassium containing substitute will be given for the salt and the hyperkalemia will occur. So we have to be very careful when we give substitutes. So with my dietitian, what do? I give them amchur powder, I give them tamarind, I give them lemon, I give them tomato. All these things are substitutes which do not have sodium. They flavor the food and people don't feel the deficiency of salt. So very important to understand the patient as well as their body. Physical activity, like I said, the Indian guidelines and the KDIGO guidelines both are saying that do 150 minutes per week at least, and any form of intensity has to be decided jointly with the cardiovascular health. And every lowering of BP is going to help you in the morbidity and mortality. So what about BP? Monitor the BP, take medicines properly, follow a low salt diet, stop smoking, lose weight, drink less, stay active, and yoga therapy. These are the lifestyle modifications which are advised for BP if you amalgamate all the recommendations. Now, what about diabetes? Very important. Diabetes is the #1 killer for kidneys in our country and the capital of the world for diabetes. So about 1/3 of the patients with diabetes will develop kidney failure. So this is an important point. Reducing the amount of salt and the blood pressure is the common way to reduce the injury to the kidneys. Other things along with diabetes like urinary infections, stones should be prevented, and you should look to it that no adverse effect drugs are given to these patients. So what are the dietary interventions suggested? No brainer. You need more fibers, legumes, plant-based proteins, unsaturated fats. You need low amount of processed meat. So basically we need a plant protein rather than an animal protein. We need a low salt diet, a high fiber diet. We suggest maintaining a protein intake of 0.8 gram per kg per day. Now this 0.8 grams will be in the earlier phases of CKD. As we go ahead, we will have to reduce the protein intake and we'll have to keep it as the plant protein. Patients with hemodialysis will require higher protein because that is required for the metabolic needs because it's a catabolic state. Sodium intake again should be less than 2 grams per day. A shared decision and a multidisciplinary team should be treating a patient when you have a diabetic patient because you need sugar control very tightly. You need to impress on the patient that, you know, every time you do something and the sugar spikes up, your brain and your heart and your kidney are suffering. We need a team of people to help people and their families cope up with whatever advice we are giving, because it's very easy to give an advice to a patient, but after they go home, they go through hell because they don't know what to eat. We have to teach them cooking skills sometimes. We are lucky to have a very good dietitian with us, Ms. Zamrud, because she is very well versed with all the tips given to the patient and the patients are happy. They're happy, we are happy because the kidneys, the head, the heart and the brain remains happy. But we need dietitians to understand the patients and their families. Now, this is the KDIGO 2020 presentation, which they have said that you need fruits and vegetables to be 50%, you need whole grain starchy vegetables to be 25%, and animal or plant proteins to be 25%. But we would suggest more of plant proteins because the animal proteins will be more acidic and it will have more blood urea nitrogen impact. Again, physical activity, no brainer. Everyone needs physical activities and that reduces your sugars. It increases your insulin sensitivity. So very important. So it is like a multi-pronged attack which we need to do, wherein the patient feels we should make a bubble around the patient, wherein, you know, everything is protected. So exercise, nutrition, smoking cessation, lipid management, blood pressure control, glycemic control. Very important at the base of the pyramid. Then comes your medications, which is the second part, and then comes the blood thinners. So what happens is that the base of the pyramid is lifestyle. So everywhere, unless you attack the lifestyle, we are not going to reach anywhere. So the nuggets: control BP, control sugars. What is the control I need? BP should be 120 to 130 by 70 to 80. HbA1c has to be 6 to 7, not more than that. We have to see that the follow-up happens regularly because the albuminuria and the creatinine have to be managed. They have to be given a list of medicines which are not to be taken. Diet, exercise, smoking cessation, limiting alcohol. Very important. So this all remains common for every kind of organ we have and protecting them. Okay. Now, what are the tips we give to the patient to do regular exercises, like our typical patient of multinational corporate, which we have, that he doesn't have time. So what happens is we tell them, take stairs instead of lifts, walk to the bus stops, walk how much ever you can in between work. So all these tips should be given. And there are studies which say that all lifestyle modifications are going to reduce the end organ damage. So I end with the last slide saying, what are the 10 commandments to prevent a CKD? Have natural foods like vegetables, fruits, nuts, and cereals. Avoid fried and processed foods. Exercise regularly. Watch your weight. Control your BP, control your sugars, get a regular check at least once a year. No unnecessary painkillers, very important in today's world. Do not ignore stones or infections if they are there, and avoid alternative therapies. Thank you.
Thank you very much, Dr. Shruti Topivara, for alluding a very interesting topic, that is lifestyle modification, which is often not taken seriously by the VBG physician. Dr. Manas, do you see any question, any query by the audience? Should we start our panel discussion and discuss some issues or some points regarding presentation? I don't see any question in the chat box, so I'll go to the first topic, that is a guideline of hypertension. So, so Dr. Kripalani,
yes, sir.
I just want to have some discussion on that. According to ACC guideline, the diagnosis of the level of blood pressure for diagnosing hypertension is lower down,
Yes.
solely based on the SPRINT trial and all that. And subsequent publication of ESC guideline in International Society of Hypertension guideline, NICE guideline, 3 major societies, they have stick to the same level of blood pressure, 140/90, for the diagnosis of blood pressure, hypertension. So what is your view on this, and why they have not changed? I don't know about the KDIGO. I'm sorry, I will not be able to deal about that.
I think in terms of diagnosing the blood pressure, I think the previous guideline, even which was given by JNC 7 very long ago, of saying 140/90 was probably correct. But in terms of the target, it's what target you want to achieve, and anyone with a comorbidity like diabetes, CKD, or a previous stroke, particularly in a young or middle-aged person, we are not talking about the elderly. There, the target should be below 130/80. So yes, the American guidelines have gone 2 steps further by making the diagnosis. They've changed the definition of hypertension, but they have also used that gray zone, that there is a high normal, like how JNC 7 had said there is something called pre-hypertension. So they have also gone on those lines. So in terms of definition, yes, there is a bit of an ambiguity, but ultimately we have to remember that to make the diagnosis, even the NICE guidelines say for a newly detected hypertensive, and now I'm not talking about CKD, now I'm talking purely of hypertension in the general population, they said you need an ambulatory BP 24-hour, and there the cutoffs are clearly different. So if you go by those, all the societies even today tell you that 135/85 or more in the daytime average is hypertension, or 130/80 in the overall 24-hour average is again the cutoff above which you will say he's hypertensive. So that's one thing which we have to remember, that in terms of the diagnosis, I would still ideally, where possible, use the ambulatory blood pressure monitoring to make a final diagnosis, unless the initial reading is very high, and we know that if the person is already in stage 2 or close to a hypertensive crisis, then you're not going to be doing ambulatory blood pressure. So that's my take on it, that in terms of diagnosis, I would still ideally want the ABPM.
Continuing this discussion on the ABPM, nowadays, it is widely available.
Yes.
And I think for the sake of discussion, for the stage 1 hypertension without any risk factor, you have to first confirm the hypertension with ABPM. This is a class 1 recommendation by all the guidelines,
correct,
whether it is ACC, ESC, ISH, or NICE.
Yeah.
So what about, which is simpler to use, it is the home blood pressure monitoring. So what is take on that?
Yes,
Would you like to recommend to the patient of home blood pressure monitoring, or would you?
Definitely, when ABPM is not feasible, home blood pressure monitoring comes a close second to it, except that home blood pressure monitoring will not be able to tell you about the nighttime BP and the extent of the nocturnal dip. But on its own, for the daytime blood pressure, if home BP is done in a resting state, which is the gold standard, we want it in a resting state, not in the middle of the day. And if you are going to do the home BP and you're going to get the average, it will give you a fairly good idea of where you stand in terms of the daytime average, at least, if not the nighttime average. So yes, if somebody is on that borderline zone and for logistical reasons you can't do an ambulatory BP, then definitely a very strict home BP monitoring for the next couple of weeks is definitely recommended.
Taking forward to this discussion, because this is a very important point where I would like to recommend to start home blood pressure monitoring, especially in a hypertensive patient, because that gives a clear idea how the patient is responding, and that also improves the compliance of the patient. That is important. So can we, so in your KDIGO guideline, SOBP monitoring, the standard, so so can you recommend that SOBP can be replaced by the home blood pressure monitoring in your point of view, whether?
It will, again, I repeat, it will complement the SOBP, but on its own, it may not be enough. You have to look at an average even in the office. If you're not able to do ambulatory BP, then you'll have to look at the average in the office and then complement it with the home BP. And therefore, in that situation, the SOBP is probably the best way to do it. And amongst the methods of SOBP, the automated office oscillometric devices are now the best and the recommended.
Nowadays, these mercury is being phased out because of the contamination issues and all that.
Yeah.
And Android are useless because they have
Aneroid has
very high,
gone up.
very bad. It should not never be used. So oscillometry remains the gold standard nowadays.
Yes.
Now some tricky situation comes to you that they come with the funny devices on the wrist hand devices, their watch, some specified watch. They come with the reading of those watches. So how do you deal with those patients?
I just don't go by those at all. Those digital, first of all, the wrist monitors should be abandoned
should
completely.
Never be used.
I've always been trying to tell this to some of the and I think most of, even other than Omron, some of the Indian companies are making good arm monitors. So I think by and large the wrist monitors, it's completely understood, and it's point well taken that the wrist monitors are rubbish. And no, I will not go by these watch BP. I know technology has a place everywhere, but I don't think technology in terms of a watch blood pressure can replace what we are doing in the clinic and what we are doing oscillometrically at home with the standardized Omron or any of the other good monitors. Many companies making very good validated monitors now. So I would completely rubbish those.
Maybe after 5 years we will be using those monitors. Maybe because the devices are validating. They are having tremendous amount of data. Regarding use of these various methods. Dr. Manas, would you like to have some
comments? If I would just like to make one more point vis-a-vis the definition. Even in the ACC AHA guidelines, whenever you make a diagnosis of hypertension in a new patient, okay, I just want to emphasize this point that you will be looking at other target organs and damage and other risk factors which the patient has. So the only point I want to make here is, irrespective of which method you're using, look at the patient comorbidities. Also, don't just look at the number and then base your diagnosis on that. So if somebody has an early retinopathy, but his blood pressure is still in the so-called normal range or high normal range, then this person already has target organ damage. You will have to treat it even if you are in the so-called normal range. So
it may be a case of masked hypertension.
Absolutely.
That can be detected by ABPM or home blood pressure monitoring.
Again, only be confirmed by ABPM. That's correct. So look at the other comorbidities, especially when you're getting a normal BP at home, but you have certain evidences like the person has obstructive sleep apnea, or the person has early CKD, or the person is pre-diabetic, or the person has, the lady has polycystic ovary syndrome. These are some of the situations where you will definitely need then an ambulatory BP monitoring and not just a home BP monitoring. So looking at the risk factors is also important, and the target organ damage.
So there is a paradox change regarding the management of hypertension over the last few years. See, earlier we used to just treat the number. 138 by 88, it's normal. Take it as a normal, and still most of the physicians take it as normal, and they don't consider the risk factor associated with 138 by 88. Considering then coming to that last talk, that ACC, or you can say the ESC, not ACC, ESC, ISH, they have all recommended stage 1 hypertension. Wait for the lifestyle modification to act for at least 6 to 12 weeks before you start pharmacotherapy, especially patient is in low risk group. That is the recommendation. Right. Most of the time we be the physician just write, but not at our institute, but we be the physician start writing prescription. Dr. Manas, would you like to have some discussion regarding the second and third presentation by Dr. Abhilash?
Yes, sir. Yes, sir. Regarding CKD MBD, the treatment in chronic kidney disease has remained same. Means like not very recent advances recently. So we have initially calcium based binders, and now non-calcium based binders, and almost the same kind of treatment is in. Next, coming to this diet part, management of CKD MBD in the role of diet. So it is already known that plant proteins have, even if they have more phosphorus content, but they are less absorbed, they are chelated, so they are not absorbed. So I would like to ask Dr. Abhilash that what is his experience about those who are predominantly non-vegetarian or presently vegetarian, and what is his advice according to Miss, like on the perspective of diet?
Yeah, possibly ma'am will be in a better position to answer this question. But yeah, it's true that of course the wider population in our setup is vegetarian, and we don't see that many patients who are primarily on animal protein, and they have a much higher bioavailability of phosphorus in the diet as compared to the vegetarian diet. So yeah, they are a little tough, on the tougher side to manage, and they require a high dose of phosphate binders. And primarily what I've been using is non-calcium based phosphate binders, and in most of the occasions apart from pediatric population. So yeah, we do counsel them to maybe shift to a higher percentage of vegetarian diet, and if still hyperphosphatemia persists, we do use the non-calcium based phosphate binders more often than the calcium based phosphate binders in the adult population.
Can I answer the question as well?
Yes, ma'am.
Dr.
So
Manas?
basically, I wanted to know that whether modification of diet should be an
that's what I'm going to talk
important
about.
part in phosphate management, or it is like it is always has to be drugs. That's what I wanted.
I'll answer the question. Dr. Manas, we've recently completed a project on hyperphosphatemia, FGF23, clotho, and vitamin D levels. So in this, we had, this project is on CKD stage 1 and 2, not on 3, 4, and 5. It's simply 1 and 2. We were just trying to see when the FGF levels start going up, when the clotho levels start coming down, and what is the situation with PTH in stage 1 and stage 2. So we found that even with the normal phosphorus levels, serum levels were normal. Within the normal levels, we found that if there were two groups, that the plant-based diet and patients who were non-vegetarian, basically non-vegetarians, we found that by manipulating their diets, the phosphorus levels came down, even though they were in the normal higher range of normalcy, they came down to the lower normal range, and the FGF levels came down, the PTH levels came down, and you'll be surprised that the GFR, within a year of strict dietary modification, the GFR went up to increased by 8 or 10 per year. And in case of patients who continued with their non-vegetarian diet, their GFRs declined from whatever it was, from I think 86 to down to 76 or something like that, but they didn't touch the CKD stage 3 ml per minute. So diet definitely has an important role in controlling CKD MBD, and particularly if you start controlling, because there are no recommendations to start phosphate binders in CKD stage 1 and 2. You can't start them before 3. So in that case, there are few studies which are, I mean, at least our study has shown that if you restrict phosphorus, dietary phosphorus, I'm not talking about supplementing them with phosphate binders. If you start restricting diet in stage 1 and 2, the GFR increases, the FGF23 levels come down. They had gone up, they were beyond range, but not very high, but yes, they were beyond normalcy. So they came down, Clotho levels started increasing, which is really required because they work in sync, Clotho and FGF. But there was no effect on the vitamin D. There was absolutely no. And the urinary phosphorus excretion, that decreased, over time, because the phosphorus levels decreased in their diet. And so the urinary phosphorus level at month 12, it showed there was a good, this was a very good comparison. And so towards the end of the study, we found very significant results. So I think dietary restrictions should be implemented right from stage 1.
Yeah, can I have one point to be discussed? This is very, very important. Whenever you go to a party and having some drink, and then somebody comes to you and asks, sir, kya beneficial hai alcohol, or what type of alcohol should we take? Can I ask Dr. Shruti, what is your take on Indian patient about alcohol? Because that is very important, and I may differ from your slides.
So whatever I see, my take on it will come only from the data which is available. So whatever the KDIGO guidelines and the Indian CKD guidelines are telling me, I will outline that. It might not reflect on the liver health. So we will have to look only from the kidney point of view. So a 2 drink maybe 30 ml into 2 per day for a male person, and 1 standard drink for a female is what is being allowed, not even recommended. So basically the alcohol is causing an increased metabolism, and it is causing an high blood pressure, and it is causing a damage to the organs. It may not directly involve the kidney, but it is indirectly involving the organs. So my take on it is limit your alcohol intake as much as possible. Yes, socially once in a while, if you want to have a drink or 2 with your friends, should be okay, but it should not be a regular feature. I'm sure every one of us knows our limits as to, be once a week, twice a week might become too much. What do you say? What is your take? I would also be interested in listening to your views.
I'll quote two major studies.
Yeah.
One is the inter-heart study, where the almost 2,500 patients of Indian patients were included, and that showed there was a 40% increase in the mortality when the patient was having regular alcohol intake, and that was not seen any other population. And the European population, US population, it was found to be beneficial. Number 2 study was the sentinel surveillance study. It was a study conducted in a captive population in the Australia area. The HL was one of the population, and where I also worked with that study for the sentinel surveillance study. There it was found that those who are taking alcohol, they were having higher blood pressure, the higher level of lipids, higher level of cholesterol, higher level of higher incidence of prevalence of diabetes, and higher level of higher prevalence of CKD. And their mortality rate was much higher compared to those who are not having drink. Having said that, then comes the confusion regarding the measure. What is?
I think the Indian genetics and the Western genetics will differ, and we might be more prone to atherosclerosis.
The difference comes from there are rather 3 or 4 reasons given to that we people are binge drinker. Binge drinking is defined
Correct.
as 0.08 level achieved within 2 hours, which is equivalent to 4 small pack, 4 small measure or unit, you can say. Now again, comes the questions: what is to be taken as a unit? In UK population, 10 ml volume by volume is taken as unit, whereas the US it is 14 ml.
14, yeah.
Yeah, so there is a difference. But
There's
for
a
Indian
difference.
population, the recommendation is you should not be having alcohol for sure. If you are having, you can't leave. Moderation is important. You already discussed about what is the recommendation. But any level of alcohol is harmful to your liver.
Correct. Correct. I mean, baseline, if someone asks me, doctor, एक cigarette पी सकता हूँ, I'll say मैं भी पी लेती हूँ आपके साथ. मतलब, if it was so good, patients ask you permission कि मेरे को तो ये mistake करनी है, लेकिन आप बोलोगे तो करूँगा. You know, something like that. So I tell them it's bad, it's
For
bad.
CVD, for CVD, the smoking is so important. It's said that it is a single most important preventable risk factor.
Correct.
You
Even
just
for
eliminate
kidneys,
and your
even
risk
for
factor is
kidneys,
gone.
because you get so much peripheral vascular disease, renal artery stenosis, infarcts. So atherosclerotic embolic diseases you get.
And the definition of the smoking is given so much importance. The definition of smoking in our characterization of demography, it is that if you have ever smoked a single cigarette in last 30 days, you're a smoker.
Yes. Yes.
Dr. Manas, your points, your comments on any other?
No, sir, that's all. I don't. Okay.
Yeah. So I think I don't see any questions. It was wonderful deliberation by a learned speaker, and thank you, Dr. Anita and organizer, for inviting me, and thank you all the speaker for deliberating wonderfully. Thank you, Dr. Manas, for sharing with my responsibility. Thank you all. So I may take
Dr.
this.
Sudeep, before we move on to the next session, which is the last session, we've had two bad news. The Dr. Sanjeev, OP Sanjeev is also admitted in the COVID hospital now. So Dr. Manas and Dr. Sudeep, can I ask you to continue as moderators for the next session also? It's on acute kidney injury and the ICU setting. So can you please continue as?
Ma'am, I have to take leave because
you have to take leave. So Manas, can you continue as a moderator?
Yes, ma'am. Yes, ma'am. Can.
Oh, so you continue as a moderator. So basically, you're right. Okay, now we move on to session 5, which is the last session of the day. This is on critical care, that is acute kidney injury. And for this, I invite Dr. Manas Ranjan Patel to moderate this session. You've just been hearing him. He's associate professor with us in the Department of Nephrology, SGPGI. And over to Dr. Manas. And Dr. Manas, I'd like to inform you that Dr. R.K. Singh has also got stuck up. His second lecture was on refeeding syndrome. So I have just picked up some slides from my previous lecture, and I'll fill in the gap for him.
Okay, ma'am. Okay. Thank you, ma'am. We'll start basically nutritional management of AKI. We discuss this in two parts. One is like acute kidney injury, proper non-critical patients, and one is acute kidney injury with in critical care patients, those who have requirement of renal replacement therapy or ventilation, those who are sicker with other comorbidities, maybe infections or sepsis. I will like to invite Dr. Rimita De. He is a critical care consultant in Peerless Hospitex, Kolkata. So Rimita, please, you can start your presentation.
Dr. De, please unmute yourself.
Yeah. Am I audible now?
Yes, ma'am. You are audible. Please share your screen and on your video.
Yeah. So good afternoon, everybody. So I'll start with my topic of nutritional guidelines in acute kidney injury. Okay. So I've just started to share my screen. Well, there I am. Yeah. So I'll just be starting my talk on the guidelines for nutritional support in acute kidney injury. As has been rightly pointed out, that AKI in ICU setup is different from CKD because AKI in AKI patient have a significant protein catabolism. There are phenomena of insulin resistance, so there is abnormal carbohydrate metabolism and an altered fat metabolism. AKI patients may be on continuous renal replacement therapy, CRRT, or intermittent hemodialysis, and that is why they are at a greater risk of protein and micronutrient losses. So the primary goals of nutrition management of AKI are to attenuate protein catabolism and to replace micronutrient losses while being mindful of the potential harmful effects of the excessive vitamins. So for that, we need to have a good understanding of the classification of the patients with AKI, in which class they belong to, the types of RRT used in the management of these patients, and the specialized micronutrient and the macronutrient requirements, appropriate fluid management, which is the mainstay of the AKI, I would say. And so these understanding helps us to calculate the appropriate dietary management of the critically ill AKI patients. So what is an AKI? Well, the session might have discussed, but then you see, in literature, I could find about over 35 different definitions of AKI. But what I understand, that AKI is an abrupt and a sustained reduction in kidney function, which is commonly defined as an increase in serum creatinine by 50% within the 7 days, or an increase in the serum creatinine by 0.3 within 2 days, or oliguria. AKI may be due to isolated renal dysfunction or may be a complication of the severe illness. For the staging of AKI, we are aware about different classifications. We are aware about the foremost rifle classification, which identifies AKI in 5 different classes from stage 1 to stage 5. So stage 1 is the risk. We know there are definite categories depending on the creatinine and GFR, where we diagnose them as at a risk of renal injury. Second is the stage 2 or injury. So risk, injury. The stage 3 is failure, which is similar to what I discussed in the definition, that is an increase in the serum creatinine to more than 3 times of what it was baseline, or more than 4 milligram per deciliter with an acute rise of 0.5 milligram, and the urine output is less than 0.3 ml per kg per hour for 24 hours, or anuria for more than 12 hours. Stage 4 is the loss of persistent acute renal failure and equals complete loss of kidney function, and stage 5 is ESRD, we know. You see, these classifications are used in different clinical categories, and now more often the ACIN or the KDIGO system is used to define an AKI, which is again similar with some of the differences in the increase from the baseline that we calculate. So this is an ACIN system. ACIN system is again divided into 3: stage 1, stage 2, and stage 3. And depending on that, we plan up how to manage our AKI in the acute care setting or in the critical care setting. In terms of nutrition, you see, I found a study by Valencia et al. Who have classified AKI in 3 different groups. And in group 1, the group 1 consists of patients without excess catabolism and a urea nitrogen of 6 gram or less nitrogen than the nitrogen intake per day. So this group 1 is mainly caused by nephrotoxins or the contrast media, and in most cases these patients are fed enterally, and the prognosis for renal function recovery and survival is excellent. Group 2 is a more severe one where the catabolism is more, so urinary nitrogen appearance of 6 to 12 gram, loss more than the nitrogen intake per day. So this group of patients frequently has complicating infections, peritonitis, in association with AKI, and they require either enteral or a total parenteral nutrition and usually dialysis and hemofiltration. Group 3 are the sickest of the group where the UNA is more than 12 gram. So the balance is negative in more than 12 gram. And this group of patients frequently has severe trauma, burns, overwhelming infection. And the treatment strategies are usually complex and include parenteral nutrition, hemofiltration, as well as blood pressure and the ventilatory support. Obviously, mortality is more in group 3 and the patients are very much catabolic in group 3. Now, what kinds of dialysis do we use in intensive care? Because this is also important in planning for the nutritional loss or the nutritional supplement they are due to receive. There are mainly three types of renal replacement therapy that we now cater our patients. Peritoneal dialysis less commonly used, hemodialysis more commonly used in most of the ICUs. Hemodialysis again can be two. It can be intermittent hemodialysis, which is performed every second day for 4 to 6 hours, or a SLED or sustained low efficiency dialysis, which is performed for 8 to 12 hours. And the third is CRRT, which is administered continuously, which again can be of two types, that is CVVH or CVVHDF. So there can be hemodiafiltration or just continuous venous filtration. So depending on these modes and depending on the type of patients, probably the nutritional demands are calculated. So what are the goals of nutritional support? That is to prevent protein energy wasting, to preserve lean body mass and nutritional status, to avoid further metabolic derangement, to avoid complications, to improve wound healing, to support immune function, to minimize inflammation, to improve antioxidant activity, to improve endothelial function, and to prevent mortality. So that is the target which we are moving to produce a good nutritional support to our patients. So starting on how do we do it? What are the energy requirements? You see, internationally, the recommended guidelines are the same that are for the patients in AKI as is used in patients with non-AKI in intensive care. It is 25 to 35 kilocalorie per kg per day. These are the ESPEN guidelines, which are used for almost all ICU patients, whether they have an AKI or they do not. What are the protein requirements? You see in ICU, when we know that the total, you see in ICU, actually the total body protein synthesis is increased by 15 to 37%. However, protein breakdown is also increased by 41 to 79%, resulting in protein catabolism. What is the pathogenesis of protein catabolism? There are multiple factors. First is an inadequate supply of nutrients. There are uremic toxins. There are endocrine factors, a defective response to insulin, the increased secretion of catabolic hormones like glucagon, catecholamines, glucocorticoids. There is resistance to and suppression of growth and anabolic factors. Acute phase response or systemic inflammatory response. So cytokines are there which causes protein catabolism. Metabolic acidosis, loss of nutritional substrates during RRT. It is assumed that approximately 0.2 gram amino acid is lost per liter of filtrate in CRRT, resulting in a total loss of around 10 to 15 gram amino acid of protein per day. An additional 5 to 10 gram of protein is lost per day depending on the type of therapy and the dialyzer membrane that is being used. So proteins become a very important prerequisite to meet up in the critically ill patients. So the optimum protein requirement for intermittent hemodialysis is actually 1.2 to 1.5 gram per kg of the ideal body weight. And the optimum protein requirement for CRRT is higher, around 1.7 gram per kg per day. Increasingly, the international literature is now moving for a protein of around 2 gram per kg per day in AKI in ICU. So that up to that can be the demand for a hypercatabolic patient. Now, assessment is based is usually based on the creatinine clearance, and this is the formula of assessment where the UNA of 5 to 10 gram per day suggests a moderate catabolism, while the UNA of greater than 10 suggests a severe catabolism. But there is a practical limiting factor in calculating the UNA, that it requires a pre and post dialysis body weight, which can be difficult to get in an ICU patient, because in most of our ICU we do not have weight measuring beds. So that is what is important. So that can be a practical limitation in calculating the UNA, but UNA can be a method of ascertaining the adequacy of protein supplementation in intensive care. Coming to the individual substrates, what are the carbohydrate requirements? Theoretical estimation is a maximum oxidation rate of glucose around 4.4 to 7 milligram per kg per minute. That makes around 400 to 700 grams per day for a 70 kg patients. To meet up the requirements of the brain, the minimum daily requirement is estimated to be about 100 to 120 grams. So carbohydrate in the form of citrate, glucose, lactate from intravenous fluids, as well as from the dialysate and hemofiltration solutions, also needs to be considered with regard to the total carbohydrate and energy intake to ensure a normal glycemia. Avoiding hyperglycemia is also a task that needs to be done in ICU. Patients with AKI are more prone to have exacerbated insulin resistance on one hand. On the other hand, around 30% of insulin catabolism occurs in the kidney, right? So in AKI, that may be hampered. The sugar control becomes really worrisome in the intensive care patients, while the target needs, we should be adhering to the principles to meet up the targets, because it has been shown that hyperglycemia actually has worse outcomes, and even hypoglycemia can be associated with worse outcomes. So normoglycemia is a target. A sugar value of around 180 to 200 as of the guidelines has recommended. Very strict control of the sugar can lead to worse outcomes. But definitely stress hyperglycemia needs management as well. Fat requirements. AKI patients are prone to elevated plasma triglyceride and elevated LDL levels, as well as decreased level of HDL. Impaired lipolysis is the most important cause of plasma exchange in AKI, as both peripheral lipoprotein lipase and hepatic triglycerides are reduced by approximately 50%. And lipoprotein lipase activity is further inhibited if acidosis coexists in patients with AKI. So ideally, 30 to 35% of the total energy should be provided in the form of fat. A furthermore specific suggested dose of fat has been recommended to be 0.1 to 0.2 gram per kilogram of ideal body weight, but it is important to monitor the serum triglyceride level, because that may go high in the presence of an AKI. What about micronutrients? Well, micronutrients we need to be very cautious about the micronutrients administration in ICU, because a lot of the patients will have deficiencies of micronutrients, whereas others may be harmful as well, like vitamin C and retinol. What about vitamin C? Vitamin C, we know, is converted to oxalate, a renal toxin in renal failure, and oxalate is not adequately removed by CRRT. It accumulates in the renal tubules and exacerbates existing AKI and potentially limits renal recovery. Hence, it is paramount to limit vitamin C to 100 milligram in intermittent dialysis and 100 to 200 milligram for CRRT. This I would like to specifically mention because vitamin C is now very commonly used, according to a study where it was shows that vitamin C, thiamine and corticosteroids given in conjunction may improve mortality. So after that, vitamin C usage in ICU has been increased, but then we should take the factor into account whether the patient has an AKI or not, or whether we are supplementing the patients with more of vitamin C. Folic acid, approximately 265 microgram of folic acid per day is lost in the ultrafiltrate during CRRT, so some amount of replenishment is required. Thiamine and selenium, there are losses of thiamine and selenium as well. So supplementation of 25 to 100 milligram of thiamine is prudent, and selenium, some 100 micrograms per day is recommended in AKI for CRRT. Vitamin D, again, I think the vitamin of the era, vitamin D. So vitamin D has been reported to be significantly associated with an increase in AKI, but there is risk of supplementation even. So what is the optimal vitamin D supplementation has yet not been established, and further research is required to establish that supplementation really improves outcome in critically ill patients, right? Vitamin A, we know it can cause toxicity due to increased plasma retinol levels in AKI patients. Phosphorus, incidence of hypophosphatemia is prevalent in ICU patients and can be further aggravated by prolonged RRT. Severe hypophosphatemia has been associated with respiratory muscle weakness and phosphorus depletion, ventilatory failure, myocardial dysfunction, and encephalopathy. Copper again is required, but it should be withheld if the serum bilirubin is greater than 3. Some amount of zinc is also required, and it forms the standard nutritional supplement. It is a part of the standard nutritional supplement in the AKI. Fluid management, I think this is the cornerstone for every ICU patient. Kidneys usually receive a 25% of the total cardiac output and hence are very sensitive to hypoperfusion and hypovolemia. But fluid overload is also associated with an increased risk of death. I mean, debate will exist and continues to exist since the inception of my career in intensive care about the optimum or what is the optimum fluid in a critically ill patient, but that depends on clinical discretion and certain indirect parameters like IVC assessments and things like that. In total, we can really assess which patients may require what amount of fluids, but trends demonstrate improved outcomes with more stringent maintenance of fluid intake and output on daily balances, and the management of critically ill is a dynamic process and requires frequent assessment and adjustment to fluid volumes. Synthetic colloids we are avoiding in ICU now because they can exacerbate AKI, we know. The literature is abundant on that. Regarding the route of feeding, it is enteral. Always we say that. But then it may be difficult in a patients who are critically ill because they may not be willing to take. Then we need to initiate them on tube feeding. Sometimes tube feeding may be difficult to continue. Only in those situations when patients are not tolerating enteral feed, a parenteral or a supplementary parenteral nutrition can be provided to the patients. So that is all in my deliberation of nutrition in acute kidney injury. I would now be open to the questions.
Thank you, ma'am. Only thing, one question I would like to ask is, what the composition of means like what type of protein, which type of carbohydrate, which type of lipids has to be supplemented. So obviously their calorie values has to be calculated, and their obviously their that is okay, but what kinds of protein and what kinds of carbohydrates and lipids has to be supplemented, that I wanted to just ask.
Yes. Yeah, I'll take the question. We do not depend on the kitchen feeds as of now because we used standard nutrition formula provided, and the I thought I would include, but did not find it appropriate in this setup. That standard enteral nutrition formula provided by the standard companies do provide adequate amount of protein and the lipids and the essential amino acids required. So I ask my dietitians to prescribe depending on the fluid volume, the kind of nutritional formula to supplement their nutrition need.
Okay, ma'am. Like.
Yeah. So Dr. Manas,
So
the next one.
And any other speaker we have, ma'am? Or
yeah, I'll be taking up. I'll take up the second one. That is refeeding syndrome, because I just have DACA, because I don't want this session to be incomplete. So whatever I have been able to collect the slides.
Okay, ma'am. We can start the.
Yeah, I can share the screen. Okay, right. So hello everyone. Once again, I'm chipping in and I'm like filling the blank, because Dr. RK, first of all, Dr. Afzal was supposed to take this talk. He came down with COVID, and then Dr. and I passed on the topic to Dr. R.K. Singh, and he is stuck up in the hospital. I mean, he doesn't even know where he is. So it's just last minute that I came to know, and so I'm going to talk about refeeding syndrome, which is quite a nice. It's very interesting topic, and it's actually one of my favorite topics. And I'll have simplified it because I wasn't really knowing that I will have to present this case. So this is a case that I presented about 2 years ago in JIPMER. On to the case now. Well, this is a 53-year-old male who underwent pancreatoid duodenectomy for chronic pancreatitis. 2 months after the surgery, the symptoms of severe malnutrition caused by nutrition digestive disorders developed. The patient was admitted to hospital with symptoms of severe malnutrition and general poor medical condition. The patient was put on TPN, total parenteral nutrition, after the preliminary treatment of water electrolyte imbalance. But after 3 days of TPN, a severe hypophosphatemia occurred with serum levels as low as 0.25 mmol per liter. So this wasn't a very good scene here. So let's go and have a look at the historical background of feeding again after a period of starvation. What does it mean? Okay, right. Burgers first described it in 1948 in World War II era, when prisoners who had undergone starvation developed cardiac failure and peripheral edema on nutritional replenishment. In Leningrad and the Netherlands, cases of cardiac insufficiency and edema were reported after refeeding survivors of the war who were starved because of scant food supplies. And this is what you see in marasmus and kwashiorkor also. Now, reports of hypophosphatemic hyperalimentation syndrome soon followed in 1970s. And in 1980s, Silvis and colleagues noted paresthesia, seizures, or coma in conjunction with hyperphosphatemia in patients receiving parenteral nutrition. The incidence of hyperphosphatemia is about 34 to 52% in ICU. Now, hyperphosphatemia is a hallmark of refeeding syndrome. Other metabolic abnormalities such as hypokalemia and hypomagnesemia may also occur along with sodium and fluid restriction. Metabolic changes that occur in refeeding syndrome can be severe enough to cause cardiorespiratory failure and death. So that's the reason I'm always worried about, when the patient comes out of great illness and is not been eating well, and the first thing that comes to mind is feed him as much as possible, only to that extent that he doesn't get into refeeding syndrome, because refeeding syndrome is fatal, and you can lose the patient with this. So this syndrome emerges with aggressive oral nutrition, enteral nutrition, or parenteral nutrition. Now, what is the pathophysiology of starvation? Now, body tries to compensate for the lack of energy by means of changes in metabolism and hormone regulation. The body goes into a state of catabolism. A shift from carbohydrate metabolism to fat and protein catabolism occurs, which provides glucose and ketones for energy. This shift to protein catabolism results in a loss of lean body mass, which affects major organs such as the heart, the lungs, liver, kidneys, and intestines. Now, atrophy of myocardium results in poor contractility and diminished cardiac output. Liver wasting results in decreased protein synthesis and further alterations in metabolism. Gastrointestinal atrophy causes malabsorption and dysmotility, further exacerbating the malnourished state and increases the risk of infection. The kidneys also lose the ability to concentrate urine, resulting in diuresis. Now, cellular mass is lost, contributing to functional loss of vital organs. Intercellular loss of potassium, magnesium, and phosphate occurs. Insulin secretion decreases, and the basal metabolic rate slows down to 20 to 25% to conserve energy. Now, consequently, the body becomes bradycardic, hypothermic, and hypotensive. Growth hormone and thyroid hormone also decrease. So the whole scenario is reduction of everything. Now, once nutrition is reintroduced to a patient who has been starved for an extended period, anabolism begins instantaneously. The body shifts back to carbohydrate metabolism from protein and fat catabolism, and glucose becomes a primary source of energy once again. The increased glucose load with a corresponding increase in the release of insulin leads to cellular uptake of glucose, potassium, magnesium, and phosphate. And this shift of electrolytes back into the cell causes hypokalemia, hypomagnesemia, and hypophosphatemia. So insulin also exhibits a natriuretic effect on the kidneys. Hence, sodium is retained, causing fluid retention and expansion of the extracellular fluid volume. Anabolism's high requirement causes further deficiencies, which may lead to life-threatening circumstances. Now, rapid correction of undernutrition causes fluid shifts and intravascular volume overload, which precipitates congestive heart failure in the undernourished patient with myocardial atrophy. So this is the sequence of refeeding syndrome: malnutrition, starvation, then you start nutritional replacement, and then refeeding syndrome happens. Now, what is the definition of refeeding syndrome? There is actually no universally accepted definition. Refeeding syndrome is defined as severe and potentially fatal electrolyte and fluid shifts associated with metabolic abnormalities in malnourished patients undergoing refeeding, whether orally, enterally, or parenterally. This definition is imprecise and lacks definitive electrolyte thresholds values to confidently diagnose the refeeding syndrome. Now, because I'm talking about a patient who became hypophosphatemic on being given total parenteral nutrition, so the classification of hypophosphatemia is important here in this case. So serum phosphate levels or phosphorus normally ranges from 2.5 to 4.5 milligrams per deciliter in adults. So mild hypophosphatemia is when the phosphate levels are between 2 to 2.5 milligrams per deciliter. Moderate is when the levels are between 1 to 2 milligrams per deciliter. And severe hypophosphatemia is when the levels are less than 1 milligrams per deciliter. That is what happened to this patient. Now, hyperphosphatemia is a characteristic feature of refeeding syndrome. During the fasting state, catabolism results in depletion of intracellular phosphates. Rapid introduction of carbohydrates into the body inhibits fat metabolism and favors glucose metabolism. This causes an insulin surge, promoting cellular uptake and use of glucose and phosphates. High demand of the production of phosphorylated intermediates of glycolysis happens, and this leads to all this, and eventually this causes an insulin surge, promoting cellular uptake and use of glucose and phosphates. And then combination of depletion of total body phosphorus stores during catabolic starvation, along with increased cellular influx of phosphorus during anabolic refeeding, leads to severe extracellular hypophosphatemia. So refeeding hypophosphatemia can occur within 24 to 72 hours of introducing nutrition. So I've already spoken about the pathophysiology. Now, what are the risk factors for refeeding syndrome? Prolonged fasting of more than 5 days, low BMI, kwashiorkor or marasmus, anorexia nervosa, chronic malnutrition from carcinoma or in the elderly, chronic alcoholism, prolonged fasting, duodenal switch, operation for obesity, hunger strikers, oncology patients, and post-operative patients. Now, if you have a look at this table is showing you what are who are the patients who are at risk of developing refeeding syndrome. This is a nice 2006 criteria. And this first column on the left is saying if you have more than one or more of the following criteria present, that is BMI less than 16 kilograms per meter square, unintentional weight loss of more than 15% within the last 3 to 6 months, little or no nutritional intake for more than 10 days, or low levels of potassium, phosphate, or magnesium prior to feeding. Now, the second column says if 2 or more of the following criteria are present, the patient is at the risk of developing refeeding syndrome. That is BMI less than 18.5 kilograms per meter square, unintentional weight loss of more than 10% within the last 3 to 6 months, little or no nutritional intake for more than 6 days, and history of alcohol abuse or drugs, including chemotherapy. So patients who are at risk of developing refeeding syndrome, one has to start nutrition support at less than 10 kilocalories per kg body weight per day, and increase the level slowly to meet full requirement by day 4 to 7. Avoid overfeeding patients with raised or increasing inotropic requirement. Now, thiamine deficiency must be treated. Thiamine is an important cofactor for enzymes needed in carbohydrate metabolism, and it is rapidly consumed in glycolysis during refeeding. Deficiency can occur in less than 28 days because its half-life is 9.5 to 18.5 days. So lower levels of thiamine impair glucose metabolism and result in lactic acidosis. Hypomagnesemia blocks synthesis of active form of thiamine. So epidemiology has shown that, well, there is a high risk of mortality with hypophosphatemia. So the clinical manifestation of phosphate deficiency are arrhythmia, hypertension, cardiomyopathy, then RTA, metabolic acidosis, rhabdomyolysis, weakness, myalgia, diaphragm weakness or delirium, coma, seizures, tetany, hyperglycemia, insulin resistance, osteomalacia, then hemolysis, thrombocytopenia, leukocyte dysfunction. As far as potassium is concerned, if it is low, it can cause hypertension, ventricular arrhythmias, cardiac arrest, bradycardia. Respiratory symptoms would be hypoventilation, respiratory distress, respiratory failure. Then skeletal would be weakness, fatigue, muscle twitching, and the diarrhea, nausea, vomiting, anorexia, ileus, constipation, metabolic would be the gastrointestinal criteria or symptoms, and metabolic alkalosis can occur. Then as far as hypomagnesemia is concerned, when one can have paroxysmal atrial or ventricular arrhythmia, repolarization, and hyperventilation, respiratory distress, respiratory failure, weakness, fatigue, muscle cramps, the Trousseau sign, weakness, ataxia, vertigo, paresthesia, hallucinations, depression, convulsions, abdominal pain, diarrhea, vomiting, loss of appetite and constipation, and anemia and hypocalcemia. And low sodium would be like heart failure, arrhythmias, respiratory failure, pulmonary edema, renal failure, then muscle cramps, fatigue, fluid retention if it is high, and swelling and edema. So these are all the causes of if the sodium levels are really high. And vitamins include the Wernicke syndrome, then congestive heart failure, and lactic acidosis, beriberi disease, skeletal and muscle weakness. So these are the deficiencies if thiamine deficiency is there. So these symptoms would appear. So the treatment strategy would be electrolyte supplementation, that is phosphate, magnesium, and potassium supplementation, glucose monitoring to prevent hypoglycemia and hyperglycemia, intravenous insulin administration in case of hyperglycemia, correction of fluid balance, thiamine supplementation at a minimum dose of 300 milligrams initially, followed by 100 milligrams daily for at least 7 to 10 days. Now, restriction of total calorie intake to a maximum of 500 kilocalories per 24 hours during the first 48 hours is recommended, because you just can't pump in a lot of calories to these patients. Consider the amount of non-nutritional calories from propofol, citrate, and intravenous carbohydrate solutions, as they may increase the total calorie load. Gradually advance feeding after 48 hours of calorie restrictions in daily steps of 25% of the target until the nutrition target is reached, and start with 7 kilocalories per kg body weight per day of energy, and increase it to the goal that is achievable by 7 days. So initially I said less than 10 kilocalories, and in fact it is actually one should start with 7 kilocalories. Now, oral phosphates are present in the market, and we have phos available, and sachets of oral phosphate. They contain 16.1 mmol of phosphates, and of course all these things require calcium, aluminium, magnesium salts should be avoided, and monitor phosphate whenever you are supplementing phosphorus on a daily basis. So for this patient, the ideal thing would be to put him on trophic feeding, that is enteral nutrition initiated at 10 ml per hour, that is 10 kilocalories per hour, along with the omega-3 fatty acids. These are really good during this time. And then we can build the patient up along with the gastric residual volume being checked every 12 hours during trophic feedings. And trophic feeding enteral nutrition was, you can advance it to full energy feeding later on, but it should be developed gradually. And blood glucose and insulin, blood glucose control with insulin therapy should be done. So the key to prevention is identifying patients at risk and being aware of the potential complications involved in rapidly introducing feeds to malnourished patients. Thank you for your attention.
Thank you, ma'am. Thank you for a nice outline of refeeding syndrome. I think means in our practice, in chronic kidney disease practice, we seldom see refeeding syndrome, probably because we are not very aggressive with feeding, I think, which is a wrong practice. So
See, Dr. Manas, in our ICU patients who've been very underfed, I mean, been starving, been off food for 5 or more than 10 days, they are at risk of refeeding syndrome. And, that is a point when we should be seeing the phosphate levels, the potassium levels. If phosphate and potassium and magnesium levels are low right at the beginning of when you're starting the treatment, then this is a criteria to diagnose that this patient is at, at risk of developing refeeding syndrome. So that is the time when we have to be very careful. If you have the history from the family that the patient's not been eating for more than 5 days or 10 days, then these 3 criteria would be able to help us in, picking up whether the patient is at risk of developing refeeding syndrome or not.
Yes, ma'am. Any more questions? We can wait for any questions, ma'am. Or probably.
Yeah, I have a question for Dr. Rimita. Is she there?
I think she has left, ma'am.
Oh, she's left. I just wanted to talk about peptide formulas for our patients. Peptide-based formulas, yeah. Because they are very good for such patients in the ICU setting when the patient is really having a lot of problems, not being able to, recover his muscle mass and all those things. So, and he's having problems getting out of the ventilator. So I think these formulas are really very helpful. So if there are no more questions,
yes, ma'am. Can we close the session, ma'am?
Yeah, we can surely.
Oh yes. Thank you very much, ma'am. And I think it is in conclusion of today's academic program. So thank you all participants and speakers for deliberating a nice talk. So
thank you, Dr. Manas, for moderating 2 sessions. And, you were our lifesaver for this session. Suddenly things have gone wrong because of the COVID. And that's the reason I said, no, at least people should know, because a lot of delegates are there who would want to know about refeeding syndrome. So I said, I'll just give a brief outline of refeeding syndrome. So tomorrow we're going to wind up the session for today. And tomorrow we start at 9 a.m. And so till then, have a nice evening. Bye-bye.